Hello, hello.
Welcome to Balco Medical Center, Central India's premier cancer hospital. Established in 2018, BMC is a 170-bed, state-of-the-art comprehensive oncology facility in Naya Raipur, Chhattisgarh. As the first flagship initiative of the Vedanta Medical Research Foundation, this NABH-accredited institute specializes in treating all types of cancer. BMC surgeons are at the forefront of cancer care with complex microvascular reconstructions, 3D printing technology, and minimally invasive surgeries.
Good morning, everyone.
With more than 60 specialist doctors, each patient's treatment plan is carefully crafted through discussions in the multidisciplinary tumor board. Situated in a serene, sunlit environment, Balco Medical Center is home to Central India's largest chemotherapy daycare. Equipped with cutting-edge linear accelerators and innovative radiotherapies, the center ensures every patient receives the highest level of care. This precision extends to nuclear medicine with advanced PET and SPECT scans, detecting cancer at the molecular level. As the region's leading bone marrow transplantation center, BMC performs the highest number of transplants and now offers CAR-T cell therapy with real-time frozen section analysis, in-house immunohistochemistry, and the first in-house flow cytometry in Chhattisgarh. Balco Medical Center's NABL-accredited laboratory services form the backbone of accurate cancer diagnosis. The ultra-modern blood center operates 24/7, ensuring the availability of blood components with zero wastage, providing a holistic approach to cancer care. The hospital treats patients under various government schemes, along with offering subsidized accommodation, complimentary transportation, and protein-rich diets, making quality treatment both affordable and accessible. Outreach programs through the mobile cancer detection van bring early diagnosis and care to the remotest communities. Located in the heart of Raipur, the BMC Cancer Daycare offers a calming environment for chemotherapy patients with its thematically designed facility.
We are a comprehensive cancer center in central India which provides all cancer services under one roof, which is very unique to this part of the world, to deliver on service, research and education, which are the three pillars needed to provide the best care for every single patient. We are tying up with like-minded organizations and institutes nationally and internationally. Staying true to BMC's vision, we have a team of 600 people who are working towards delivering affordable, accessible and quality care to every single patient who walks in through the doors of BMC.
It's such a pleasure to be here with so many inspiring women. So this morning,
Welcome to Balco Medical Center, Central India's premier cancer hospital. Established in 2018, BMC is a 170-bed, state-of-the-art comprehensive oncology facility in Naya Raipur, Chhattisgarh. As the first flagship initiative of the Vedanta Medical Research Foundation, this NABH-accredited institute specializes in treating all types of cancer. BMC surgeons are at the forefront of cancer care with complex microvascular reconstructions.
Sharing action points. So I welcome Dr. Seema Gulia and Dr. Shona Nag to give us a welcome and for context sharing.
Vanita, and a very warm welcome to all the wonderful ladies who are sitting there. So we have seen recently that particularly in India, more and more women are choosing oncology as their career option. This field demands not only the medical expertise, but also deep reserves of empathy and resilience. Behind the rise in statistics of growing participation in this field, there lies a more complex reality. The journey of a woman oncologist is often shaped by the constant balancing act between the profession and the personal responsibilities. It is the expectation at home as well as the demands at the work that needs to be balanced upon. Many women oncologists, they need to spend long hours in the clinic and hospital, and they stretch late into the nights, followed by the equal relentless care that is to be given at home as a mother, as a daughter, as a spouse. Career advancement often comes at its own hurdles. Fewer leadership opportunities, subtle yet persistent gender bias that we all face. There are limited access to the mentorship opportunities as well as professional networking. At the same time, oncology itself is emotionally draining. We need to spend long times with the patient and their families throughout the most difficult time. Yet, despite these challenges, women oncologists in India have continued to bring a unique strength to their work, combining clinical skills with compassion, perseverance, and the determination. There are a few examples in front of us, like Dr. Geeta, recently in Delhi, she inaugurated the standalone women cancer hospital, which is called as Athena Apollo. Dr. Shona Nag, who is the director of the Balco Cancer Hospital, she is the beacon of hope for the patient in this region. We have Dr. Shona Nag, who is the director of Sayadri Group of Hospital, and she is being a passionate teacher. I still remember the days when she used to travel on weekends to teach us and empower us with her own knowledge. Their stories highlight not just the obstacle they face, but also the resilience with which they overcome them. So there is a need to create an ecosystem where we support each other, we empower each other. So ladies, we have to walk into the room we have never been, and we have to chase our dreams. So Nari hi Shakti hai, Nari hi Abhiyan hai. With this, I would now like to invite Dr. Neeta Nair to set the stage. Thank you so much.
Thank you, Seema. So Susanna and I have discussed how we'd like to take this forward, and we're just going to talk to you about some of our journeys and some of our stories. She's going to take you through her journey as a medical oncologist and as a woman in medical oncology with a family that she's got a crazy family at home, crazy family at work, and how you can balance that together. And then we'd like to open it out to everybody to share their experiences and concerns and how we can take this forward without looking at the negative side. And an example I'll give you is actually on the flight here, I ended up watching a movie which I've been planning to watch for a while, which is called 6888. And if you haven't seen it, I sort of implore you to watch that. It's on Netflix. It's about the first African-American war cantonment in the army, which obviously, because they were a minority, being African-American and women, got treated badly. And they were always undermined for their intelligence, their ability to do anything. And they were given the task of getting maybe 1,700 letters, which had just gotten lost during wartime, during World War II, of sort of settling all of that, getting it all in place and getting it to the right people. And the fact that these are women who were extremely intelligent, some of them were triple majors in physics and mathematics, some of them were professors in their field, and how they all came together and put their mind to it. Because the idea is you're going to come across obstacles. We are a minority. Look at the room, right? We're all the oncologists in GI and I think bone soft tissue, if I'm not wrong, that are in the space, and we're the minority in the space. And that is a reality, because practicing female clinicians are not as many as those who start out. And that's because of the hurdles we come across while going through life and practice together. You have to find what ticks for you. You have to find what works for you and the balance that works for you. I think we all dance to a different tune. We each have a different story, and I don't think comparisons make sense, but I think at the same time, we also need to find support among us. And an example I'll give you is my own story, where my mentor is not a surgeon. the person who has taught me oncology, who has guided me through my entire career, who has made me the oncologist I am today, and I'm a surgical oncologist, is a medical oncologist. And I look up to him and I revere him greatly because of that. I am the oncologist that I am today because of a man who is a medical oncologist. So I don't think it's about finding mentorship which is just women. I think it's about finding someone you respect, taking the effort to go up to that person and ask to be led or to be taught. And I'm telling you, most people are willing to teach. It's about how ready you are to go and ask for help. You have to strike a balance for what works. Very recently, we've had a lot of young girls who backed off from the amount of clinical work they do, wanting a work-life balance. And I think you understand what works for you. I worked in an institution for 18 years. It was my life. I don't think I went home more than 5 hours a day where I went to sleep. That's what I enjoyed at that time. And I'm going to make Vanita talk to you about her story, just to understand that what happens is you do what works for you. And you do it well. You at the same time understand that you cannot expect somebody else to handle your weight and to support you and expect that it's normal just because you have responsibilities. We each have a different set of responsibilities. We each have a different set of reasons that we want to grow or not. And I made a personal choice in 2000 because of a loss in the family to take a step back and want more free time. I do not beat myself about it. I made that choice. I went from treating 5,000 patients to maybe 50 a month, and I'm okay and I'm happy with what I do. But the difference is what I do well even now, and I work extremely hard with where I am, and I don't let the men in the room stand there and point that I'm not doing my bit. I think the way you have to move forward and the struggles that we all have as a minority population in the system is to be able to support each other, and I think that's what makes the difference. Women need to stand with each other. You need to find mentors, whether they're men, they're women, that work in uplifting your career and your growth. And you need to learn from other people's stories. And I think that's what we're going to hear from Dr. Stanway, and she's going to take that forward for us.
Is it possible to get them up? Thank you.
You have her slides, right? I think they confirmed, yes, yes. There they are. No, that's not it.
I don't know where you've put them. Thank you. Yeah, that looks like it might be it. There we go. That's it. Okay, thank you very much for inviting me to come and talk today. Thank you, Nita, thank you, Aparna, thank you, Pavna, for inviting me to this fabulous conference. I'm not used to giving this kind of talk. I hate talking about myself, and these are all put together a little bit last minute, so apologies in advance. I suppose my passion and my career has culminated in the nexus of health and peace, and that's where my interests currently lie. And I believe that the true measure of any society can be found in how it treats its most vulnerable members. So I just wanted to speak a little bit about my career path and just a few of my learnings along the way. I'm probably going to talk for about 10 minutes. So I acknowledge that I come from a position of privilege. I was very fortunate to go to an international school in the UK where I mixed with people from around the world, which I suppose ignited my interest in different cultures, different ways of thinking about things from an early age. And then I went to study at the University of Bristol. I think it's important to acknowledge that we're all going to have failures. My first career failure, I suppose, was the fact that I didn't get the elective that I wanted to get. After we have a medical school stint in the UK, we get to choose where we get some more experience in an international environment. My first choice was to go and study trauma in Durban, and I didn't get that, and I was really upset about it. But I think when one has failure, one has to pick oneself up, learn from it, and dust oneself off. I was then fortunate enough to go and work in a renal transplant unit for 6 months as a junior doctor in Christchurch in New Zealand. And I think that at this point it really ignited my interest in chronic disease and in non-communicable disease. And when I came back, I did my medical rotation at the Middlesex Hospital in the UK. I was then really fortunate enough to go for 8 weeks to go and study in the Solomon Islands in the South Pacific. And again, it was really fascinating to learn about how medicine was practiced in different parts of the world. And I think that that was my second learning point, is just be open to opportunities. I think serendipity is one thing, but I think being open to opportunities is probably more of a thing. I came back and I did my 3 years in a laboratory helping run a phase 1 trial of a breast cancer drug at Imperial College, which was a really fantastic experience. I think at this point, I just wanted to say that as a woman, I think that just as we've heard from Nita, the men in my career have often been my most staunch proponents. And, you know, particularly one of the senior GI oncologists at the Royal Marsden Hospital that many of us here know has probably been my most staunch proponent in my career and stood up. So I think whilst we have to stand up for each other as women, we also have to acknowledge that the men in our careers are going to be hugely important. I was fortunate enough to do my rotation at the Royal Marsden Hospital in the UK, where I then subsequently went on to practice as a consultant, and I now have an honorary position as a senior teaching fellow at the Institute of Cancer Research. It's not going forward. Right, there we go. I think at this point I started having children. I've now got 4 children, but at this point I had sort of gone back to work full time, having had my first child. I went back to work when she was 20 weeks old, worked full time, didn't see her at all during the week. And I think on reflection, it made me realise that you are completely replaceable at work, but you're not so replaceable to your family. For your children, you are all you have. You are their one mother. And whilst I do believe it takes a village to raise a child, and I'm very lucky that I have a wider family unit and friends who have helped me bring up my children, I do think it's important that we prioritise our family and friends. I also think it's important that we don't snub less than full-time working. And actually, after a year, and when I was pregnant with my second child, I went part-time. And that to me was really important because it enabled me to balance both. And I realised that I was in a fortunate position that I was able to do that, and that not everybody is. But for me, that worked. But at that time, which was almost 20 years ago, I didn't really have any people to look up to who were part-time. And I suppose I did feel less important and less successful than my male colleagues, all of whom were full-time and who were forging career paths at double the speed that I was. But I also think that life, it's a marathon, not a sprint. There's no rush to get anywhere. We all have long careers ahead of us. And, you know, many of us will have long life expectancies and will be working probably into our 60s, 70s, perhaps beyond. My father is in his 80s and is still working. So there isn't a rush, and I think we have to be mindful of that as well. And I also think it's important to remember that perfection is for the gods. And you don't have to be perfect. You can, I think at home sometimes just be good enough, and being a good enough mother is okay. I think it's also important that we advocate for better working conditions as women at work. You know, I remember going back to work, still breastfeeding my 20-week-old baby and having to run out in the middle of ward rounds and express milk in a loo, which felt sordid. And I'm really grateful that things like that are now changing for women, and I think that that's really important. I suppose my next learning point was create opportunities for yourself. At that point, I was a junior doctor, completely unimportant, but I think if you want to make change, throw yourself out there into a position of responsibility and recognise how you could find a platform to do what you want to do. So at that point in time, there was an opening for the oncology section lead at the Royal Society of Medicine, which I applied for and got. I think probably mainly because nobody else wanted to do it, but I think I saw it as an opportunity that you could then organise meetings about whatever you wanted to organise, and you would have a platform. And it was then really that we started to organise this annual day meeting around cancer control in low and middle income countries, which I felt really passionate about. I think my inflection point had been looking after a teenager at the Middlesex Hospital who had been brought from a sub-Saharan African country, and it pained me that she then went on to die as a teenager in London, not surrounded by any family members. And I think for me that was the inflection point that I wanted to work and collaborate with colleagues around global cancer equity and global cancer control, such that low and middle income countries had better access to cancer care and teenagers like her could receive treatment in her own country. So that day meeting that we organised at the Royal Society of Medicine has gone on to become London Global Cancer Week, which will run this year for the 7th year in a row, and is really a series of meetings over a week. This year we're liaising with about 90 entities, ranging from UN agencies to smaller NGOs, really cutting across the cancer continuum from prevention, diagnostics, treatment, palliative care, survivorship, and including many other cross-cutting domains such as workforce, climate change. And it's predominantly virtual meetings because we realise the difficulty that many colleagues in low and middle income countries have in having the financial capabilities to come to international meetings, and also the difficulties that we all find in getting visas to travel around the world. And yet in this world that we now live with digital technology, we can all communicate, collaborate virtually, and so that's mainly what London Global Cancer Week is about, and it's about creating this space where we can push global cancer care up the development agenda. So I think that that's it really. If something doesn't exist, try and make it happen, and we all have agency to do that. So my interest really has been focused around the global challenges that we face, whether they're sort of anthropogenic, which most of the global challenges now are, ranging from pandemics, conflict, earth systems governance, climate change, sustainability, artificial intelligence, and the effect that these have on ability to provide NCD care, of which cancer and heart disease are the most prevalent, and how other things interact with this, whether it's the demographic crises that many countries are facing, food, water, energy, security, market, rising global debt, raging inequality around the world, urbanisation, and all of these cross-cutting themes, and how really global leadership now is needed more than ever. So I think my next learning point was really just dance to the beat of your own drum. And if something gives you passion, that'll drive you. So I think one of the things that I realised having these kind of interests was that in order to interact with people that were going to have agency to make change and make a difference, one had to upskill oneself in policy, which we learn nothing about at medical school, and I suspect in nursing training and other interdisciplinary training programmes isn't part of the curriculum. So I think it's incumbent upon ourselves to go out and arm ourselves with training that we're not necessarily formally given. So reflect constantly and recognise what skills may be helpful to you and go out and get them. And in this age, there's many ways that you can do that in a free way that doesn't cost money. I also think it's important that we get involved in many different spheres. So as healthcare professionals, we are often involved in education, we conduct research, we're involved in capacity building, we interact with policymakers. It's important that we demonstrate allyship with colleagues around the world who may not be in fortunate positions that some of us may be in, that we convene, that we network, that we mentor those who are coming up below us, and that we advocate to reduce inequity, and that we engage with activism. This is an example of an MPO in the US that was set up by Joan Schiller, who is a lung oncologist, which is the only NPO in the world, we think, looking at the intersection of climate change and cancer. And I think that that's a real example of someone who's just started something from nothing. This is the UK and Ireland Global Cancer Network that Mark Lodge set up, that several of us are involved with, reaching out and collaborating with people around the world in a bi-directional way, learning from each other. And I think that it is important that we collaborate globally and that we learn from each other around the world. This is the annual China Anti-Cancer Summit. They've just launched the Holistic Integrative Oncology meeting, which looks at traditional medicines and holistic ways of treating cancer, and I think that we can all learn from each other in this way. This is engaging with colleagues in Africa. This is a 3-year programme that the Royal College of Physicians, funded by the East African Development Bank and the British Council, ran. And this is Train the Trainer courses that we collaboratively ran with people on the ground in Tanzania, Rwanda, Uganda, Kenya. And then recently working with colleagues in Somalia and in South Sudan as well to try and build capacity in these countries. And then building research, I think, is really, really important. This, one of these projects we ran in DRC, which was around palliative care, and I think that this happened during COVID, and it slightly fell apart because many things did during COVID, and I think that this is just always that things don't go smoothly. So I'm just going to skip over some of these slides and come to the end to give other people an opportunity to talk, but I just wanted to say, remember self-care outside work. We've got a session which is going to feature a little bit about burnout tomorrow. Remember to look after yourselves, the importance of exercise and taking time out to do things that inspire you and that develop you in other ways, and that sometimes outside interests can join with professional interests, such as this song that we released 2 years ago to raise awareness for people affected by cancer in areas of conflict, focusing on Sudan and Ukraine. Seek out your own mentors, just as none of us have one friend, we have many friends. We may have friends that we like reading books with, friends that we like walking with. Seek out mentors that satisfy or may be able to help you in different spheres of your career, and engage with international organisations. And don't forget to bring back your learnings, global learnings, back to your domestic situation as well. So that's really the main points that I wanted to say. Thank you for listening.
Thanks for those incredibly inspiring remarks, and would love to invite all the speakers to come back up and join us on the panel.
I invite Dr. Shona Nag to share her experiences with us. You're there on that, no?
She's just shocked. Putting you on the spot, but
hi everyone, I'm not prepared for this, but I don't know what to say, but I think we as women have a very complete life. I've enjoyed every minute of it, and I wouldn't change my struggle if I had to, because I think it builds character. Oncology was very nascent when I entered the field. I remember that after my MD medicine in Pune, I worked in an ICU for 2 to 3 years. Luckily, that hospital had the vision of starting a cancer center, and so the first radiation machine came to Pune. And they sent me to Tata Hospital to train. And unfortunately, my father had just passed away 15 days before that due to lung cancer. And he was being managed at Tata by Dr. Dinshaw. In those days, we didn't have a LINAC. So I remember she did the planning by drawing on his chest, and I was actually there when she did it. But he had metastatic disease, and he lived for a year after that. And that perhaps was the impetus for me to get into oncology. So when I first walked into Tata, all I could remember was him, and in 20 days I came running back because I hadn't addressed the grief properly, and I was the only child. So then Dr. Smriti took me under her wing, and for about 6 to 8 months, I worked under her in Bombay Hospital, and then went to Tata, approached Dr. Advani again. It took a lot of courage, and spent almost a year there, where I had the fortune of meeting people like Bhavna. And in those days, we had CMF, FAC, paclitaxel had not yet come in. It was very crazy days. And all I did was did rounds of the AML ward with a torch, looking at the mouth and the rectum, and there and then decided that hematology was not part of my armamentarium. And came back to INLAC, started a daycare unit. At that time, I had a baby. When she was 3 years old, decided I did not know enough in oncology, and a lot of our people had gone to Australia for a few weeks. So I applied as a registrar and luckily got in, and took my 3-year-old child, my mother-in-law, of course, screaming, and my poor husband made trips every 3 months. It was damn expensive. So 2 years later, she phones me up and says, enough is enough now, please come home. So that's when came back, and I didn't learn anything fantastically new in Australia, but I learned systems. And I learned how things can be done in an organized way, and how to respect the nurses and everybody who worked in the hospital. The daycare concept, we started the first daycare in Pune when I returned. So there were a lot of firsts, and that's when paclitaxel came into the picture. It was very exciting, and we were treating all our ovaries with this drug. And of course, then it's, the translational bug hit us, and we've not looked back in medical oncology since then. So I still have friends in Australia, and you really, I think that helped me a lot for confidence. And you know how we are, we Indians, we run through patients very fast. So their OPDs would be 15 or 20 in the clinic. And there were 4 or 5 of us for those 15 patients. And I would finish off in an hour, and they'd say, what happened? I said, OPD is finished. And they would like, oh, but we've seen 1 patient. I said, well, when you're back home, you kind of churn them out. So it's a different, completely different practice. And then I went on to have another child, and working back, we've all been through it, been back to work 6 weeks postpartum. Luckily, I had a flexible job, I had good bosses, and had the pleasure of setting up a cancer unit at Sahyadri from scratch. That's been the last 7 years. Publications, had super mentors, had friends like Sudeep, Seema, and Bhavna to see me through this whole thing, Aparna, Neeta. And then got into breast oncology, and only have been doing breast gynae for the last 5 years. So it's been difficult, but we built a good survivorship clinic, started the NAG Foundation, a way to give back, where we do research, education, hold the year-end review, do a survivors conference, and of course help patients with support groups. And we have a Herceptin fund as well, where we provide 3 to 6 months of anti-HER2. So it's been a terrific journey. I remember my registrar telling me once in Jahangir, ma'am, if you were a man, where would you be? And I looked at her and I said, exactly where I am today. I don't feel any different. Luckily, I've not had a problem with being one of the only female oncologists in Pune has helped, because women have a great comfort level. But I've never once felt, kind of exposed. And yes, when it comes to negotiating with salary, we are pretty useless. We are very bad. And we have, my husband being a businessman is forever looking at me in horror and saying, like, why did you do this free and why did you give this away? But it's made me happy. So Vedanta study has added a lot to my life. So I do religious study 4 times a week. I do an e-learning course, which is a very formal structure of the Bhagavad Gita and all our other things. So I'm part of an organization. I have a guru. And that has helped me ground myself a lot and keep a little distance from my patients. I think we do get too involved as women, so we need to keep that little distance. So that's my story. I mean,
Needs
and
to be balanced.
I hope, I mean, I was thinking of retiring and be a grandmom and do all the silly things that you know, women do, and watch serials and garden and all this. I seriously was thinking about it a year ago. Then I had Bhavna sitting on one side and Sudeep sitting on the other side. They looked at me and said, "Are you mad? You will drive everybody crazy. You will be miserable." And Sudeep says, you know, in my observation, people who retire early, they get dementia and they degenerate mentally. So when he told me this, I got so frightened because there's a lot of dementia around that I decided I need to keep working. So that's in short.
Seema, come on up.
So I'm actually going to say something just to continue what Shona said. Shona comes from a slightly different generation than I do, and we're very grateful for that because it's women like her, Bhavna, Vani madam for that matter, who paved a certain way for many of us where we didn't really struggle with that. By the time I entered oncology in Tata, Dr. Vani was already the female breast surgeon in the system and everybody knew her. And she was a force to reckon with, still is. So you're always going to have a different set of struggles, but we've had a bunch of ladies before us who paved a certain path, created a new normal, which is normal now to have women in oncology in senior leadership positions, and create a space where we just need to work and strive to get to. With the permission of the chair, I'm going to ask two specific people to stand up to tell us their journey, just because I know that they struggle with a slightly male-dominated system, one of which is Sanya. She's an HPV surgeon and a young HPV surgeon who's doing extremely well, and I think a lot of it has to do with the efforts to publish. If you publish, you get recognized, you'll get called, you'll get noticed for the efforts and the work that you do. And another person I want to invite is actually Mau, who's a surgical oncologist in a small town. And I'd like to hear both their stories and tell us what they've experienced and how they probably advise us to move forward.
Thank you, Neeta ma'am. And I think we've all stressed on the fact that we had women before us, but we've had great mentors.
Absolutely.
My mentor sitting right there looking back.
Correct.
If she's sitting there, I didn't know that.
Yeah.
So yeah, we've got great mentors who pushed us through, made us be able to do things which we thought were probably not feasible to work, collaborate with international colleagues, be there, stand there, talk. Because in the places that we work, we always question our own selves.
Yes.
As to whatever we're doing, and is it the right way, or in just smaller things. So to be able to get up on that front and to be able to talk and for people to recognize what you're doing is something that you strive at, you achieve at, because you want to be 110% all the time. You are fighting with your own self because you're trying to be much more than what you think is your baseline. Your baseline is 100. That's what we all try to achieve, and I think we should take forward from that because that's putting in a lot of stress. I think without that stress, we might do much better.
So I think that's exactly what Susie tried to say, is that you don't need to be perfect. And I think we put that burden on ourselves more than anybody else in society does. And I think as women, we think that everybody's judging us, and I think we are our worst critics. So you need to be okay to garden. It's not okay to retire, by the way, especially for you. But it needs to be okay to have a life outside of work, whether it's your family, whether it's your own choices that you make. And I think that that's normal. Mau.
Thank you for giving me an opportunity. I belong to Ahmedabad.
Thank you. Your microphone is off. Okay. Just change it.
I am a native of Ahmedabad and having stayed there for 28 years, getting married in this place where I would say that there was nothing on the name of oncology actually when I came here 22 years back. So I joined a hospital, a multi-speciality hospital, and I had to get the tie-ups done for every single thing. Like the biopsy report, it would go to Delhi. Then once the patient needs radiation, there was only single radiation machine in medical college, so I had to send the patient to medical college. Medical oncologist was 40 kilometers away. She was from AIMS and she was sitting 40 kilometers away in the city of Bhilai. So to pioneer all these things and to organize all these things, it needed a lot of struggle and a lot of willpower to establish myself as a surgical oncologist in a tier 2 city.
I think you've done an excellent job there.
Is there anybody else who wants to speak? Mansi, Aparna, you guys, Aparna, yes. We wrote a paper together on how women should be empowered.
Thanks, Bhavna ma'am, for this great opportunity. So all the speakers spoke about their own mentors and how grateful they are. My own mentor is Dr. Bhavna Sirohi ma'am. So I would like to ask you one single question. If there are structured programs for mentorship, like ESMO calls for mentorship program, they match the mentee and mentor and they make a pair and it's like official. But that opportunity comes once in a while, maybe once in 2 years, 3 years. We actually look up to so many of you, like we are mesmerized by your career progress. We actually have a lot of respect for what you do. We would want some of you as our mentor, but how do we actually get a mentor? If you are fortunate that in your workplace you have someone who guided you, which was like very spontaneous for you, but say I am in a tier 2, tier 3 city, I look up to so many of you, many of the international or national faculty or people who are doing very well for yourself. It may be a male or a female, but how do we actually get a mentor if you are a little
So, you know,
underprivileged?
she was introduced to me by one of the Lancet editors actually. You know, but we should have a, I don't know, one of you could, Vanita, Aparna, one of you could, we should have something which is in India where, you know, we can match a mentor and a mentee so that, you know, we can guide.
Ma'am, I think Balco can do it because you have done a fantastic job organizing every year. Maybe we can start it small time.
Next
like
year,
some-
maybe we match the mentor mentees and then, you know, get them to present what has happened. Aparna, what you want to say?
I would also just add, don't be shy to reach out, right? I think structured programs are incredible and I think create an opportunity that, but that opportunity can also happen without structure. And so I have developed many relationships just by reaching out to people and vice versa. So I have mentees that are not at my own institution and those relationships were not necessarily formed, some of those were not formed by structured programs. It was people that weren't shy to reach out and send me an email, and then, you know, if the opportunity presented itself to meet in person, then taking avail of that opportunity. And so don't be shy. I think there's a lot of people that actually want to help and it's mutually beneficial, right? You learn a lot as well by forming these relationships. So the structure is incredibly important, but also I would just say don't be shy to reach out to people as well.
So I'm actually going to say if you only had structured programs, I probably wouldn't have been matched to my mentee because, my mentor, because I'm a surgeon, he's a med-onc. I would never have interacted with Dr. Gupta that way. So a lot of it is really, if you look up to somebody, you need to reach out to them. Make the effort yourself. Very few senior people will say no, right? So Sanya talked to you about Dr. Shrikant, and I can tell you if you make a room full of people stand up, half the room will stand up and say he's their mentor. So for GI, he's been the mentor to most surgeons in the room, and that's true. So I know every student that's worked with him looks up to him. I used to run the surgical oncology program in Tata. We tried this mentorship in a structured program. We had to stop it because everybody chose him. And I said, I cannot give him 24 mentees. It's not possible in a year. So what you need to realize is that there are going to be opportunities that you will get. Many of you may not get opportunities. I was lucky to be in an institution where I had so many senior people that I could turn to. I've met two of the most fabulous medoncs who every patient that comes to me who wants a second opinion, I say there are only two people that you can reach out to that I will respect an opinion of, blindly take as an answer in breast oncology, and that's Dr. Shona and Dr. Bhavna. And I wouldn't have met them had it not been for the opportunities that got created through conferences, right? So you meet people in spaces. Please go up to them, introduce yourself to them, tell them you want to learn from them, create a structured program for yourself. Don't wait for a system to do it for you.
Vanita, last word from you, and then we'll have a photo op. Girls, start coming to the front.
So I'll just say that you don't need to have one mentor, and it doesn't have to be a senior person. So for example, Sanya is really junior, but she can mentor people to get to where she was, right? So you can always reach out to people who are just about one single rung ahead of you, isn't it? And I think there are a lot of senior people here. Perhaps we could give our names to Bhavna and say, you know, we are ready to mentor somebody, and whoever wants, please approach.
Shona was actually saying exactly that we could make a list of people who are willing to mentor and put it up there, and anyone wants to get matched to that person can feel free and reach out.
Good morning, everyone. I'm Mirna Domet from Lebanon, and I would like to quote a quote that President Roosevelt, the 32nd President of the US, once said: if we cannot control the word for our youth or prepare the word for our youth, let's prepare our youth for the word. So I think we need to prepare our boys and girls for this culture of equality. And this starts not after they finish school or after they finish university. This starts from the family. So we, as mothers, we need to prepare our children, boys and girls, to respect each other. We need to prepare our boys to respect their sisters and not to have priority, and girls to be outspoken and to speak. And we need to prepare our schools, our teachers to respect this. By doing this, we will reach a day where men will look at women and women will look at men at the same level. And this is where we can say we have, and this is how we empower each other. So I hope one day we will not have a session for only women. We will have a session for professionals, men and women together, because we won't have this difference. I know now that we are struggling not only to succeed professionally, but to prove ourselves as women that we are capable. We don't see this in men. And I hope that it will stop one day. Thank you.
It will one day. So
I would now like to request all the women present here to kindly come up on stage for a group photograph. Let's capture this special moment together.
So men can join as well if they want. I would like to request our chairperson, Mrs. Jyoti Agarwal, also to join us on stage. So you guys keep sitting. Some of you, Ms. Agarwal.
Some can come on this. We can actually do one part of this.
Front. We're looking at the front.
Oncology. The G has to be longer.
Yes. I think next year we will have a session for 2 hours actually in the middle of the conference. That is better because we could not do a meaningful discussion today actually. It was too rushed. More time, yeah. We will do the mental. Yes. Wine and cheese, yeah. Yes. Actually, that's what they do at ESMO. We'll do the same here. Fireside chat, yeah.
On behalf of Balco Medical Center and Women for Oncology, we sincerely thank our chairpersons, speakers, and all of you in the audience for your time, insights, and wholehearted participation. Good morning, everyone, once again. I, Dr. Harshita, it gives me immense pleasure to welcome you all to the 3rd annual BMC Chhattisgarh Cancer Conclave and 6th edition of eCancer. This year, our theme is Driving Common Sense Oncology, Multidisciplinary Management of GI, GU, and Lung Cancer. We now begin the inaugural function of the conclave, marking the formal commencement of this year's scientific journey. It is my pleasure to invite Dr. Bhavna Sirhoi, Consultant Medical Oncologist and Director of Balco Medical Center, to welcome the gathering with her address. Over to you, ma'am.
Good morning, everyone. Please have a seat. Please settle down. So welcome to Raipur and Balco Medical Center, Vedanta Medical Research family. It's a great pleasure for me to invite you to the 3rd BMC annual conclave. So we have done this conclave in collaboration with eCancer. We are very grateful to them because they fund most of our international speakers to come. And I got in touch with eCancer through Professor Gordon McVie and Professor Umberto Veronesi, who were 2 doyens in global oncology. This UK-based charity was founded in 2007, mainly to democratize education globally. So we are very, very privileged and blessed to have them as our partners. Common Sense Oncology, this was a movement started 2 years ago in Canada, in Kingston. And a group of 30 oncologists from 30 countries literally came together, 2 of us from India, myself and Dr. Manju Sengar from Tata Hospital. We wanted to bring the patients back into the discussion because somewhere down the way, we'd lost our way as oncologists and we were chasing numbers. So what matters to patients is living longer with a good quality of life, and this is what this whole conference is about. So what the speakers we have here, all the faculty, all of them are going to try and see how we deliver the best care for our patients here regionally in Chhattisgarh. We started the journey 2 years ago. At that time, we just had one international faculty, Dr. Sanjay Popat. We trained together. I rang him like literally 6 weeks before the conference. And I was like, you can't say no. We had Dr. Badwe, then the director of Tata Hospital. He's also on our advisory board. He kindly did the breast cancer surgery. We had our chairperson, Mrs. Agarwal, director from TMC Kolkata, and director and CEO of Balco, Mr. Rajesh Kumar. So we launched this mainly to drive knowledge sharing, education in the region so that we learn from each other. And since then, we had our beloved chairman, Mr. Anil Agarwal, as well at the meeting. The second conclave we had last year, we had 6 international faculty. Susie is here and Chris Jackson is here. They were there last year as well. And very sadly, Dr. Borges was here last year. We had a remembrance yesterday for her. It's very sad that she
passed away day before yesterday. She was one of the most dynamic people, an educator, amazing humanitarian. She ran the Cancer of Unknown primary workshop for us with Dr. Sandeep Ojha, who's our pathologist. And again, you know, we curate the agenda so that it is relevant to us locally as well and nationally as well, so we learn. And that is why this Congress, I would say this conclave, has become something where students actually really want to come and learn from each other. We also launched Women for Oncology last year. And next year, great suggestions. We are going to actually make it bigger, maybe possibly in the evening, like fireside chat, like we have at ESMO. And we will make an effort in this room to make sure what Aparna said, you know, that we have a mentor-mentee session so that we can guide some of you through our experiences as well. This year we had the live surgery workshop led by Dr. Anil De Cruz. I think we were going to have 40 people. We ended up having 80 people. Everybody wanted to see this. And Dr. Gauri Pantvedya from Tata Hospital. We had the Mini Accord Research Workshop yesterday, which was inaugurated by our Honorable Health Minister of the region, Shyam Bahari Jaiswalji. The workshop was so popular, run by Dr. Martin Stockler and Dr. Pankaj Panda and our colleagues from all over India, and Chris Jackson as well. So the mentoring will actually shape tomorrow's treatment. Today's research is tomorrow's treatment. And of course, we have Women for Oncology. Communication skills workshop, I'm very excited about tomorrow. I think Martin, Susie, Dr. Yogesh Kalkonde, Avinash Tiwari, you've had literally weekly meetings. Dr. Rudra from our team and Dr. Senthil to drive the role play session that you're going to have tomorrow to see how you tell the prognosis to a patient. How do you break bad news? So that, you know, when a patient has a cancer diagnosis, they don't just run away because of fear. We have a cancer prevention workshop which is going to be led by Padma awardee Dr. Nirja Bhatla and Dr. Sharmila Pimple. She's the head of preventive oncology. This is the need of the hour for this region because most of our patients come in stage 4 and stage 3. We want to change the dynamics so they come in stage 2, stage 1 and stage 0 ideally. Radiotherapy planning workshop is led by Dr. Gaurav Gupta. Again, this is to drive quality and excellence in the region. Tomorrow we'll have about, I think, 20 to 30 consoles where consultants and delegates will learn how to do live contouring for a liver cancer and a pancreatic cancer. And for the first time, we have poster presentations this time. And we are very grateful to eCancer for publishing them, the top 6 abstracts. Thanks to Aruni Ghosh. We're going to publish them in eCancer, the top 6 ones. Briefly about BMC, as you can see, we are doing better with increased patient footfall and occupancy. A typical month in Balco Medical Center, we are literally, last month we did about 1,600 chemotherapies. We do almost more than 11,000 labs. In a month, we are touching almost 280 surgeries, thanks to our amazing surgical team led by Dr. Devakar Pandey. These are just the numbers. We have NABH, NABL, all the key accreditations that are needed in our country. The key achievement for last year was that we have been empaneled with CAR T cell therapy, which is going to be led by Dr. Dubendu De. So the team at BMC is, I'm extremely proud to be working with the team. We won the Cancer Grand Challenge Award last year, which is the first and only Indian institute to ever have received that. And most of the work is done. We are now just waiting for Health Ministry Steering Committee approval. We are the largest BMT unit in the region. We've done more than 100 successful bone marrow transplants as well. And the most important is we've started the DNB program, the education program in medical, surgical, and radiation oncology. And Dr. Harshita is our first student. Dr. Saur, all of them are here today. But she is also going to be the master of ceremonies today. So I think cancer treatment is important, but what we do separately is also very important because most of our patients, 90% I would say, are below poverty line. Logistics have to be taken care of. So to provide holistic care, we have free pickup drop services from the station to the hospital, from the train station.
This high protein diet, which is funded for all patients who come to, general patients who come to the hospital, which is funded by Mrs. Agarwal, and we are very grateful for it. Every patient who comes gets a banana, almonds, Threptin biscuits, and dates. So via Cuddles Foundation, very grateful, we get free nutritional supplements. We've also tied up with CanKids. The whole point of tying up with like-minded organizations is to make sure that the patients, every single patient gets the treatment they should get. Free diagnostics, we have Dr. Purna Kurkure here, and extremely grateful to Indian Cancer Society. So last year, from BMC Charitable Fund and ICS, we funded almost 1.8 crore of diagnostics benefiting 1,400 patients. This is just last year. And Arun Kurkure Fund helps us with almost diagnostics for 60 to 80 patients per month. So we make sure, because Ayushman Bharat doesn't fund diagnostics, we have a mammography van. We did about 60 camps last year. The aim is to do more than 120 camps this year. The most important thing for our country, we have driven HPV vaccination drive for eligible girls. So various schools we go to, mainly government schools, we are trying to target 15 to 18-year-old girls and drive HPV vaccination in these areas. Mainly to support also our government's, Modi ji's initiative of Swasth Nari Sashakt Parivar Abhiyan, which is being run from 17th September to 2nd October. We are doing camps every single day to make sure that every woman who needs to be screened gets screened. These are our donors, supporters, and collaborators to whom we are extremely grateful. And of course, none of this would be possible without the visionary leadership of Mr. Anil Agarwal, chairman of our Vedanta group, who has set up this facility when I came here in the middle of nowhere with the best infrastructure under the sun. And I think we now also have the best team under the sun. And of course, Mrs. Jyoti Agarwal, who's here with Mr. Praveen Agarwal as well. She is one of the most amazing, I should say, bosses to have, because our vision is the same. And once your vision is the same, I think everything is doable. Thank you.
Thank you, ma'am. We shall now commence the ceremonial lamp lighting, a tradition that signifies dispelling of darkness and ushering of knowledge and wisdom. I would like to call upon our esteemed dignitaries, Mrs. Jyoti Agarwal, Chairman of Vedanta Medical Research Foundation. We welcome you, ma'am. Dr. Shona Nag, Advisory Board of Vedanta Medical Research Foundation.
Sorry, I was supposed to announce. Mr. Praveen Agarwal, Chairman of Sterlite Group, please come and join us for the lamp lighting. Dr. Shona Nag, who's our advisory board member. Dr. Shailesh Shikhande, who's representing Tata Memorial Hospital today. And I'd also like to invite the 3 key people who have actually delivered and worked so hard on the Congress with me, Dr. Devakar Pandey, Dr. Yashwant Kashyap, and Dr. Gaurav Gupta. Please join us.
But
Our first session today focuses on some of the most important issues in cancer care. How can we make cancer treatment long-lasting and resource-conscious? How can we support our patients across the entire journey, from detection to survivorship? And how can we use different healthcare models to shape the way cancer is delivered? To lead us through this important session, I now have the privilege of inviting our distinguished chairpersons, Mrs. Jyoti Agarwal, Chairman of Vedanta Medical Research Foundation, Dr. Shona Nag, Advisory Board of VMRF, Medical Oncologist and Director at Sayadri Hospital, Pune, Dr. Shailesh Shrikhande Sir, Deputy Director, Head of GI and Hepatobiliary Surgery at TMH, Mumbai. To kindly join us on stage, I would request Dr. Shailesh Shrikhande Sir to kindly introduce Dr. Sudeep Gupta Sir.
Good morning, everyone. Sudeep, can you hear me? Lovely. It's really unique, an honor and an opportunity for me to serve as the Deputy Director of Tata Memorial Hospital. And Dr. Sudeep Gupta, Professor Gupta was supposed to be here. He's unfortunately, due to pressing commitments, unable to make it in person. But here he is. I have known him more as a colleague for more than 2 decades. At that time, I used to like him more because he was in GI oncology. But now, of course, he's a widely regarded and respected medical oncologist in gynec and breast oncology. That's his first introduction. The second bit is that he is brilliant with research, and I'm in awe of his research capabilities and the way his mind functions. I'm fully aware that some of my research projects are going to get completed only because of his super insights. But I won't take much of his time just now. You all have assembled here to hear him talk. Last but not the least, he is the director of the Tata Memorial Center, clearly the foremost cancer center and one of the finest that we have had. And we are very proud to have him here. And Sudeep, good morning to you, and we want to hear you talk to us, to a very fine audience here. Thank you. We are unable to hear you, Sudeep.
Can you hear me? Can you hear me?
It's still...
I'm unmuted. Hello?
Not
Can
yet.
you hear me? Hello?
One sec. We will check whether there's anything at our end that needs to be checked.
Can you hear me?
Yeah, now you can make it a little loudly. We're just about...
Can you hear me? Can you hear me?
Yes. A little more volume if we can at our end.
Yeah, if we... Yeah. Can you hear me?
Yeah. Thank you. Thank you. Go ahead.
Good morning. Thank you very much, Dr. Shrikhande, for your kind introduction. It's an absolute honor to be your friend and your colleague for the past 2 decades. The feelings are mutual. Let me share my screen and get on with the... Oh, you have... Okay. So I have to be allowed to share the screen. If somebody can make me the co-host or give me the sharing rights.
Yes, they are working on it and they are right here and they will facilitate that.
And they have done that, and I believe my presentation is on the screen. Can you hear it? Can you see it?
Yes, very clearly.
Okay, perfect. So good morning to the esteemed chairpersons, Mrs. Agarwal, Dr. Nag, Dr. Shrikhande, and to Dr. Bhavna Sirohi, all other colleagues in the audience. Before I begin, let me join all of you in mourning the loss of India's greatest pathologist, Dr. Anita Borges, who I believe was also the last year's awardee. We all will deeply miss her, especially her guiding hand in the care of our patients. I fully intended to be in person among all of you, but due to some unavoidable circumstances, I am unable to do so. So please accept my profound apologies. Thank you, Dr. Bhavna Sirohi, for conferring on me the McVie Varanasi Award lecture. I hope I will do justice to the mandate that you have bestowed on me. So, Tata Memorial Center is one of the units of the Department of Atomic Energy, and there are 30 of them, all of them shown on this slide. And we are very fortunate that we are part of this family. These are all the hospitals of Tata Memorial Center, now in 7 states of India. And I will share with you some insights and thoughts on how we work, especially to deliver cancer care that is sustainable, that is cost effective, and useful for our community and our fellow citizens. This is some data from the UN Population Division, and it shows that in the past 200 years, the population has expanded, literally exponentially, but almost all of it has been in the so-called developing parts of the world. And what this means is that everything that we associate with increased population, including growth, including GDP, but also including disease, is in the same proportion. This is rather a remarkable forecasting analysis from the Global Burden of Disease Study Group, and I like it very much. It tells us, it forecasts for us what will we and the world look like in another 75 years at the turn of the next century. On the left is the population of the whole world. It will peak in the middle of this century and then decline. But very importantly, on the right, the population of India will also peak in about another 25 to 30 years at about 1.7 billion. And then it will decline at the turn of the century to about a little over 1 billion in the year to 2100. This is the age structure of the world's population, and it is very similar to what is happening in India and many similar countries. And you can see that just now, the world's population is relatively young, but it will grow progressively older as we mature and as we so-called develop in many parts of the world. And of course, what this means is that when we become older, maybe less populous, the number of working age adults will decline, but also the burden of non-communicable diseases is going to increase on the world. These are some numbers from IARC, and for purposes of depiction, I am showing 2020 and 2040. So we had about 1.3 million new cancer cases in India in 2020, expected to increase to about 2.1 million in 2040. We had 850,000 deaths in 2020, which will increase to 1.4 million deaths in 2040. On the left is data from many countries in Europe. The incidence is about 350 per 100,000 population. The mortality is about 80 to 120. So which means that approximately a third of the patients who are diagnosed with cancer in Europe die of their disease. These are data from several Asian countries, and towards the bottom is India. And you can see that even now, the incidence of cancer is relatively lower. It is about 100 to 120 per 100,000. But about 60 to 70% of patients die of their disease. So although our incidence is lower, the case fatality ratio, the proportion of patients who get cured of their disease, is actually lower. These are data from the population-based cancer registries in India. And at the bottom, I have depicted Barshi rural, which is about 60 per 100,000. But you see towards the upper part of this cartoon, for example, in Delhi, the incidence of cancer has now crossed 150 per 100,000. So there are disparities, but as India becomes more urbanized in the coming decades, this is what we are going to see. The topic for my talk today is sustainability, and I thought about it, and I searched high and low. So let me give you my 2 pence worth on what sustainability is: delivering better outcomes per rupee for more people for longer with system resilience and ethical governance. There are several things in this statement, and each of them is very important. So sustainability can be looked upon from an institutional standpoint, from a personal standpoint, from the national standpoint. But for the purpose of today, let me talk about it from the institutional standpoint. So we need financial sustainability, workforce sustainability, including when required task shifting, research and innovation that feeds into affordability and cost-effective care. We need resilient infrastructure, integration and partnership with our community, equity and access, so that we do justice as far as possible to all sections of the society. We need to progressively integrate data and digital and learning health systems. Our decisions should be driven by clinical value and outcomes, possibly HTA driven as we become increasingly more sophisticated. And of course, everything has to be in the context of governing ethics and culture. And there are certain aspects of sustainability that are hardwired into our systems and that lead to mission critical sustainability. So let me give you a little brief about Tata Memorial Center, because it is an example of sustainable cancer care for over 8 decades now. Our vision and mission is to provide comprehensive cancer care to all sections of the society, regardless of their ability to pay for it, through excellence in service, education and research. We were commissioned by the House of Tatas in 1941, but since 1962, we are one of the units of the Department of Atomic Energy, the Government of India. And in 1941 and in 1952, we were a single institution in the middle of Mumbai in Parel. CRI's Cancer Research Institute, which is our basic science wing. This is some data from 2018, and this shows that in 2018, about 77,862 new patients registered in our Mumbai hospitals, Tata Memorial Hospital and Actrec. The question is, where did these 77,000 patients come from? And this is a heat map that was generated by my colleague, Dr. Pramesh, the director of Tata Memorial Hospital. And you can see that the patient who came to Mumbai came predominantly from northeast, east and northern part of India. And you can see that there are relatively fewer patients from southern India and western India. And this, of course, attests to the variability in cancer care expertise and infrastructure that is available in various parts of our country. So beginning 2013 and up to now, we have created 9 more hospitals, in the process of creating 2 of them, but 9 more hospitals in 6 more states of India, and all of them are listed on this slide. And in the calendar year 2024, we registered 129,000 new cancer patients among all our hospitals. And this is about 9% of all the new cancer patients registered in India. We have MOUs for technical assistance to several state governments that are listed on this slide. So let me tell you not about Mumbai, but about Muzaffarpur. And the reason why I'm saying that is because we need to create sustainable systems and infrastructure in every corner of the country to care for cancer patients, and of course also for patients with cardiac, renal and other non-communicable diseases. So 15 acres of land was given to Tata Memorial Center by the government of Bihar in 2018. We started the construction of this hospital in 2022. But beginning in 2021, we began the operations. The building was not yet constructed. On the left upper part of this slide, you can see the prefabricated sheds that were created for caring for patients with COVID. And on the bottom left of the slide, you can see the wards for cancer patients that have been created in this COVID era sheds. And even as the building was being constructed, by the end of 2023, we had registered close to 11,000 new cancer patients in Muzaffarpur. We had performed a little over 5,000 surgeries in the same hospital. In a rented premises from the local medical college, we created an NGS lab. And the reason was not because NGS cannot be done from elsewhere, but because we want to create a system, we want to create a proof of concept that relatively sophisticated tests and processes can be established in every part of India if we create resilience and have the will to do so. We conducted awareness, screening and training in all the 38 districts of Bihar that are listed on this slide. You can see we created daycare centers in several districts of Bihar, Gaya, Bhagalpur, Purnia, Darbhanga, Patna, and so on. And some of the numbers are listed there. Very importantly, this is what was the situation about 1 year ago. The hospital was being constructed, and I'm very happy to say that on 22nd August, just over a month ago, we had the Honorable Prime Minister of India inaugurate the full hospital that you can see on the right. But a hospital is not made of buildings and equipment, it is made of people. It is meant to care for individuals. And you can see here that even as we speak, as of August 2025, a total of 23,000 new cancer patients have been registered in our Muzaffarpur unit from the beginning of its operations. And close to 13,000 surgeries have already been done. The growth of the Muzaffarpur center is depicted on this slide, and you can see the various milestones that I will not go into in detail. But I'm very happy to also say that we started 3 linear accelerators and a brachytherapy unit in Muzaffarpur about 9 months ago, and it is now a fully functional, comprehensive cancer center that provides reasonably good treatment from all standpoints. Wherever we start our hospitals, we also begin with documenting the cancer burden and the cancer incidence. And just about a month ago, my colleague Atul Buduk and several of our colleagues have published this very important paper about the cancer burden from Muzaffarpur from the population-based cancer registry. So many hospitals actually start their operations without fully documenting, at least in their vicinity, the problem of cancer as it presents itself. And you can see the Muzaffarpur district and its various blocks depicted on the bottom right of this slide. These are the most common cancers in Muzaffarpur, as expected, those of the mouth and tongue, but very importantly, prostate is also there, and among women it is the breast cancer. Very importantly, although the incidence of cancer is low in Muzaffarpur, only about 40 to 45 in men and women, but you can see the mortality is high. So about 2/3 to 3/4 of patients who are diagnosed with cancer in the district of Muzaffarpur actually die of their disease. And this is data from 2018 to 2021, when we had established the registry but had not yet established our hospital. And these are the survival outcomes from the patient from the same 2018 cohort. And you will immediately see, for example, in breast cancer, the survival is a little over 25%, which is not as it should be in breast cancer in this day and age. And therefore, it is very important to document the baseline with which we will compare ourselves as we go along. Let me give you a second example of our hospital that we started in Punjab. And in Punjab, we have 2 hospitals. The hub is in New Chandigarh, which is on your left. But the spoke or the smaller hospital is in Sangrur, which is a semi-urban location in Punjab. And that is a spoke hospital. It was commissioned in 2015, and even today we operate out of the district hospital premises, which have been very generously given to us by the government of Punjab. And you can see here that we have registered a large number of patients, performed surgeries, given chemotherapies, given state-of-the-art radiotherapy, performed very sophisticated interventional radiology procedures. But very importantly, it is also important to build the local ecosystem. The workforce, the trained workforce will not magically appear out of somewhere and drop from the skies to work at each of these locations. We have to create the local workforce, and you can see that a number of courses have been started. And I'm very happy to say that some of our alumni are currently employed in the same location where they trained. Again, we started population-based cancer registry in Punjab before we started the clinical operations, and we have shown that the quality of registration is high, and there are very important methods for documenting the follow-up and survival to an accurate extent. The third example is Varanasi. Again, two hospitals. On the left, the railway hospital that was given to us. On the right, a greenfield hospital that was created in the BHU campus. And again, I will draw your attention to the fact that in 2024, we registered 26,000 new cancer patients in Varanasi and delivered the care that is depicted on this slide. As our centers evolve, as our units become mature in their operations, we begin to incentivize them and to help them conduct high quality research. And I'm just depicting that on this slide, a randomized control trial led by Varanasi that showed that metronomic chemotherapy is quite useful in patients with head and neck cancer that is refractory to platinum-based chemotherapy. Another example of resilience is childhood and sustainability is childhood cancers. In 2008, there was a survey that was conducted by our pediatric oncologists and some individuals from the community who cared about the situation, and 25% of patients actually abandoned their treatment. And the reasons for abandonment are listed on this slide and in this cartoon. Gender bias, crowded treatment center, financial constraints, very important, belief in the incurability of cancer. And so in 2010, in Tata Memorial Center, between our pediatric oncologists and socially minded individuals from the community, we started a foundation called the Impact Foundation. And what that has done is to do all of these. And again, I'm giving this as an example because we are talking about sustainability. Financial support, accommodation, nutrition, transfusion support, education, travel, survivorship, bereavement. And everything has been accomplished progressively. You can see that various things have been done along the way. Very importantly, we tracked what happened to our patients. There is no point in saying things that are not quantifiable. You can see that every patient has been tracked from 2010 onwards. We have provided social support. We have motivated individuals to create a platelet donor registry, which is voluntary, and that is extremely important for hematolymphoid cancers and pediatric cancers, and of course also for many adults. Accommodation was provided through partnership with the St. Jude's Children Cancer Center, nutrition support, bereavement support, dignity in death, education programs so that they don't miss an academic year, sports and culture to ground them in real life. And you can see that although we started pediatric oncology only in Tata Memorial Hospital in Mumbai, but now we are present in almost every center that we have created. And in the most recent year, we registered close to 4,000 new pediatric cancer patients among all our hospitals. And I'm told that the only center that registers more is the one in Egypt. Very importantly, from the point of view of sustainability, the annual requirement to care for all these patients is about 80 crores. And our colleagues from the Impact Foundation have raised 54 crores of those 80 from non-governmental sources. And this is a very important example of sustainability and partnership with the community to provide focused care and outcome to a group that actually can be cured and contribute to the community and to our society for decades to come. So many treatments were supported, they are listed on this slide, and the details are not very important except to say that everything starting from day one workup to something as advanced as proton therapy is being supported by the Impact Foundation. But again, like I said, what is not quantified is not done. The abandonment rates were 25% in 2008, and in 2023 they are 1.77%. So you see the impact that the Impact Foundation has made in 15 years of its existence, sustainability. This was published as a peer-reviewed article in this journal, and the long-term survival of children patients has increased from 41% in 2010 to 58% in the 2018 cohort with a 5-year follow-up. So everything that is inputted, there is an output, and both the input and the output are quantifiable, and we have proven that it is sustainable, at least in a 15-year time frame with respect to the Impact Foundation, and I'm certain that this will go on in the future as well. In Tata Memorial Center, we care for patients in a terminology and in a mechanism called the multidisciplinary disease management group. So Dr. Shikhande is a surgeon, but his primary affiliation is as a GI oncologist. I'm a medical oncologist, but my primary affiliation and identity is as a breast and gynec cancer oncologist. So we have these multidisciplinary groups. Of course, we need to have sufficient capacity and sufficient strength to be able to pull this off. And we have done that in our Mumbai hospitals, and we will establish this in the other units of Tata Memorial Center across India. I will give you only a few examples of research that feeds into sustainability, cost effectiveness, and what is doable and practical. We try to research in all these themes, and along with Dr. Badwe, I had the occasion to put this as a perspective in the National Medical Journal of India. Improved treatment delivery mechanisms, affordable technologies, population-based interventions, translational research, and novel treatment strategies. This is the randomized controlled trial of screening for cervix cancer by visual inspection with acetic acid that all of you know about. 150,000 women in parts of Mumbai randomized 1:1 to either receive VIA or only health education. And you can see that the cervix cancer mortality declined by 32%. The other component of this study was clinical breast examination as a method of screening for breast cancer. Again, breast cancer mortality declined by more than 30% in women above the age of 50 years. This is doable, this is sustainable, this has been adopted by the Government of India for implementation throughout India at the primary and secondary healthcare levels, and is being implemented in almost all states of India. I cannot say that it has been implemented in full, but at least we have provided a model for what is sustainable and what is doable. Oral cancer, very important cancer in India. Our colleagues from the head and neck group showed that performing neck dissection saves lives, doable, implementable, sustainable. Our medical oncologists from the head and neck group showed that oral metronomic chemotherapy is at least as good, possibly better than platinum-based chemotherapy for some patients with oral cancer. My colleagues again from the head and neck cancer group showed that giving an immunotherapy drug at 1/7 of its labeled dose is still useful in terms of survival. That you can see on the right. This is published in the Journal of Clinical Oncology. Our breast cancer group showed that short course trastuzumab is non-inferior to its full 1-year course. Again, something that feeds into sustainability and doability and was adopted by the Ayushman Bharat scheme. More recently, in collaboration with the Bhabha Atomic Research Center scientists, we tested a derivative of chlorophyll. So all of you know chlorophyll is the green plant pigment. Its derivative is chlorophyllin, and it has been found to be exceptionally useful in preventing side effects of radiotherapy. You can see the severe cystitis that almost resolved with the use of this tablet. This is under drug development. Again, this is not something that will cost 3 lakhs of rupees a cycle, something doable and sustainable. In collaboration with our colleague from IIT Bombay, who's seen circled here, and with my colleagues from Tata Memorial Center, we helped to create India's first indigenous CAR T-cell therapy that comes at a small fraction of what it costs in other countries. So we have learned that we need to ask a relevant question in the Indian context. We don't necessarily need to be dazzled by what others are doing. We need to figure out what we must do and what is useful for us. It should have the potential to define clinical practice worldwide, should have robust design, meticulous follow-up, and of course there needs to be funding, for which we are grateful to the Department of Atomic Energy with a long appetite for long gestation periods. So we spoke about sustainability in cancer care, and one of the inputs there was governance, ethics, and there was a word called culture. So everybody is very fond in Tata Memorial Center of talking about Tata culture. And I could never hear anybody define the word Tata culture very well. And just about a few months ago, Professor Ashish Jha from the Brown University, the Dean of the Brown University, was visiting us, and he gave a very nice talk on the Thursday morning. And after the talk, I was having a chat with him, and he actually gave the best definition of an institutional culture that I have yet come across. And this is my conversation with him, and let me tell you what he said. The culture, or an institutional culture, is a set of norms and expectations that institutional members have of each other, built as an institutional memory over decades of existence. So in the 84 years of existence of Tata Memorial Hospital and Tata Memorial Center, our members have come to expect something of each other, and that is what is it is a loose but the best definition of institutional culture that I have come across. And this is what we wish to infuse, and for our other centers to imbibe all over India. So we try, life is not perfect, individuals are not perfect, and institutions are also not perfect, but we try to deliver affordable cancer care in India with quality and at scale, and we try to create replicable models of affordable cancer care. Thank you very much for your attention, and I hope I was able to convey to you a sense of what we do at our institution. Thank you.
A special thank you to Dr. Professor Sudeep Gupta sir for his support and contribution. Since sir couldn't be here with us today, Dr. Bhavna ma'am will felicitate sir with memento in Mumbai when she meets him during the WCI. We now come to a very special part of the program, the Mrs. Vedavati Agarwal Oration Program. I request Mrs. Jyoti Agarwal to please introduce our next speaker. Thank you, ma'am.
I think Madam Agarwal will have a few words to say, and then she will of course introduce the next speaker.
You just heard the story of Tata Group, how they had a long journey for the cancer care. Balco Medical Center was just 8 years back. We started this journey. But the vision remains the same, affordable cancer care to all the human beings who are there on earth. Respected dignitaries, esteemed doctors, our dedicated staff, valued partners, and my dear friends. It is my great honor to welcome you to this third conclave of Balco Medical Center. Today is just not another gathering, but a celebration of what we have built together. and a reminder of the work that still lies ahead. When we first envisioned this hospital, our purpose was very clear: to make advanced cancer care available to every person, regardless of where they live or what they can afford. For too long, families in smaller towns like ours have faced the double burden of disease and distance traveling to faraway cities, spending beyond their means and enduring the uncertainty of treatment away from home. Our hospital was born out of conviction that quality health care is not privilege of the few, but the right for all. Our group chairman, Mr. Anil Agrawal, had the same vision. Under the dynamic leadership of Dr. Bhavna, over these years, I am very proud to say that we have built up with a similar vision of cancer care affordable to each and every one of our society, providing treatment to thousands of patients with compassion and dignity, offered subsidized and free care for those in need, invested in modern diagnostics and treatment facilities, conducted outreach programs to spread awareness and promote early detection. We have started this program in a very rigorous manner to go to the interior parts of Chhattisgarh, Orissa, and to our neighboring states, so that the awareness of the cancer comes to these strata of people where they were ignoring and reaching to the stage 3 or 4 and having an early end of their lives. So these camps have helped a lot to us. But what gives me the greatest satisfaction of these human stories is that when there is an early detection for these people, the farmer can complete his work. He does not have to mortgage his land. The mother can stay with his child, and the survivor. These are the milestones of our journey. Friends, our mission is far from complete. Cancer is on the rise in India, and in smaller towns, awareness and early detection are still limited. The road ahead requires us to strengthen our community programs, focus on prevention, build research capabilities, and train the next generation of caregivers. This conclave provides us the perfect platform to exchange knowledge, to explore partnerships, and to reaffirm our shared commitment to a cause larger than ourselves. I take this moment to express a heartfelt gratitude to our doctors, nurses, and staff whose dedication turns despair into hope every single day. To our donors, supporters, and partners who believe in our mission and sustain it with their generosity. And more importantly, to our patients and their families who show us what courage truly looks like. As we move forward, let us renew our pledge to heal with dignity, to serve with compassion, and to ensure that no life in our region is left untreated, no family left without hope. Together we can and we will make cancer care accessible, affordable, and humane. Thank you, all of you, and I wish the conclave a great success. The Vedvati Agrawal oration has been instituted in honor of Mrs. Vedvati Agrawal, mother of our chairman, my mother-in-law. Mrs. Vedvati Agrawal believed deeply in compassion, service to society, and the dream of equitable care for all. To carry forward her vision, Vedanta Medical Center Research Foundation is introducing this oration to acknowledge individuals who have made significant contributions in making cancer care more affordable, accessible, and patient-centered. We are honored to present the inaugural Vedvati Agrawal oration to Dr. Purna Kurkure. Dr. Purna Kurkure is a distinguished pediatric oncologist with over 53 years of experience. She founded the Arun Kurkure Investigation and Treatment Fund under the Indian Cancer Society after losing a husband to colon cancer. Through AKITF, Dr. Kurkure has supported patients at VMRF as well as contributing to 2.65 crores. I repeat, 2.65 crores and helping 1,670 patients with diagnostic tests till date. She has pioneered cancer survivorship care in India by establishing the country's first after completion of therapy clinic at Tata Memorial Hospital, offering a holistic approach to patient care after treatment. Dr. Kurkure also serves as a trustee of Indian Cancer Society, the largest cancer charity in India. I would like to invite Dr. Kurkure on the stage.
May I now invite Mrs. Jyoti Agarwal Madam and Mrs. Bhavna Madam to felicitate Dr. Professor Purna Kurkure Ma'am for her dedication, outstanding service and commitment in cancer care.
Good morning and thank you to Balko and Mrs. Agarwal for that kind introduction. I can't thank Bhavna because she has begun her journey and she has been the partner in this journey she started her career in oncology with us in pediatric oncology and has moved on, and I'm really proud of her for her various roles at various centers and now settling down at Balko and doing good work. I am grateful to Agarwal family for bestowing on me this very prestigious Vedavati Agarwal oration. And you can see here in a very candid picture which Bhavna provided of Mr. Anil Agarwal with his mother, Mrs. Vedavati Agarwal. द वेद मेरी माँ का नाम है, वेदांता वहीं से निकलता है, मेरी सफलता मेरे माता पिता का दिया गया प्रसाद ही है. It means that he is acknowledging all that he has achieved, and the family is really grateful to the parents and particularly mother, and whatever they have achieved is because of them. And that is where the humility comes, and we all appreciate humility in various aspects. What I am going to run through our experience at Indian Cancer Society is not me, but on behalf of all the board of trustees, as you can see here, and we lost our vice chairperson. Everybody knows Dr. Anita Borges as an astute oncopathologist nationally and also internationally, but to us, she was a vice chairperson of Indian Cancer Society, guiding us in many aspects in screening and education program that we run. And we really will miss her for this guidance. We all are aware of cancer control continuum, which spans through this various facets: prevention, early detection, diagnosis, treatment, survivorship, and end-of-life care. This is the cancer control continuum which has been well established, and we all work in different compartments. As a clinicians, we are more with diagnosis and treatment. As a public health workers, we'll be more involved with awareness, prevention, and survivorship and end-of-life care is at the end of the spectrum. But we have to remember that one rolls into the another, and it starts from prevention, primary prevention or a secondary prevention through early detection, correct diagnosis leading to treatment. A good treatment, appropriate treatment will lead to survivorship, and some of the unfortunate ones where you cannot cure, you have to endure and take care with the palliative care. So this is a merging phase, and at Indian Cancer Society we try to take care of the all verticals through our verticals. We have a vertical on awareness, screening and detection. We try to initiate the investigations, diagnostic procedures in a right way. This is as a support system and also support the treatment, which leads to better survivorship, and that we look after their survivorship phase after cancer care and rehabilitation. We have not dwelled at our headquarters. We have headquarters in Mumbai with branches in major cities like Delhi, Bangalore, Lucknow, Calcutta, and Nagpur. But only Bangalore has made a very special efforts as a prototype for the palliative care. But at Mumbai, we concentrate on medical education, research and registry. And the first population-based cancer registry was established through Indian Cancer Society in Mumbai. Now there are many, and you have seen the power of data through Dr. Sudeep Gupta's presentation as to how it can guide the cancer control program. So through awareness, we have touched 100 million lives. Through the screening and detection, 4.9 lakhs. More than 31,000 are helped through the diagnostic fund, which was started as a family and friend support in memory of my late husband. But now it has been institutionalized for Indian Cancer Society with the CSR support. So though the name has been kindly given by the Indian Cancer Society as Arun Kurkure Treatment Initiation Fund, popularly known as AKTIF, it is being now institutionalized in Indian Cancer Society with the CSR support. We have been very leader in the Asia's first rehab center was started way back in 60s, and now we have expanded this with the survivorship program and our medical education research and registry, as I said, first population-based registry, and the Indian Journal of Cancer, which has been PubMed indexed for many, many years, has been there. And it's a really good source of information is what is happening in India in the oncology space. The awareness, I'll just quickly run through our awareness program, and this is our brand called Project Satark. It is started as a pilot studies in the pilot states are Telangana, West Bengal, Goa and Maharashtra, and the whole model consists of training of the trainers who in turn train the frontline health workers who bring the awareness to the community and the masses. So we have so far conducted TOT for 130 doctors and 45 staff nurses who in turn trained the 4,887 frontline workers, ASHA workers. Basically it is a primary healthcare centers which are the focus of activity, and 65,000 plus community awareness sessions are being conducted, reaching to 9.7 lakh plus beneficiaries. The awareness through multimedia is now the norms, and for the increasing reach, and we use various celebrities to pass on this message in a very positive, hopeful and non-intimidating messages to stay 2 steps ahead of cancer. We are not saying that cancer can kill or cancer is this is hazardous. We say that you have to have a lifestyle to keep and have the proactive participation to stay 2 steps ahead of cancer by various mechanisms in mass media on the important oncology calendar days. We have also, our Delhi branch has launched an app, and this awareness through mobile app is everybody is very savvy with the app on smartphone now. So it is available on both Android and iOS, and it is going to be multilingual, because in India we have to be a multilingual. To begin with, we have chosen 5 languages and 5 diseases like most common: oral, breast, lung, childhood cancers. These are the diseases, and cervix cancer, because we are in a very big way in cervical cancer control. So these are the diseases which are there on the app in 5 languages. The medical education program, as I said, that many don't know this aspect of Dr. Borges. She spearheaded this, and particularly during COVID, when we could not do things in the field, we started developing this module for the family physicians and general practitioners to engage and educate them for cancer care, building their commitments, making them aware of the common signs, symptoms, and how they can share the patient's care and their journey through and through, rather than just referring to the tertiary cancer center. So their engagement and involvement through this program, MEP, what we call medical education program, it began in COVID when we did not have the field activities, and it is being now carried forward. Awareness through sensitizing teachers and students. This is also spearheaded by our Delhi branch along with Government of India, and they try to do the faculty development program. Teachers are taken into consideration, and each teacher looks after 5 to 10 students to mentor them and give them the cancer related information. E-learning courses on cancer fundamentals are given, and improving classroom learning by empowering teachers. The whole aim is this, that we empower the teachers to pass on the message to the students. Screening. Now, screening has various steps: target the population, collaboration with the government already existing agencies for reaching out to the larger numbers, community awareness, registration. Pre-camp activity consists of community awareness, then only you will have a good turnout and registration. Then actual screening, and then the data. Again, we have to have the answer as to how effective we have been and are we successful. So data entry, then counseling of the screen positive persons, and navigating them to the cancer centers to diagnose them early, which is the main aim of the screening camps. Not just do the numbers, but have the quality product at the end by having the screen positive patients, not the patients, I would say screen positive individuals, navigate them to their final destination to prove whether it is a cancer or not. So we have been, though VIA, visual inspection with acetic acid, has been applied, but now we know that HPV DNA is the final word for the diagnosis of cancer of the cervix, and we are trying to do that study to find out how far that has been the case, and try to take up this initiative of WHO of 90% of women being screened, 70% of girls being vaccinated, and 90% are aware. So the cancer of the cervix is a preventable disaster, and no woman should die of it. That is the statement of WHO, and we are trying to align ourselves with this goal, and we have created a position paper, and we are working very vigorously on this aspect for cervical cancer prevention. You heard about the Arun Kurkure Initiation and Treatment Fund, and there was a gap. We have the another big scheme of Cancer Cure Fund, which is based on the financial model of a mutual fund generating large amount of money of the investors and giving at least 5 lakhs per patient to carry on with the treatment. But there is a gap of diagnosis. Nobody supports. Now you have Ayushman Bharat and many other schemes which support the treatment part of the story or journey. But the diagnosis and correct staging, which requires planning of the treatment, which is a mandatory thing for planning of the correct treatment, is missing. And that is how this aspect has become very important, and nobody is trying to help there. And AKTIF fund is really helping the patients to get to the diagnosis and proper staging, because all of us, we know that diagnostics of the oncology are quite money spent, like it's a large expenditure upfront, and many of the patients, they just abandon further interaction after learning the cost involved. And Dr. Ravi Kannan has given the endorsement that how it has been helpful in remote areas of Silchar in northeastern region. Similarly, Dr. Banavli always says that the most important thing which has happened in Derwan, which is the interior of Konkan area in Maharashtra, is the AKTIF fund. And you can see the distribution. And this is the Cancer Cure Fund which I was talking about. It has supported so far 18,500 patients, and rupees 302 crores have been disbursed till March 25, last financial years. And this is through total support, though it was started by HDFC Asset Management Company in their 10th year celebration, and the whole idea is the investors gives the money which is managed by them professionally, and the dividends which are created are given to Indian Cancer Society, either in 100% form or 50% of that. The investor has a choice. The principal remains with the investor. So this is how large number of common men came and invested, besides the institutional investors. And looking at the success of this story, many of the CSR funds are adding to this Cancer Cure Fund. And we have already empaneled large number of hospitals with a good volume of patients across the country. More than 17 hospitals are, 19 CCF empaneled hospitals are there. And as you can see, though the overall mortality from the population-based data with Dr. Sudhir Gupta said is very dismal, when you give this kind of a support, 54% of the patients financially supported for treatment have survived for more than 5 years. This is what we have analyzed from 2011 that we started to help the patients till 2019. And that has improved the survival, and this tells us that how a sustainability can be brought by good support systems. Balco Hospital, as Bhavna mentioned, was empaneled only recently in 2022, but in a short span of time, large number are helped through AKITF, 1,842 patients, and Cancer Cure Fund has helped 119. So very significant amount has gone to Balco, and we are happy that it is being very much used, and it aligns with the vision and mission of the founders and the hospitals. It's not moving. It's not moving, please. And the last, which is very dear to my heart, is survivorship and rehabilitation as a professional also, and as a part of ICS also, is survivorship and rehabilitation. If you have to support patients during treatment and with their post-cancer efforts to mainstream, the whole mission is to support patients during treatment and with their post cancer efforts. So it rolls over from Cancer Cure Fund, AKTIF giving rise to good diagnosis, patient being supported for Cancer Cure Fund, that is our vision, being survivor and rolled over to survivorship program. Which we help through education fund, late effect fund. This is for childhood cancer survivors group that we do, but we want to extrapolate this experience to the next age group, which is also very productive and useful for society, that is adolescent and young adult, AYA. We will soon look after that also. And we have created this UGAM, which is a survivor supporter group, emotional support group of childhood cancer survivors, is a unit of ICS under its survivorship program. UGAM means to rise, and underscoring the determination of these survivors to rise above all obstacles in life by being victors. And this was launched in 2009, and we celebrate each year on the International Cancer Survivor Day, that is the first Sunday of June. And 16 years have gone by. 3,000 plus survivors have been supported at survivorship clinics at 16 hospitals in 8 states. And this module has basically emerged out of our ACT clinic at Tata Hospital, where first it was only medical late effect surveillance and management clinic. Then came the UGAM in 2009, and we have floated this module that we have to go hand in hand with medical management, medical surveillance and management at ACT clinic, being supported through psychosocial evaluation and other support through network, through the cancer survivors group like UGAM. And this module, we felt that it should be more, it is more comprehensive, and it takes care of medical follow-up, associated late effect clinics, and career and counseling, psychosocial counseling, support group, NGO or not-for-profit organizations like ICS is deeply into educational and vocational support and late effect support. So it's a very comprehensive care beyond cancer therapy also, and we tried to take this experience through our project Picasso, that is Partnership in Cancer Survivorship Optimization, across the country to encourage regular follow-up after completion of cancer treatment, to facilitate education, increase awareness of late effects and monitor for early detection of the same, encourage support group formation, and to improve the quality of life after the cancer experience. And what we do is to partner with hospital where there is a good amount of pediatric cancer work going on, and try to facilitate. The hospital has to agree to start the ACT clinic on their own with their medical pediatric oncologist, and there should be a committed pediatric oncologist for the cause. And through counseling, need assessment, support emotionally and financially as required. That comes from the Indian Cancer Society. So it's a true partnership which is being taken care of, clinical aspect from the hospital and psychosocial aspect from the ICS. And as you can see, we have already registered, there are 17 units which we have created in this span of from last 8 years, from 2017 onwards. And as you can see, 4 are in Mumbai and many other places like Uttar Pradesh. And we try to go where there is a large pediatric cancer units like Homi Baba Cancer Institute in Varanasi, they are now having. We have a distinct place like Sher-e Kashmir Institute, because there was a committed pediatric oncologist who wanted it and who is complying with all the requirements. So that is the first and foremost requirement for us, and we generally try to go where there is a comprehensive care for children with cancer. And this is what shows how it is being, our education program has been named after the founder, Dr. DJ Jasawala, and we have spent almost 3.3 crores and total of 458 applications, new applications, and 887 re-applications have been looked after. So it is not a one-time fellowship that we give. Once we identify eligible survivor, we handhold them through and through their career development till they reach their final milestone. So milestone is defined upfront, and that has been generally taken care of through and through. We define the medical late effects, which are not in the ACT clinics, and then what do we do with them, because there is nobody to take care of them. There are endocrine replacement therapy like growth hormone replacement therapy, which are very costly as a treatment itself. So how do we take care of these things to improve the quality of life? So we have created the Medical Late Effect Fund in Indian Cancer Society as a part of survivorship program, and we take care of the various endocrine, neurocognitive, vision, prosthesis, hearing deficits, all those common late effects in partnership with you require experts in all the fields. This is encompassing, it is not an oncology care, it is encompassing the whole of multi-speciality care which you need. And it is a very difficult, but we have developed a module, at least in Mumbai. But how to do that for other partners sitting across the country, we are figuring it out, because it is very difficult to control or monitor it from a distance. But we are trying to do that. So just now they are referring the patients, survivors who will benefit from these efforts, but we try to do that at their level also. So these are the late effects, and they started from 22, and now till 31st March we have already taken care of this many late effects, as you can see here. And the commonest ones are endocrine, which are very, very costly. Other is prosthesis, because these growing children, they require their prosthesis to be after the growth is over, they need to be revision. They have to undergo revision, and that is again costly affair. So all these are taken care of. And then we said that they have to be empowered with the knowledge, and the survivors have to be empowered with the knowledge and given the responsibility of their life. We cannot be hand-holding them for the life. So we state that we will develop this open forum, and we talk about various issues every month on a Sunday, virtually, and we bring out heart health, fertility, marriage, and so on. So all the common issues which psychosocial analysis has brought out as to what are they worried about, we try to talk openly, and the survivors join us with a number of experts who come and give them the talk, followed by the interaction. But this is virtual, once in a month on a Sunday, when all the survivors can attend, because survivors have become busy themselves. So this is just a glimpse of our anniversary celebrations, which is full of life, and it's a very vibrant event. Our calendar for the survivors in Mumbai starts in June with the celebrations, and goes round the year with various activities. They are our ambassadors to tell the society that childhood cancers and many other cancers also are curable if detected and treated appropriately. So they personify that statement, and we begin the celebration on 1st Sunday of June, and then go through this many activities. One of the most important survivor-based activity is Relay for Life, and we are the nodal agency for Global Relay for Life, and we take the survivors to various educational institutes, higher secondary onwards, in colleges, and try to build around this their three mandates: celebrate, remember, and give back. These are the three. So it is mainly awareness, activity, and also when it is successful, it can be a fundraising activity as well. So this is what survivors drive the whole efforts of Global Relay for Life through our survivorship efforts, vertical. And there are many other partners who have taken up the model of UGAM and started developing survivors network in their own cities, like Sahas in Mazumdar Show Cancer Center at Bangalore, similarly Shere Kashmir, also Cancer Institute Adyar. All of them, they are taking this as a prototype and trying to develop the survivors network locally. And they celebrate 15th February as International Childhood Cancer Day, and September, which is the current month going on, as a Childhood Cancer Awareness Month. And they come forward with and help us to create this awareness amongst the community about the childhood cancer, amongst the professionals, by, as I said, by giving the example how they have survived in the whole journey. So we acknowledge the continuous support from the partner hospitals, advisors, donors, and UGAM members who have driven this whole awareness program. Our rehabilitation center was the first one in Asia. In 1961, we started this center. It was not a center, it was in the basement of Tata Memorial Hospital, where Dr. Jasawala was a director then, with various vocational activities being done in the basement of Tata Memorial Hospital. And looking at those activities in 1979, in 78 we got a piece of land which was very adjacent to Tata Hospital, and we constructed and started the first rehabilitation center then. We have this various programs, psychosocial rehabilitation, vocational training. Patients receive vocational training like prosthesis making, tailoring, bag making and printing, so that they can become financially viable once their treatment is over and lead a good life after cancer. Physical restoration services, the rehabilitation department takes care of physiotherapy, occupational therapy, nutrition and financial support, which is very important. Nutrition is taken care of during therapy and also after. More than 10,000 beneficiaries have been supported in last 2 years with low cost or 50% of the cost of the prosthesis. Can you move the slide, please? It is not moving. The next slide. So these are the aids, like as you can see, psychosocial counseling, tailoring. They are given a government accredited tailoring course so that they can function and be self-sufficient wherever they go. Beautician's course, lymphopress for the lymphedema which can follow breast cancer surgery and radiation. We provide the low-cost breast prosthesis and vaginal dilators, which are very unique because the cancer cervix is a common thing, even for the rectal cancers and all, with requiring a pelvic irradiation in female. This is a very, very important to improve their quality of sexual life. Also, we conduct various sessions like yoga and other supportive measures, music therapy, art therapy for children, to make them go through this journey easily. As I mentioned earlier, that we are into research and registry, and this is our journal, Indian Journal of Cancer, and population-based registries which has started in Mumbai, but now we have many others in other parts of the country. Now we all know that Sir William Osler said that the good physician treats the disease, but the great physician treats the patient who has the disease. So we are trying to inculcate or spread the message that cancer is not only oncology care. There is a huge amount of non-oncology or supportive care which a patient requires to go through this journey. So this journey of cancer continuum can be successful only when you hold the hands, not only for treatment but beyond treatment, before treatment and beyond treatment. And we all acknowledge the fact that it takes a village. This is true, and this quotation is often true for the children when it says that it takes a village to treat a child with cancer. But I think it is true for everyone. You require support of your family, your extended family, your community, and society at large to take care of this disease. Thank you.
We sincerely thank you, ma'am, for delivering such an insightful talk. Ladies and gentlemen, may I request you to please join me for an heartfelt standing ovation to Dr. Professor Purna Madam in recognition for her extraordinary contribution in the field of oncology and lasting impacts on countless lives. Thank you, ma'am. We now continue with the prestigious VMRF oration. I would like to request Dr. Shona Nag Madam to introduce and invite Dr. Shailesh Srikhande for this address.
I know. Good morning, everyone. It gives me great honor and privilege to introduce our next speaker for the oration, Dr. Shailesh Srikhande, currently Deputy Director of Tata Memorial Hospital. He's an excellent GI and HPB cancer surgeon with over 2.5 decades of clinical and basic research in pancreatobiliary cancer surgery. He has an H index of 65. He's an exceedingly popular mentor, as we discussed this morning, and he's trained several capable students. I know him for the last few years, and we meet regularly at conferences. He has an exceedingly sharp intellect and is a very witty person. He's right now spearheading the new cancer center, the Hafkins, which is an 11.5 lakh acre state-of-the-art cancer center. In 2 years, it will double the bed strength of the current Tata hospital and will house 5 DMGs. I invite him to give his talk on common sense oncology.
Thank you, Shona, and thank you once again, Bhavna, for consistently ensuring that we all, from all over the country and beyond, end up in Raipur and experience the growth of the Balco Center as well as experience the fantastic hospitality. But what I don't like is the difficult talk that you give to a surgeon. But I have to now do that job as well, and I've tried my best to put together my thoughts to share with you about socialist versus capitalist oncology. I think the talk is a great one, and this would be one of my first talks, but I'm sure I'll be able to refine it in the years ahead. Now, the oncology world that we live in, it has 2 extremes. And the areas that we need to look at always for patients who have illness is in terms of quality. And apart from quality, we also need to know about accessibility and affordability issues. So you have in the upper half the conventional socialistic thought process, which is not a wrong thought process, by the way. We have generic medicines, we have cheaper medicines, we have conventional open surgery, traditional surgery, which has got more refined than ever before. It's not that surgery has just kind of plateaued. Even the traditional surgery, it's got far more refined than ever before. And then you have the standard chemotherapy backbones in the oncology world. You have something like minimal access surgery with laparoscopic surgery coming in 3 decades ago, and perhaps it's kind of juxtaposed where it's somewhere in between when it comes to quality, accessibility and affordability. But the lower half is where we have the challenges. You are challenged by technology, which is fascinating, which is addicting, for example, robotic surgery. And then you have precision oncology and newer molecules and immunotherapy and whatnot, which makes you outdated every few weeks in the world of oncology. Now, I'm nobody to speak or teach about capitalism and socialism, but broad thoughts. These are industry-driven technologies. The ownership is usually private. Goals are by and large individual, which is fine. Competition is immense, and that's good. And I won't say always, but quite often it can be focused on profit more than the highest quality of evidence. Generating evidence and gleaning evidence itself are two different things, and the ability to decipher and understand what is high quality evidence is another facet altogether. So when it comes to socialism, you have government ownership. You have perhaps a possibility to cut down competition. I would say it's less intense, it can be, unless you are very self-driven. The concept of shared wealth is good, very good in principle. Accountability can take a beating, and the focus is perhaps more on public trust, not necessarily evidence. So these are the differences between capitalism and socialism, broadly speaking. And before we dive a little bit deeper in the next few minutes that I have, let's look at the world we live in. So you just have about 24% of the world which has got upper middle income status, or upper income countries are only 3%. We all travel all over the world and we think that this is the world that we live in, but we are all living in an oyster. The ground reality is the kind of work that is being done by Bhavna and the Balco Center. That's the ground reality of a country like India, as I was having a wonderful chat with Mrs. Agarwal as well. The low-income countries and the low-middle-income countries is what the real world is, and India very much belongs to an LMIC. Some insights about the situation in India. You have the light blue and the orange bars telling you what's the situation in 2022. And then you have the yellow and the darker blue bars telling you the expected situation in 2030. Comprehensive cancer centers, as Sudeep said, we are building physical structures much better than ever before, and we will have many more. But look at how woefully short we are when it comes to radiotherapy equipment requirements of the nation. You might have some more radiation oncologists, but look at the medical oncology situation. Why do I highlight these things to you? This is also going to breed and feed into capitalistic thought processes as well, even if you want a socialistic outlook to handle things. You have surgical oncologists who are going to fall short. You have medical physicists who are also going to fall short as we try to chase and catch up with the rest of the world. You also saw Sudeep's excellent slide telling you about how India's population is going to be a challenge and how we are going to try and negotiate that, or is it always going to be a catch-up situation? We are worse when it comes to manpower, infrastructure and cost. You can see that the penetration of radiotherapy equipment per million population, look at the United States, look at India, look at China. Manpower, incidence per oncologist across countries. I always tell all my colleagues that you should never feel insecure in India. I only see opportunities everywhere, and there is too much of work to do actually. No one should be worried that I'm not going to get to work to do. There's too much of work to do. The other problem is literacy and education, and also awareness. You see the way the costs increase as the cancer goes from stage 1 to stage 3 and 4, just giving you an example of breast cancer and cervical cancer. There are multiple gaps in the patient journey. 77% have never undertaken or heard of screening. 60% of people are diagnosed in advanced stages, nearly half diagnosed by a GP, more than half, more than one consult to confirm a diagnosis, more than half no access to any support group, 46% with second opinion, lack of confidence in the initial diagnosis, 61% in such a large country prefer the private sector, 66% not aware of what's latest or what's ideal for them, 50% travel more than 50 kilometers away. We are all troubled by the distance between an airport and a hotel, and this is the ground reality of life. 64% no form of insurance, only 20% had a positive view of facilities for long-term care, and only 1 in 5 of cured patients have, poor quality of life post-treatment. And then we try to identify these gaps and try to address them. Bihar, Jharkhand, Uttar Pradesh, Orissa, and Assam are the top 5 states with the least penetration of comprehensive cancer centers. We do not have a single source of comprehensive cancer information. Like with many things in India, we remain fragmented. And then you have the problems of high cost of treatment and quality care facilities locally. Actually, a doctor close to home is the best doctor. But are we really there? No, we are very way behind. Now, what's the Tata Memorial Hospital philosophy? We want to have high quality, cutting edge, competitive with the rest of the world. We want super efficiency, come what may, and yet we are victims of our success, and yet we want to keep the costs down. Very idealistic, but ideology has been, let's combine a socialist ideology with a capitalist ideology. So in medical oncology, I want the best outcomes from my medical oncologists, but please give medicines with evidence-based approach. And evidence-based has become a fashionable word. Do you really understand how to study data or study statistics? I do not, a large part of it. I get empowered by sitting and talking with people who are far more intelligent to tell me how to understand evidence. That's one. Surgical oncology. Just because you have a hammer, everything should not look like a nail. Please do the right thing on every patient that you do, and always think, what would I want someone to do to me if I have a pancreatic, rectal, whatever tumor that you talk of. Rational use of radiotherapy, newer molecules and immunotherapy. You must have disease management group decisions which are truly based on something which is going to add benefit to the patient. By saying this, I'm not trying to make a political pitch, and I know we must become, someone where we manufacture our own things. So Atmanirbhar Bharat is what I completely believe in, and we will move in that direction in the next 10 years. But for that, I don't mean to say we must use only generic medicines. This kind of advertisements is terrible. There is heavy irrational discounts. Offering freebies is a political stunt. There is nothing which is for free in this world. All these things also lack international benchmarks and quality standards, and very often they may not even contain the parent molecule. Now we say we are socialistic, but the people who are offering this to the masses are actually capitalistic. We need to understand this, that you cut down costs so that you improve your profits. So you say I'm into socialism, but you are actually practicing capitalism. We should not forget that as well. And this is not necessarily based on latest and ever evolving scientific evidence. Let's look at medical oncology. You have expensive drugs in GI malignancies, and some of them will give you excellent benefits. And what is excellent is highlighted in white for you. Now the cost per cycle in INR is 3.62 lakhs. This is 362,000 if I were to talk in terms of the money required. But this is cost per cycle in INR. I want every doctor to know what kind of salary we earn per month for what we do. And it's nice and easy to prescribe drugs to tell patients what kind of an expert you are. But the ground reality is this. This is very hard-hitting reality, and these are the maximal benefits that I'm trying to give you as an example. And then I've highlighted in red about a tumor which is dear to me, a very aggressive cancer. I've spent almost the dominant part of my last 2.5 decades in pancreas surgery. And here you have 2.25 lakhs for a survival advantage which takes you to 4.2 months in locally advanced and metastatic pancreatic cancer. These are randomized trials. These are presented in ASCO. Then we go to ASCO, then we enjoy in ASCO. But this is the reality. Someone is paying for this somewhere. And this is not what we are supposed to be doing given the circumstances and the landscape that we are in. So it's also very difficult and very individual. How do you define what is significant survival benefit of newer agents? Statistics is one, trials is another, ground reality is another. Are we really justified on the background of catastrophic health expenditure? The next thing is, it's not just medical oncology, it is surgical oncology as well. Everyone loves this toy and it's addicting. That's the robot. And now you're going to get robots all over the place. Elon Musk has said that my career is going to end in the next 5 years. We will discuss over coffee, that will not happen, but still, the fact is that you have got much more refined technology, but much more expensive technology. And there is ever evolving evidence to support, and there is evidence to not necessarily support, but it again depends on how you read this evidence and what you want to read, what your mind wants to do. These are two different things again. So you have proven evidence just for this broad non-surgical and surgical audience, where everything that is resectional surgery with less reconstruction, minimal access surgery is here to stay, as we know, both with lap and with the robot. And then you have the gray zones, where the minute you have more complex reconstruction, the benefit of the minimal access approach somehow tends to go down, and it has multiple issues to it. One is who is doing it, how well you are trained, are you in the right place at the right time to get trained well enough. So there are multiple facets to what dictates the final outcome, but the end result today worldwide is an increase in cost. The good argument is that when robots become available in every nook and corner, the cost will come down. That's a good argument, but that's not the reality today as we talk about it. I've done some small studies to address some of the issues that we face. An old publication from our group at Tata, Bhavna was very much there at the Tata Memorial then, and you can see some of the highlights. Self-paying patients, 70% of them, only 29% patients insured. This is not NHS, this is not United States of America, this is Mumbai. You also have the problems not just in the public ward, but in the semi-private and private ward, patients moving towards catastrophic health expenditure for a complex operation which has a known morbidity profile of 20 to 30%, depending on how well trained you are in any corner of the world. More recent study from our group, prospective study, 244 patients of consecutive gastric and pancreatic cancer cases, less than 500 kilometers traveled, between 500 and 1,500, and more than 1,500. And you can start seeing how the non-medical catastrophic health expenditure increases. This is again the ground reality that we need to be aware of when we talk of capitalism and socialism. Look at distress financing, borrowing money, selling assets, selling land, selling jewelry so that you get care. I think what I'm trying to appeal to you is you need to have a conscience to know that are you really helping people or are you destroying lives? You need to understand this in terms of asking the right questions and offering the right treatment to your patients. 2-3 slides about surgery and my own perception, because this is our own work. When we talk of becoming an expert doctor, this is an example of surgery. You have learning curves not just in open surgery, but laparoscopic surgery and robotic surgery. And not just that, when you say a learning curve, there is a learning curve, there is a proficiency curve, and there is a mastery curve. So it's a lifelong journey the minute you choose to do a complex operation. And the learning curve involves so many characteristics. It's not that you do 20 cases with an expert or you do 5 operations on a pig and then you get a certificate to show on Twitter. That's not what I mean. This is the reality that you need to have. But if you do that in a standardized fashion, you might be able to minimize costs by improving outcomes. Minimal invasive pancreatic surgery, it's all over the world now. And we have tried to address who should be doing it, for whom, by whom, and where. These are important things if you want to avoid comparing apples with oranges and forming wrong conclusions despite we being doctors and so-called intellectuals. So you need to have a simple grading system, document data, compare data, and that's where I feel that in the next 5 to 10 years, the data has already started coming in. This is a recent publication which I have led for the International Study Group of Pancreatic Surgery. If we are honest enough to document our data, we will know what is the real worth of minimal invasive pancreas surgery. More expensive, Intuitive wants us to use it for every operation, but do I do it at Tata? I don't do it everywhere. A vast majority, 70% of patients will get open, conventional, high quality surgery, which is equally good, sometimes better than minimal access surgery, which we will also continue. So we will test modern technologies, we will generate the right evidence, but we will not allow ourselves as intelligent people to become slaves of technology, where our brain stops to work and we just become adept at using good toys that are available at our disposal. With that, I think I leave you with some thoughts about socialism and capitalism, and thank you very much for your kind attention.
Thank you, sir, for that thought-provoking and insightful oration, challenging us to rethink the way oncology is practiced and delivered. May I now request Dr. Alok sir and Dr. Divakar sir to felicitate Dr. Shikhande sir as a token of our deep respect and appreciation. We now begin with the keynote lecture. I request Dr. Shona Nag ma'am to introduce and invite Dr. Prashant Mathur sir for this address.
So good morning again. It gives me great pleasure to introduce Dr. Prashant Mathur, the head of ICMR NCDIR. He leads exemplary work on the prevention and control of non-communicable diseases using data management and analysis. He has been conferred the Clarivate Web of Science India Research Excellence Citation Award 2025. Dr. Mathur has been recognized as the top scientist in the medical and health sciences category with highly influential publications for the period 2019 to 24, reflecting the impact of his research at both national and global levels. He is also the first ICMR scientist to receive this distinction. May I please invite him to give his talk. Dr. Mathur.
Good morning, everybody. Thank you for that very generous introduction. And thank you, Dr. Bhavana Sirohi and the organizers of this conference for inviting me. It's difficult to follow on the very influential talks that we have heard, but I'll try to continue the pace and momentum and keep you excited about this. So this is about the India's National Cancer Registry Program, and Madam Kurkure, what you started from ICS has grown into a very organic system which systematically collects, and I think as all Indians, we should be very proud of our National Cancer Registry, and all your ICS registries are part of the National Cancer Registry Program. And this is another step towards making us Atmanirbhar, on data at least. So we are now 37 population-based cancer registries, and this National Cancer Registry Program was started by the Indian Council of Medical Research in 1981. It has grown leaps and bounds. So in India, cancer is still not a nationally notifiable disease, unlike the West, though some states have made it. So we have 37 population-based cancer registries, which you can see on your left of the screen, and around 340, 350 hospital-based cancer registries, and this number keeps increasing very frequently. So as I said, there are 17 states in India who have made cancer as a notified disease, the ones in the dark blue, though it is yet not a nationally notifiable disease. And so the Cancer Registry Program receives data from almost 8,000 or so data sources across the country, and represents almost all states and parts of the country. What the registry program does is to provide epidemiological insights. It doesn't solve a problem. So it is not an end in itself, it is a means towards an end. And this has a mix of very good population-based as well as clinical-based data sets. So I'll try to give you some exemplars of these areas which we do. And this is our latest paper, which has been published just about 3 weeks ago. And this is data from 43 population-based cancer registries. And the reason why not 37, why 43? Because 33 are operated by us from NCDIR, but 9 PBCRs run by the Tata Memorial Center data is also part of this. And the whole state of Tamil Nadu data is also part of this. And if we conclude all these 43 population-based cancer registries, this covers 18% of the Indian population. While 18 may look a very meager number, but for India, it's a very substantial number. Many countries can get covered in 18% of the population. And so this is the largest data set which has ever been published in the history of cancer registry. India is not one. So there is a lot of heterogeneity, and these are age-adjusted incidence rates for males and females. So I don't think so. On the y-axis are listed the 43 population-based cancer registries, and you can see that Aizawl in northeast Mizoram has an incidence rate of almost 250 per 100,000 population, and it keeps decreasing in men to Osmanabad Beed in Maharashtra, which is around 36. And similarly in female. So these are opportunities and these are challenges. Opportunities, because where it is low, we have to work to keep it low. Where the challenges are, where it is high, how to bring it down. So we have to work either way, even if it is low or if it is high. We looked at what has changed in India between 2004 to 2021, and we look at the disability adjusted life years, which is the burden of cancer. So clearly cervical cancer, which was number 1, has gone down to number 4. Breast cancer in females continues to maintain its position at number 2. But what is surprising is that in 2004, lung cancer was at number 10 and comes to occupy number 1 position. This is in spite of the fact that at population level and public health level, we are trying to increase our battle against tobacco. And there are survey reports to show that tobacco consumption is going down. But there is something else which is increasing, and that is air pollution, both indoor and outdoor air pollution. So as cancer people, our work is still not over. And this multimodality prevention is the call of the day. As per the latest figures from the National Cancer Registry Program, we have a crude incidence rate of 107.4 in men and 113.4 in women. This is against what Dr. Sudeep Gupta presented, world statistics, that they are around 200. So we are still at the lower edge, but it will not take us a long time before we catch up if we don't act now. And the cumulative risk of developing cancer till 74 years of age is 1 in 9 Indians. So 1 in 9 Indians is likely to develop cancer in their lifetime against competing causes. Now, this is against what in the US and Europe is around 1 in 3 or 1 in 4. Now, is this a challenge or this is an opportunity? It's both. How to keep it there and not let it rise. We distributed this lifetime risk to see between men and women what is the risk for leading sites of cancer. Oral cavity in men is 1 in 40, whereas in women it is 1 in 28. But breast cancer is 1 in 29 in females in India. And this is a lot of problems. Our breast cancer rate, total breast cancer incidence is 34 per 100,000, which is highest for all sites of cancer. So, number one cancer across both genders is breast cancer. Then we looked at projection or estimated for 2030. These are our estimates based on different sites. So, tobacco related cancers would contribute 47.8% of all cancers, whereas breast and cervical cancer is 20% of all cancer. We did not project till 2040 and all, because the longer the lens period that you are projecting, the more errors you are likely to make, and that doesn't help us. What are the estimated incidence and the top leading sites in 2024 in India for males and females? In males, oral cavity, lung cancer, prostate cancer. Now, prostate cancer 10-15 years ago was not even talked about as a public health problem, but this is rising very rapidly. And these are invasive cancers. So, cancer registry is collecting invasive cancer data. This is not just PSA-based data. So, there is a rise in the prostate cancer incidence rate, and for females it is breast cancer 31%, cervical cancer, oral and ovarian cancer. When you look at mortality, the leading causes of cancer deaths in men is oral cavity cancers, respiratory and liver cancers, whereas for females it is breast, cervix, oral cavity and ovarian cancer. What is the distribution of tobacco-related cancers? In men, it is contributing to 60% of cancers, whereas in females it is 35% of all cancers. The highest proportion comes from the mouth, lung and tongue. And so, if we as a registry are able to monitor sites which are tobacco-related sites, we will be able to monitor also where the impact of tobacco cessation is happening. We look at the clinical extent of disease at diagnosis, that means at before starting treatment, and what we observe is for breast cancer, localized tumors constituted 44. Now this is data from 96 hospital-based cancer registries. The loco-regional was 41.2%, and this is a significant increase which has happened in the last 10 to 15 years. Otherwise, we were seeing a localized of almost 20 to 30% only. So, a lot of our awareness and the good work many of you and other outside this room are doing in creating awareness and screening and early detection programs is showing results. Whereas in cervix uterine cancer, we still are grappling with a lot of loco-regional stage of cancer at diagnosis. But the most worrisome are lung cancers, where whether it is men or women, we do still have 40 to 50% in distant metastatic phase. And you all know the challenges of implications, including continuing into the talk what Dr. Shrikhande gave around capitalism and socialistic approaches. How do you tackle such a catastrophic cancer burden? We looked at population-based survival for cervical cancer across 11 registries, and the pooled data shows that it is 51.7%, which is around a 5 to 7% increase in the last 10 years. And you can see that how is the distribution, where Ahmedabad urban is 61.5 and Tripura is 31.6% 5-year survival at population level. Similarly, we looked for breast cancer, where the overall survival was 66%, which is again nearly a 10-point increase in 5-year survival. But there is a lot of variation and disparity in the survival. And we also looked at stage-wise survival across localized, regional for breast cancer, and if for localized it is 65.9, regional 53.5, and distant 18%. Again, a very good public health message that why we should invest in early detection, diagnosis, and treatment of breast cancer. Oral cancer survival paper also shows that overall was 37.2, the least and the poorest of survival amongst breast, cervix, and oral is for oral cancer. And there is a very notifiable difference between 55% survival in Ahmedabad to 22% in Manipur. We do see a lot of advanced stages which has a 4 times higher risk of dying compared to those diagnosed at early stages. Urban residents and younger adults tend to have a better survival rate. Now you can, discuss a lot about whys and what needs to be done and what can be done. Certainly do that, but as a registry, we can monitor whatever interventions you do at scale. We also looked at some histological patterns which are emerging. So 2 data points we took for lung and esophageal cancer, 2012 to 14 and 20 to 22. And there is an increase in adenocarcinoma and a decrease in squamous cell carcinoma being observed during this period, though the difference is not much, but does tell us something about changing etiologies. So even histological surveillance of cancer has implications on etiology, survival, treatment, and many more things which we can measure and report on. We looked at our cancer care distributed across type of hospitals. So we have public hospitals, which are tertiary hospitals, mostly medical colleges. We have the regional cancer centers or the tertiary cancer hospitals under the Government of India scheme, which are recognized as the tertiary cancer care hospitals, and we have the private hospitals. If you look at the treatment status, what is disturbing is that the brown bar, where no treatment was offered. So public 27.5, regional cancer centers 35%, private 32%. Overall 35% of patients did not receive cancer-directed treatment. Reasons? Many. Including in RCCs, when you talk to them, they say we always see very advanced stage, so we end up giving palliative. So we are losing opportunities, we are losing patients. We may be investing heavily on a lot of other things, but we are not maybe hitting at the right place. That was for head and neck cancers, and similarly you could see for breast cancer, cervical cancer, and lung cancer. I mean, the proportions are very high where no treatment was offered. Then we looked at some early data on molecular markers for breast cancer. And this is a data on around 76,000 breast cancer cases in females. Those tested for a hormone receptor, 70%, for HER2, 66%, for both 65%, and not tested 30%, who are not tested for molecular markers. And then we looked at those who had been tested. ER positive was 59, PR positive 51, triple negative breast cancer was 23%. There are many more combinations of ER, PR, and HER2, but I'm not depicting them. So testing and finding positivity rates we need to carefully observe, and the TNBC. So then we looked at how many of them were started on hormone therapy. If you look at overall, hormone therapy was given in 73.2%. And if you look at the breakup, it is 84% in public, 85% in regional cancer centers, but only 37% in private setup. This has some conversations to be made with insurance, with systems which can support hormone therapy. And it also talks about where it was not given in terms of looking at what can be done. Either the testing was redundant, or patients could not afford, or there are other reasons. Targeted therapy, 14% of the total HER2 positive cases were being put on targeted therapy. This is real world evidence. These are not trial evidences. We may prove efficiency, efficacy through trials, but in real world settings, we are not observing the same. Then we also looked at the ecosystem, at functioning tumor boards. Now again, divided that into regional cancer centers, public institutions, and private institutions. One regional cancer centers had a higher number of multiple tumor boards, and this disease specific or multiple tumor boards. This proportion decreases as you move across from public to private. Now, whether that is acceptable, whether it is too ambitious, I don't know the answer, but certainly it is a reflection on care. And once we do an analysis based on these survival and outcomes on this health system or the types of hospital, it will give us a more insight. But what is also worrisome is a large proportion of public institutions not having a tumor board. They don't have a tumor board. So what kind of decision making is being made for cancer directed treatment? So these are some of the snippets what I thought of sharing. And since radiotherapy is a very popular discussion, so we thought and we published this paper looking at in the BMC cancer, epidemiological analysis of radiotherapy utilization and its implication for cancer care in India, based on data from the NCRP. So this is evidence-based radiotherapy, optimal utilization, actual utilization, and the absolute gap. And we propose that we do not need to chase the WHO 1 per million target. We need at least 1.5 per million target to be chased if we have to achieve an equitable and an efficient distribution of radiotherapy. Based on this paper, there are discussions and initiatives being taken by the Ministry of Health and the Government of India to scale up radiotherapy procurement. And there is a big push through the Atmanirbhar Bharat's effort to bring more affordable radiotherapy machines into place. We looked at looking at hospital-based cancer survival data for breast cancer on 18,000, basically trying to show that those hospitals which are diagnosing early, whereas those who are diagnosing much later in stage 4, what kind of a survival pattern are we looking at? And female breast cancer, another female cancer is gallbladder cancer, and we looked at 3-year survival. from stage 1, which is 84%, and stage 4, which is 3.5%. But we don't talk of gallbladder cancer in many of our women-oriented discussions, partly because it is a problem in the northern belt of the country, extending from Jammu and Kashmir going into Assam, Tripura, not so much in the southern part of the country. But this is another women cancer which is neglected, and we do see a lot of distant metastatic cases at presentation, and survival is extremely poor even at 3 years. So, to summarize, registries provide real-world evidence which is collected systematically over long periods of time. They are vital tools for cancer prevention and control. They are useful indicators to measure cancer care and control. And for resource prioritization and allocation, and yes, data saves lives. There cannot be a more powerful system, a more powerful argument if we have to achieve a reasonable amount of cancer control. And I would like to end here and thank you all for your very kind attention and providing me this opportunity.
Thank you, sir, for that enlightening lecture and highlighting the critical role of cancer registries in shaping public health policies and national cancer control strategies. May I now request Dr. Yashwant, sir, and Dr. Gaurav, sir, to felicitate Dr. Prashant, sir, as a token of our gratitude and appreciation. May I now invite all our international guests to kindly join us on stage for a group photograph as a token of our shared commitment to advancing cancer care. Alok sir and Divakar sir, requesting your presence. Dipanjan sir, requesting your presence. I request Devendu sir, please join us on stage. On behalf of the organizing committee, I sincerely thank our chairpersons for their valuable time, guidance, and for moderating this session and setting the tone for meaningful discussions. Ladies and gentlemen, with this we conclude our inauguration ceremony. we thank all our dignitaries and all of you for your gracious presence and encouragement. We now look forward to your participation in the scientific sessions ahead. Thank you. So now we move on to our scientific session. I would like to invite the chairpersons for this session. Dr. Anand Mukund Kekre sir, he's the ex-joint director MHS, PTJ JLN Hospital and Research Center in Bhilai. Dr. Moiroy ma'am, clinical director, surgical oncologist at Sanjeevani Cancer Care Hospital, Raipur. Dr. Devendra Nayak, gastro and laparoscopic surgeon and medical director at Sri Balaji Institute of Medical Sciences. Dr. Siddharth Nanda, professor and head of radiation oncology at AIIMS Raipur. Dr. Rajiv Ratan Jain, sir, associate professor, radiation oncology, Regional Cancer Center, Raipur. And Dr. Yusuf Memon, sir, oncosurgeon and director, Sanjeevani Cancer Center, Raipur. Dr. Saroj Sahu, Director, Surgical Oncology, Shankara Bagchi Cancer Center, Bhubaneswar. I would like to invite our chairpersons for this session, please. Dr. Devendra Nayak, sir, gastro and laparoscopic surgeon and medical director, Sri Balaji Institute of Medical Sciences. In the interest of time, I would request the chairpersons to ensure that we stay on schedule, please. Thank you. Now we have an important talk on precision approaches to treating biliary tract cancers, supported by Servier. May I now invite Dr. Milind Javle, sir, Professor of GI Medical Oncology at MD Anderson Cancer Center, Houston, Texas, where he leads the biliary cancer program. Dr. Javle is also immensely passionate about democratizing cancer care in India to share his expertise.
Thank you very much. You know, I attended the wonderful talks this morning, and I was listening to Shailesh talk about the economics and people beyond earlier. These issues are universal. In fact, in the US, 60% of bankruptcies are because of healthcare. And the fact remains that we have to do both things. We have to improve primary oncological care. Bhavna runs a fabulous molecular board every week, and I've attended some of them where people carefully look at molecular alterations, use whatever is available here in India. So I think both approaches need to go hand in hand, and I'm really excited that we are on the forefront of the journey with precision medicine as well as in primary oncological care. So my talk is on new frontiers in biliary tract cancer. I shall try to be brief. Because this is a relatively focused area, I'm going to talk on three topics. One is how do you diagnose this cancer accurately, because patients unfortunately undergo through a long journey before the diagnosis is ever reached. What happens in immunotherapy? Are there some categories that respond better? And I'm going to give you some experience from our group. And then targeted therapy. What have we learned from our first generation of targeted agents? A lot of this work has been done by juniors who work with me and other institutions, so I'm really proud for what they have achieved. So first of all, biliary tract cancer is recognized as three different diseases: intrahepatic cholangio, hilar cholangio, as well as gallbladder cancer. The diagnosis of intrahepatic cholangio, that is a small duct cancer, it's a diagnosis of exclusion. You look at The pathologist calls it adenocarcinoma, and you look at really a pattern of immunohistochemical stains, such as CK7 positive, CK20 positive or negative, and exclude other things like liver cancer, breast cancer, and so on. So there is no need for multiple tests and endoscopies and PET scans because the diagnosis lies really in pathology. This is even more complicated when you look at hilar cholangiocarcinoma. So as you can imagine, this is the cancer right here in the extrahepatic bile duct. Getting a diagnosis is difficult, and in fact, we shouldn't do a biopsy because there's a risk of peritoneal seeding. So the diagnosis is one of those rare situations where the diagnosis is made clinically by the presence of a stricture, presence of high CA19-9, a mass, or polyploidy. So these are some 2 points that I love to make in any talk, that the diagnosis of this cancer is challenging, but it's relatively simple, and patients don't need to go through an unnecessary journey of diagnostics. Having dealt with this disease for really almost 2 decades, it's been a very exciting journey because before 2020, we really had nothing approved. We used drugs that we used in colon cancer, in pancreas cancer and others. But since 2020, there has been a host of new agents approved with the FGFR, IDH1, HER2, and many other molecular targeted drugs. So this has become like a sort of like a non-small cell lung cancer in GI malignancies with a lot of pharma attraction, which never happened before, and that has improved care. What has changed remarkably over the last 3 or 4 years is immunotherapy, and we have 2 drugs now approved. One is durvalumab, a PD-L1 inhibitor, and pembrolizumab, a PD-1 inhibitor. Now you're all probably familiar with this study, which was first-line study with GemCis and Durva, followed by GemCis versus GemCis. And this showed that the PD-L1 inhibitor resulted in improved survival. This was modest. You would think like 2 months, 11 months to 13 months, but there's a tail in the curve where 25% of patients have disease control at the end of 2 years. So this is a real gain. This has been confirmed now at 4 years, where you see a continued improvement that occurs. Now, what biomarkers do we have? We know that PD-L1 is really not prognostic in this disease. What we have been working on in our institution and others is to look at the impact of fatty liver, now called as metabolic associated steatotic liver disease, or MASLD. So this is the rising incidence of cholangiocarcinoma that is in the blue line. These are the numbers we see at MD Anderson, which are large. And we feel like there is a strong link between obesity and the link and intrahepatic cholangiocarcinoma. In fact, right here in India and China have the most rapid increases in MASLD or NASH or fatty liver. We don't really know why. Perhaps it is because what we eat now is not really appropriate for our constitution, or things have changed over years. Now, we have been investigating this for a few years, and this is some work done by Ricky Dahatia and Madhu Illuri, who are our fellows, and they looked at what are the risks for cholangiocarcinoma. One of the biggest risks we found was early adulthood obesity. That is, people who are overweight before the age of 40. These people are at a higher risk for liver disease, not just cholangiocarcinoma, but liver cancer, cirrhosis, hypertension, diabetes. So we decided to dive into this further. Our current postdoc, Sven, who is actually from Balco, he looked at what is the impact of metabolic associated steatotic liver disease in patients who get immunotherapy. So he looked at over 600 patients who got immunotherapy and looked at the impact of MASLD. You found that actually there is an inferior survival in patients who have fatty liver or MASLD with immunotherapy. Now, patients who have fatty liver or MASLD and then who have diabetes have a higher risk for fibrosis. These patients have even a worse survival. So then we looked at what actually is happening at the cellular level in immunotherapy with fatty liver. Why are these patients actually, is there something that you can look at the single cell level or at the transcriptomic levels? So this is work done by another fellow, Nakul Shah, And he looked at at the transcriptomic level. This is the tumor that you see in red. You see the blue and the green are colored myofibroblasts or cancer-associated fibroblasts, and the immune cells are represented in orange. Basically, what the figure shows is that the immune cells are prevented from getting into the tumor in muscle D because of these myofibroblasts and cancer-associated fibroblasts. If there's a way in which we can target those, likelihood that immunotherapy response may be perhaps improved. Clearly, the money here is also in precision medicine related to molecular targeting. So we have been doing molecular sequencing at NGS and MD Anderson long before any drugs were approved. So this was over 400 cases. We found that intrahepatic, extrahepatic gallbladder have different molecular genetic profile. These papers are also now coming out from India. I saw a nice paper now by Mohshami and others, which will soon come in JCO Global Oncology, where we need to know the patterns of these mutations in the different types of biliary tract cancer. One of the first drugs to be approved in this place was ivosidenib, which I'm proud to say was now approved in India as well over the last few months. So this is because this was approved to target IDH1 mutation. Where in the presence of IDH1 mutation, you have alterations with high level of 2-hydroxyglucarate and altered epigenetic regulation. This was investigated in the Clarity trial, where patients who got GemCis were treated second line with either ivosidenib or placebo in a crossover design. And then they looked at what was a progression-free survival. That improved very modestly, but it was positive. But what got the drug the approval was that 25% of patients had disease control at the end of 1 year, and these patients often had disease control at the end of 2 years. So it's a real benefit that occurs in about a quarter of patients. These patients who have long-term tumor response, tumor control, also are likely to have partial responses, tumor downstaging. Several groups, including ours, then looked at what is the mechanism of resistance to ivosidenib. So this is a patient, for instance, illustrated who had a nice response, and then why we do biopsies afterwards, like liquid biopsies and post-treatment biopsies. This shows that there's isoform switching, where in this case IDHR132, which is arginine residue substituted to cytosine at position 132, was altered to IDH2. So there is an isoform switching, which may be perhaps regarded as targetable. But then we also looked at who are these 25% of patients who actually do well. So this is my junior colleague, Dr. Lee, who looked at the profile of these patients, and he looked at two sets of mutations, that is epigenetic chromatin modulating genes like ARID1A, BAP1, and showed that those genes are more likely to be associated with disease control. And by reverse, PMF genes, which is PI3 kinase, AKT-mTOR, are associated with a worse outcome. So why are these factors important? Because we know that these cancers are do not respond to a targeted therapy in a linear fashion. You have to look at concurrent mutation profile. So I think if there's one lesson I can discuss with you today is that we don't just look at the gene and the effect, but we also look at the environment, both in the tumor and the liver, and what other genes are altered and how they may impact the overall disease outcome. So these tumors are also immune depleted. So this is some work done by another fellow, Shalini Makavida, who showed that these tumors are immune depleted. MSI high is likely to be low, TMB is likely to be low, and these tumors are in fact an immune desert. But when they are treated with ivosidenib, it increases PD-L1, other checkpoint inhibitors. So you probably consider that maybe ivosidenib makes the tumor more immune responsive. In fact, in a series of very nice experiments done by Nabil Bardisi at MGH, he showed that inhibition of 2D by ivosidenib increases T cell recruitment, makes the tumor perhaps more immunogenic. This is a basis for now combining ivosidenib with immunotherapy in the first line setting. I'm going to quickly move on to FGFR. This is some work done by Apurva, who was a fellow who worked with me. She first showed that these tumors occur in earlier stage of disease, in younger women, and have a better prognosis. These tumors, the FGFR alterations in cholangio, are typically characterized by FGFR fusions, and these fusions can be targeted with small molecule inhibitors. This was the first study done by a group with a drug called infigratinib, and then subsequently 2 more drugs are approved called pemigatinib and furibatinib. I think pemigatinib is now available in India. So again, this feature of what is the impact of concurrent mutations. So this was a study done by Silverman and others in Cancer Discovery, showing that TP53 has a worse outcome. There's a profile of mutation, tumor suppressor mutations that have a worse outcome. So again, I think we are learning how evaluation of the molecular genetics report beyond the primary mutation may impact its outcome. I'm going to move on to acquired mutation and causes of resistance. We know that pemigatinib, infigratinib, furibatinib, once given, after a while, acquire a panel of mutations which makes the drug resistant. There are drugs being developed in the second-line FGFR space, one called tiningotinib, which is effective against these mutations. So tiningotinib has been shown to be effective now in patients who have prior treatment with FGFR inhibitors, and I won't belabor this. This will be presented in ESMO in a couple of weeks, which showed that it is effective in the second-line space. Again, the inhibition of FGFR might result in the tumor becoming more immunogenic. Again, this was shown by my colleague, Dr. Sangeeta Goswami, showing that neoantigens are increased with FGFR fusions, and treatment with FGFR inhibitors can result in increased lymphocytic infiltration, making the tumor more immunogenic and perhaps responsive to immunotherapy, although this remains to be proven. In the last few minutes, I'm going to talk about HER2-directed therapy. This was a study we did with collaborators at Chile, which showed that HER2 amplification occurs in 15% of patients with gallbladder cancer, and they can be targeted with trastuzumab, pertuzumab, really an equivalent response that you see in breast cancer. Also recently by my colleague, Dr. Shubham Pant, with the zanidatamab study, and most recently also by trastuzumab deruxtecan, which shows a very nice response in a pan-tumor study in biliary tract cancer with HER2 3+, showing a very nice response. So this has now led to a phase 3 trial in the frontline setting of patients with HER2 amplified biliary tract cancer who will be treated with either Enhertu, Enhertu plus TIGIT, or then gemcitabine, cisplatin, and durvalumab. So I'm going to conclude my talk by really putting a pitch on precision medicine and why precision medicine is important and why why every patient matters. And I'm just going to tell you a short, small story that I found online that I love. I live in Texas, Galveston is where all the oil rigs are. We find lots of dead fish on the beach every day. So this is a story of a young boy who was a man who was walking along the beach, and then he sees this boy picking up the starfish. There were many dead starfish or dying starfish, and the boy was picking up one fish at a time and putting it in the ocean. And then this man asked, "Young man, what are you doing?" And the boy said, "Well, throwing this starfish back into the ocean because the surface is rising, the tide is going out, and if I don't put the fish back into the ocean, they're going to die." So this man laughed to himself and he said, "Don't you realize that there are miles and miles of beach and thousands of starfish? How are you going to save them all?" So after listening politely, the boy bent down, picked up another starfish and threw it into the surf, and then throwing and smiling at the man, he said, when he throws that one fish out of thousands, I made a difference. It made a difference to that one. So I think that this is what precision medicine is. The difference matters because everyone matters. Thank you very much.
We thank Dr. Javli for sharing cutting-edge perspectives on precision therapy in biliary tract cancers. We now move on to the panel discussion on GEJ cancers and gastric cancers. For this, I would like to invite our moderator, Dr. Senthil J. Rajappa. He is consultant medical oncologist from Basavtaram Indo-American Cancer Hospital and Research Institute in Hyderabad. Along with our eminent panelist, Dr. Prashant Penumedu, Medical Director and Head of Department of Surgical Oncology, Sri Venkateshwara Institute of Cancer Care and Advanced Research, Tirupati. Dr. Ajay Varun Reddy, Senior Robotic Surgical Oncologist and Consultant Surgical Oncology, Medicover Hospitals. Dr. Manali Patel, Senior Consultant, Critical Care and Palliative Medicine, Indian Spinal Injury Center, Delhi. Dr. Amit Jotwani, Senior Consultant Radiation Oncologist from Hyderabad. Dr. Nishita Shetty, Professor, Medical Oncology, Father Muller Hospital, Mangalore. Dr. Rakesh Mishra, Medical Oncologist, Sanjeevani Cancer Care Center, Raipur. I would request Dr. Senthil sir to take the session forward.
Okay, so thanks and good morning everybody. Looks like we have to take an attendance of people who are in the panel and people who are not in the panel, people who have been added afresh, whose names I don't have on my list. Can you please give me an edited list by the time I start my panel, because this is becoming a huge challenge. Right, I'm serious about what I'm saying. I need a fresh list of panelists with who are medical oncologists, who are radiation oncologists, who are surgeons. Okay, so that it becomes easy for me to do my job. Right, so the theme of this conference is choosing wisely, and I'm sure our panelists will make wise choices. So this is what I felt when I saw the list of panelists a couple of days ago. And the initial set of panelists was 6 surgical oncologists, 1 medical oncologist, 2 radiation oncologists in a panel on locally advanced gastric cancer. And I was the only medical oncologist, right? So I'm glad that there are a few more lions and lionesses here, and there are, it's probably a better playing field. Okay. As
Can I interrupt you for a moment? I would like to invite Dr. Swapnil Patil, sir. Surgical oncologist.
Surgical oncologist.
Please, sir. Yeah.
Okay, Dr. Pushpendra is not there? No, he's not there? Okay, so get me an edited list, please. Till then, I'll call upon people. Ajay is there, Prashant is there. I know some faces, I don't know most of the faces anyway, so never mind, it's all right. Okay, so as I'm getting the list, this is a case that I will use to illustrate a few things. I've got 3 case scenarios which I put up in the group earlier. We'll try to discuss how to choose wisely in each of these 3 different case scenarios. So here is a 75-year-old male, a non-smoker with dysphagia of 3 months and 10% weight loss. He's presently 88 kilos. He's a diabetic, he's a hypertensive, he's got coronary artery disease, a PTCA done 10 years ago. His DPD is wild type. He's got a geriatric assessment done and he's fit to undergo whatever treatment is necessary. Oh, you're not able to see? Oh, you've got only 1 monitor there. Okay, right. So that's the endoscopy picture. So it's lower esophagus, just getting onto the GE junction. And here you see the pathology report, which says that it's an adenocarcinoma, signet ring cells, and some mucinous areas there. So lower esophagus, GE junction with adenocarcinoma, some mucinous areas, signet ring cells. So that's the PET CT. Don't bother. It's a typical medical oncologist way of choosing the pictures. The brighter it is, the better it is. So you see that I've highlighted a few things on that report. It's a lower esophagus, GE junction, bulky mediastinal lymph nodes. There's also a perigastric lymph node. There is extension of this growth up till the GE junction. So we'll take it for all practical purposes as a GE junction cancer, because this is the case that I could lay my hands on in the past couple of days. So let's start. Prashant, staging laparoscopy, I'm sorry. So we'll have short answers to questions because we're running short of time. All patients, some patients, none of them.
Majority of.
Your mic is not.
Majority of the patients would undergo staging laparoscopy, and locally advanced, all patients.
Okay, locally advanced. Let's say if you're doing perioperative therapy, you would prefer to do?
If you're doing perioperative, then 100%.
100% for perioperative. Okay, so this is locally advanced, so we will generally do perioperative therapy, so 100% ideally should get. Dr. Swapnil, in your practice, what percentage actually end up getting a staging laparoscopy?
So in my practice, I am currently in a private setup, so I can...
The mic closer, please.
So I can post patients as per my will, and the list is not a problem, and operative time is not a problem. So I would send most of these patients for staging laparoscopy.
It happens?
Yes, it happens.
Lovely, it happens. So ideally, we would do staging laparoscopy, but in reality, at least I can speak for my hospital. Some patients get it, not all patients get it, but we are slowly moving towards doing staging laparoscopy if possible for all patients who undergo perioperative treatment. Ajay, who should get upfront surgery? Not necessarily locally advanced, in general.
In general, this patient I wouldn't go for upfront surgery, but ideally T1, T2 node negative patients probably you can consider for an upfront
T1,
surgery.
T2, what about bleeding, obstruction and all of those?
Bleeding, you mean?
Tumor
bleed, I still would, if I can salvage them and then go for chemotherapy, I still would suggest because this is a node
You all
positive
seem
disease.
to be loving the medical oncologist. Excellent, I'm happy with that.
Tumor perforation is definitely, you have to go
Okay,
for surgery.
perforation, obstruction, bleeding,
And-
all of these very early tumors would go for surgery.
But there was one thing I wanted to point out.
Yeah,
This
please.
Technically is actually a lower esophagus. The epicenter is actually somewhere up.
So that's
More
why I said
importantly,
for all practical purposes, because I couldn't get another case, we'll take this as a GE junction. Okay? You're right that it is predominantly lower esophagus, but for today's discussion. Okay, so let's ask Ajay again. Ajay, why do you want perioperative therapy?
because one thing it is shown in trials that there is definitely a survival benefit. To
Which
giving
trial? Which trial? Which trial has randomized patients to perioperative versus all of them neoadjuvant versus all of them adjuvant and shown that there is an overall survival benefit to doing perioperative therapy?
At least in the lower esophagus or esophageal and G junction cancers, there are trials perioperative versus surgery alone. There are trials now with the type of perioperative, FLOT versus the previous standard of cross as well.
Correct. So it's comparing two perioperative standards.
Correct.
Right? So the point is that though all of us have moved towards perioperative therapy, there are no clean trials which have really done only perioperative versus adjuvant with the same treatment delivered preoperative versus adjuvant. Unfortunately, all of these trials which have done perioperative versus adjuvant only are biased towards more treatment, more drugs given perioperatively compared to just adjuvant. But you're right that we have moved quietly towards perioperative therapy because we think better resection, better margins, all of those things. So, but the point is that there are no clean studies which have tried to answer this question at all. So that's something that we need to keep at the back of your mind. Okay, medical oncology friends, Rakesh, any biomarkers that you would do for this patient with locally advanced, let's say, GE junction cancer?
So in all locally advanced gastric GE junction cancer, we go for the MSI testing, sir.
MSI testing, okay, lovely. So what about PDL1, HER2, Claudin, all of those?
So not in case of locally advanced.
Not in cases of locally advanced, so you would do only MSI. What method do you generally follow? IHC, PCR, NGS?
Sir, I do prefer IHC.
You would do IHC, okay, excellent. So that's the only marker that we would use to make some decisions in this setting, so that's absolutely fine. So all patients who go for perioperative therapy ideally should have a laparoscopy staging procedure. Some patients get upfront surgery, T1, some T2s, and patients who present with some complications. Perioperative therapy is where we have moved to, though there is no high quality evidence to say that every single patient should get perioperative therapy. Biomarkers, we've said we will do MSI. So we will now move on. Okay, scenario 1. This 76-year-old diabetic, hypertensive, coronary artery disease has got good cardiac function, good lung function. He is ready to take FLOT surgery and can afford anything under the sun. What should be the ideal treatment for this patient? I've given you some choices there. Perioperative FLOT, Matterhorn, which is FLOT durvalumab, cross, one of those modified perioperative treatments, S1 oxaliplatin and all, or anyone in the panel has got a different idea. Dr. Nishita, what would you offer this patient if he came to you? Your mic is not working.
So you've told me his geriatric assessment.
Yeah, lovely, super.
So for him, even if a good geriatric assessment is done, I would not offer FLOT.
Okay.
And my go-to regimen would be Folfox, maybe cycle 1. Even if the DPD is negative, I would offer him a reduced dose because of his age and his comorbidities.
The DPD is wild type, so he can tolerate whatever
so
5-FU
my
you
go-to
want
regimen would be Folfox or Capox in him.
Okay, so you would do Folfox, Capox.
Regarding the Matterhorn, I think I am not aware of the PDL1 status, so I would keep it inferior.
Okay, we'll come to Matterhorn and the PDL1 in a moment. Rakesh?
Sir, here also, sir, I'll go with the Folfox, sir.
Okay. Okay, so we are a little apprehensive in giving FLOT to a patient who's 76-year-old with hypertension, diabetes. Prashant, if these were your two medical oncologists, would you push them to give FLOT?
No, not in this patient.
Not in this patient.
I generally leave the decision to the medical oncologist. As a surgeon,
Lovely.
I wouldn't interfere.
Lovely, excellent. That's a nice, one of the choosing wisely, I suppose. Right, leaving the decision
in
to the
team with the
medical
conference and in real life too.
Okay, excellent. Very good. So both our medical oncologists want to choose a attenuated version of perioperative treatment rather than, okay, suppose Nishita, suppose I say that the PDL1 CPS is 50, would you do durvalumab with plus Folfox?
I would still watch for Folfox because I think with Durva, the OS data is still not like...
But is there data with durvalumab and Folfox?
No, that is with FLOT and Durva.
585 looked at a non-FLOT regimen and they couldn't prove overall survival, or they couldn't prove even a statistically significant event-free survival, right?
Yeah, I think they wanted to keep both the arms stronger, and FLOT is the standard of care. So maybe they wanted to just check with addition of Durva and PDL1 positive, does it really make a difference?
Okay, so we'll leave the PDL1 aside. Since you asked for it, I gave you a number, but there's no data with Folfox and durvalumab. 585 looked at a non-FLOT regimen, 5-FU platinum or a oxaliplatin 5-FU based treatment with immune checkpoint inhibitor, did not give you an event-free survival benefit. So if you're using durvalumab today, for whatever reason you decided to do it, PDL1 positive, negative, it is with FLOT, not with any other regimen. So that's the reason why I asked you this question. I think our medical oncologists are absolutely right. It's a little daisy to do an intensive FLOT regimen in somebody who's 76 with multiple comorbidities. This is some data on patients more than 65 who took FLOT. The mortality of FLOT in somebody who's 70 plus is about 3%. Now this is from Western centers. So we need to be extremely careful. A lot of patients don't end up completing their treatment. So if you've got a 75-year-old with comorbidities and all the other baggages that our patients come with, it's very important to make that wise decision of discussing a non-FLOT regimen. So I'm glad our medical oncologist did that. So for people who are wondering what this Matterhorn is, this is what Matterhorn is all about. The curve at the bottom is something that I've drawn to try and illustrate what the benefits of adding durvalumab relative to the earlier increment that we did from ECF, EOX to FLOT. So remember that when you're looking at a curve like this, you have to understand that a lot of patients don't need this intensive treatments. Some patients need more treatments. Just durvalumab or FLOT is not good enough. When we jumped from ECX to FLOT, that is the number needed to treat. You needed to treat 6 patients for 1 patient to prevent a recurrence. But when you're going to the addition of durvalumab, you need to treat 12 patients in order to get 1 event prevented. So as we are climbing up, the incremental benefit starts going down, and the number of patients that you need for 1 patient to benefit keeps increasing. So let me get back to Rakesh. Are there some patients that you think of benefiting from durvalumab? How would you choose? This is the forest plot for your reference. So is there anybody whom you would say, you can clearly point out and say, this patient is not likely to benefit from durvalumab, so I'm not going to use this treatment in that patient?
So, sir, definitely, sir, PDL1 positive patient, they actually do get benefit with the adding durvalumab, and the cost is not an issue. Data is good enough to convince me to go for the additional therapy if patient can afford.
So do you think, based on this forest plot, patients with PDL1 negative don't benefit? Is that your interpretation of this forest plot?
Sir, actually, the thing is that the numbers are less.
Lovely.
So,
Okay. So numbers are less so?
So you cannot comment that this group of patient will get how much benefit they got from the durvalumab. So definitely in these patient, I am little skeptical to use durvalumab.
Okay, so you may say that this is inconclusive, but you can't conclude based on this forest plot and the wide confidence intervals on a small number of patients that you're seeing that it doesn't benefit. I don't think there is a single subgroup in this where you can definitely say that the drug actually does not benefit.
So
I'm not pushing for Matterhorn.
Sir, another very interesting point actually, I want to highlight the diffuse variety. Diffuse histology.
Okay, so let me ask a question then. If somebody, you got a 70-year-old with a diffuse gastric cancer with a PDL1 that is negative from Asia, if that's your interpretation of this, would you use durvalumab or not? Multiple factors based on this forest plot that seem to be benefiting less. So how do you choose wisely in that patient?
So yes, I'll do not, if cost is not a concern, I'll use them. But yes, if these features are there, I do not push them to go for the dual.
Okay, excellent. That's a nice answer. So if you've got multiple factors that you think don't seem to be in favor, then you won't push. If you think there are multiple factors, a GE junction, an intestinal, a PDL1 CPS of 50 and all of those, then you would push.
Yes.
Okay, so push versus not push depending upon some of these characteristics. So this forest plot does not tell you that any subgroup does not benefit. So this has to be very clear, but it tells you that the push-pull is in some directions, but those directions are by no means conclusive. But interestingly, the NCCN's recommendation is not yet FDA approved, but the NCCN's recommendation is that you use it for patients who are PDL1 positive. For the first time, I'm seeing a narrow endorsement from the NCCN. NCCN usually will say use it for everybody, right? It's usually the Europeans who will say based on PDL1 or some biomarker. For once, you're seeing that the NCCN has narrowed the indication down to, I think the problem here is that this trial is not representative of patients who are PDL1 negative. So that's the way I would look at it, because only about 10% were PDL1 positive. So that probably is what I think went on in these people's minds when they made this endorsement, not because they think it does not benefit. So we leave it at that. So in a patient like this, you need to be very careful. So these are some reasons why I think Matterhorn passed the test, while Keynote 585, a very similar study, actually failed the test. You need to use FLOT if you want to use durvalumab. There's something called as exhausting the P, which, in 585 people did. PDL1 and then lesser patients completing protocol. So that's what it is. So for me, guys on the panel, I'm going to read what I thought was choosing wisely in a patient like this. You can differ. You can tell me if you differ. Perioperative over chemoradiation followed by surgery. Okay, so that's the first thing. Beware, as my panelist rightly said, FLOT in a 76-year-old man can be a huge challenge. Strongly consider a non-FLOT regimen. There's no randomized controlled study to compare any one of these perioperative to cross and say that it is superior to cross. If you're not doing FLOT, you don't do durvalumab. There's no conclusive lab or clinical parameter to choose or not choose Matterhorn over the other strategies. So do we have agreement on this?
Yes,
okay,
sir.
Excellent. All of you are nodding. Scenario 2, same patient. Borderline cardiac function, 49%. Performance status is 2. Patient and doctor probably are unwilling to do FLOT. Dr. Manali, you're a palliative care physician. How would you, optimize this patient and then make him fit for treatment? I know it's a surgical question, but probably you're also involved in part in doing that. So what would you do? Your mic, please.
Yeah. Optimizing this patient would be...
I can't hear you. Into the mic, please. Pull the mic closer to you. Yes.
Optimizing this patient would be a challenge.
Okay.
because of the age, because of the comorbidities. So definitely before considering new therapy for this patient, more therapy might be more harmful.
More therapy might be more harm. Excellent. So that's why we've got this big list of treatments put up there. So cross followed by surgery, perioperative, not FLOT, it's a slightly modified version of FLOT, S1 OX, definitive chemo radiation. And then if the surgeon states, start chemo and then let me decide later. Ajay, would you do that? Say, tell your medical oncologist, okay, start, let me see after 3 months and then let me decide what I want to do. Would you do something like that in a patient like this?
There could be some scenarios in that, but not in this case.
Not in this case.
I would, it's the same patient with the same
histology. It's the same patient, but he came back after 1 month, same growth, but is PS2 now.
I'm tending towards a definitive CTRT because he already has a borderline cardiac function, which plus 76, and I'm really not sure if he'll tolerate the classic transthoracic esophagectomy that we're going to do.
Excellent.
So also considering that fact, he is a signet cell, I'm not sure that we'll get a complete response, but still.
That's the best bet.
That's the best way forward.
Your thoughts?
Definitive CTRT, I'm not sure whether this patient would actually tolerate.
Okay.
That is because performance status 2, EF of 49%, and he has deteriorated over a period of 1 month, as you've said. So I'm not very sure whether, and I'm also not sure, let me start chemo and then take a call later whether he would really tolerate surgery at that point. Because the pathology isn't a good pathology here. You see a signet ring poorly differentiated. We know that the response to chemotherapy is poor. And it's less likely that he's going to show a dramatic response because even with he's not fit for FLOT, and maximum, I think probably you must be looking at FOLFOX or SOX or modified regimens where the response isn't that great. So I don't feel that this patient would come on table.
Okay, so this patient is unlikely to come on table. Amit, all yours now. So what would you do? What would you tell this patient?
I would refer to my surgical colleague whether they want
surgical
to go
colleagues,
for
both of them have said what they want to say.
So cross, I would go for a slightly higher dose. Cross didn't do justice to the radiation dose.
So how much would that be, and what is the likelihood of getting a complete response with whatever dose you're referring to?
Various studies have reported even higher pathological complete response with at least 45 gray.
Okay.
So I would rather go for at least 45 gray in this patient. With modern techniques, we can achieve better dose distribution and lesser toxicity compared to older techniques.
Would you go to 50 gray? Would you go to 50? 50 gray, I said. 50 gray, I said.
I will definitely assess at 45, and if my surgeon is not sure he would be able to operate, or if it is definite, going towards definitive, I would touch 50-40.
Okay, so you would assess at 45 gray, surgeon says no, you would go to 50 gray. If surgeon says yes, you would stop at 45 gray and send him for surgery. Okay, so let's come back to our surgeons. Swapnil, would you agree with all that your surgeon colleagues and our radiation colleague has said, or would you say something else?
The patient is not fit. I don't think so. As Dr. Prashant said, that patient is less likely to ever come up on table. So I don't think so. We should be pushing for it, and we should be upfront telling him all the available options, and probably highest palliation may not be a bad option to begin with.
Okay. Prashant, let me come back to you. You know, a lot of things discussed about this SANO study and, just doing chemo RT, and then if they've had a complete response, leaving patients away without doing surgery. What are your thoughts on that? Because that's something that we would start discussing in a patient like this, right? Let's do chemo RT, see if you get a complete response, let's leave it. If you don't get one, let's see if we have to push to get surgery done.
Yeah, I think such patients are ideal for SANO approach.
Okay.
Because, when we know that they're able to borderline for surgery. So if this patient did not have a major subcarinal node.
Right.
And, I might have considered with some perioperative, at least a transhiatal, which is a lesser morbid surgery when compared. Now that with a 3.5 centimeter node in the subcarinal, there's no point just doing an esophagectomy and leaving the lymph node basin.
Very nice.
So and my concern here for definitive RT is the large subcarinal node that you are actually seeing. I know it will get covered in the field of radiotherapy, I'm sure about that, because it's a lower third. If it is a purely GE junction type 2 or type 3 with the subcarinal, the approach would have been different. So I would still go for Sano approach in this patient if the radiation oncologist is comfortable, if my radiation oncologist is comfortable. Yeah, I'll take care of all those things. The problem here is patient also has a perigastric node.
Right, a small one though.
A small perigastric node, which is a significant uptake on PET.
Yes.
So will you be able to cover all 3 areas?
Amit,
that's the thing which I would...
Amit, if they want to do a Sano approach, will you be able to cover and then you have to stop at 41.4 or you would push a little longer?
Yeah, we can definitely try. At least 45 gray I would like to touch.
At least 45 gray you would want. So for people who don't know or not have heard about the Sano's approach is where they're trying to preserve the organ. So they did 41.4 along with radiation. Interestingly, 75% of patients in the study were adenocarcinomas, not squamous cell carcinomas. And at the end of 1 year, the event-free survival, the overall survival, if I'm not mistaken, it was a non-inferiority study with a 15% non-inferiority boundary that was built in, and it was non-inferior. A lot of patients moved from the surgical arm into the non-surgical arm because they wanted to save the organ. But it comes with so many challenges, so one needs to understand all the challenges before you get into an approach like this. So for me, choosing wisely on a 76-year-old with locally advanced, the condition that we just said, if you find a daring surgeon and a daring patient, CRT followed by surgery, if the anatomy fits into a cross protocol, remember that you need to be very clear about the extent of disease. Prashant actually pointed that out when you're doing cross protocol. You can't do it with 5 fields. If not perioperative S1 OX and then surgery, if you have a daring surgery in patient. For all the others, it would be definitive chemo radiation and pray that this patient should attain a complete response which is sustained. No immunotherapy in this situation. Okay, so that's situation number 2. Do we all agree that this is the wisest way of managing this patient? Okay, if you all agree, we'll move to the last situation. We've got 5 minutes to go. Medical oncologist, here you go. Good cardiac function. Prashant says, I will operate. Swapnil says, I will operate. Ajay says, I will operate. But you found an MMR deficient in this patient. Who wants to go first? Rakesh or Nishita? Matterhorn, immune checkpoint inhibitor only and consider a non-operative management. Flot perioperative because the volumes of data are not large enough to convince any one of you. Or some immune checkpoint inhibitor plus minus chemo at some dose for some time. What is it that you would want to do in a situation like this?
Sir, in this patient, MMRD positive, I'll go with the single agent immunotherapy and will assess the response. If the complete clinical response, I'll prefer to go for the wait and watch policy and continue immunotherapy, sir.
So you will start with single agent immune checkpoint inhibitor, see if there is complete response. If there is complete response, you would continue the immune checkpoint inhibitor. How long would you want to continue that?
Sir, I'll continue till 2 years, sir.
Till 2 years?
Yes.
Lovely. Nishita, what would you do?
This is that same patient, sir.
Same patient?
No,
it's the same patient with a slightly
yeah.
different profile now.
I would still go with chemotherapy only if the cardiac function is
but
good.
But people say that chemotherapy is not very effective in patients with an MMRD, right, Nishita?
But I don't think we have very strong data of what to do later on and for how long, as you asked, for how long to continue immunotherapy.
So what volume of patients and how long follow-up would you need to convince you to say that you will want to change
as of
treatment?
now, we are still with chemotherapy only. Maybe for your earlier patient, if the performance status is not good, not willing for a surgery later, actually there I thought of, why not?
Okay, would you, come to choice number 4, some IO, some dose, sometime, would you do that at all, or would you never touch the IO at all in the perioperative
Maybe
setting?
after the chemo, as still the surgeon feels, no, it's not, the
surgeon done, surgery done.
No, if the surgery
Flawed,
is done.
Prashant operated, sent it back to you, pathological complete response.
If I've given perioperative chemo, I would continue the same.
You will continue the same, so you're not convinced about the immune checkpoint inhibitor story. Any one of the surgeons want to comment here?
There are a couple of things, especially in preparation for this. There was some pooled analysis which said that only surgery is better than actually giving surgery and chemo. I am not sure if everyone
Nishita?
agrees. I haven't come
Ajay
across
is
that
saying the
scenario.
same thing. Only surgery is better than doing surgery plus chemo. What do
That
you
was a
want to say?
Pune analysis from the MAGIC and I think some other trial. And
Lovely. Good point. Good point. So both of you have to counter him now and then say, no, I want to do chemo.
I am in favor of perioperative chemo.
Okay.
Yeah, I am strongly in favor of perioperative chemo.
Okay, you are strongly in favor of perioperative chemo. Okay, so I think there's no one correct answer, but the way this direction, the science is moving is this. So I've got 3 data sets, very crowded slide, but what all of this is saying, the one on the lower left corner is just 3 months of immune checkpoint inhibitor. The one on top right is durvalumab. Both of these are dual immune checkpoint inhibitors, just 3 cycles there to top right. And the one is dostarlimab's love affair with, MMRD. So this is a very recent NEJM publication. I've just highlighted the cohort of patients with gastric and gastroesophageal junction. What you get roughly here is about 75% of patients will get a complete response with a very short burst of immune therapy treatment. 75%. 64% of the whole cohort seem to be in complete clinical response, and that is sustained so very well. You see that Kaplan-Meier on the right top. I have not put the Kaplan-Meier for the dostarlimab study. All of them are straight lines. At the end of 1 year, at the end of 2 years, you see that almost nobody relapses if you've had a clinical complete response. Okay? So I think Rakesh is probably right. That's what I think. Though Prashant and Nishita are not totally wrong in what they said, but it seems to be that if you get them on an immune checkpoint inhibitor, if you get a clinical complete response and then watch them, that would be a good idea. But if you don't get a clinical complete response, you do surgery, there's no role for any adjuvant chemotherapy. So this is what is my choosing wisely for this patient. I would do dual IO followed by consider for non-operative management, intensive surveillance by an experienced trained team, and a willing and compliant patient is extremely important in this situation, because this is not something that all teams are trained and all patients are ready. So that's very important. For those who have residue, operate, no adjuvant chemotherapy. Prashant, last point from you and then we close.
Yeah, if a patient can tolerate, if you think that he is fit for FLOT, he is fit for surgery.
Yes, but of course if you get a clinical complete response, no surgery. No response, surgery.
We don't have data. Sano is with radiotherapy.
No, we are not. So that this straight line is without surgery, Prashant. The straight line that you're seeing there is without surgery.
Yeah.
That's better than all the Sanos in the world.
This is definitely better than Sano.
So that's why I said, like Nishita said, we don't have tons of evidence to support what I'm saying, but I think that's the way we're moving. We've got a rectal cancer non-operative management panel next. I'm sure you will break your head over that in the next panel. But if you have an MMR deficient patient, that's the direction in which treatment is going, because chemo doesn't really work. Immune checkpoint inhibitor really does wonders, and most patients can probably avoid surgery, which I think is extremely important. And then this is my final thought: efficacy, effectiveness, and cost effectiveness. I think effectiveness is something that all of us have to be very cognizant about, because what works in a trial need not necessarily work in your hands. So what works in your hands is what you should choose, and that's what choosing wisely is all about. So if there are no more points that the panel wants to make, we will close, and thanks so much organizers for that opportunity. Thank you so much.
Sir, only one question.
You got one question?
Yes, sir. So what the duration of Nivo you will give?
I would stop at surgery, or I would stop after 3 months. No Nivo EP after that. If you're giving dostarlimab, it's total of 6 months of dostarlimab. That's all. No dostarlimab after
Wait and watch?
Wait and watch. You just wait and watch. You don't do immune checkpoint inhibitor after that. It's just 3 months of treatment, 3 cycles of treatment. That's why it's so very dramatic. That's why I said that probably is the best thing to do, rather than hammer them up with some chemo and surgery and all of those. We try to do non-operative management. Thank you so much.
Any questions from the floor? Then we invite Dr. Ashwin D'Souza for conducting the next panel on organ preservation for rectal cancer.
Dr. Ashwin D'Souza is Professor and Consultant Colorectal Surgeon at Tata Memorial Centre, Mumbai. I would like to invite our distinguished panelist, Dr. Rajesh Shinde, Professor GI Oncology, Apollo Hospital, New Bombay. Dr. Rakesh Mishra, Medical Oncologist at Radiant Cancer Hospital. Dr. Sushil Kumar, Consultant Medical Oncologist, American Oncology Institute, Raipur. Dr. Prithviraj, Consultant Surgical Oncologist, KIMS Sunshine Hospital, Hyderabad. Dr. Reena Engineer, Radiation Oncologist, Professor and Conveyor, GI, DMG, Tata Memorial Hospital, Mumbai. Dr. Aparna Dhar, Director, Hereditary Precision Oncology and Genetic Counseling, Max Super Speciality Hospital, Delhi. Dr. Lakshmi Sandhya, Consultant Medical Oncologist at SVI CCAR, Tata Center Foundation, Tirupati. Dr. Vivek Sukumar, Consultant Surgical Oncologist, Specialty Surgical Oncology Hospital and Research Center, Tata Cancer Research Memorial Institute, Mumbai. Dr. Mufaddal Qazi, Associate Professor and Consultant Surgeon, Gastrointestinal Surgery at ACTREC, Tata Memorial Hospital, Mumbai. Over to you, sir.
Dr. Tapesh is not here. That list? No. Dr. Rajesh is a new addition to the list that we had previously, sorry.
Yes, sir. Yes, sir.
What is his specialty, please? Sir. Dr. Rajesh. Oh, Shinde. Sorry, I have to be careful to direct the questions correctly. So we have one more surgeon in a non-operative panel. Okay, that's good. And Dr. Sushil is here? Yes, sir. Sushil? Yeah, okay, good. Great. So the topic given to me was organ preservation in rectal cancer, but I have taken the liberty to change the title to non-operative management in rectal cancer, because no doubt the primary aim of non-operative management in rectal cancer is organ preservation, but fortunately that is not the primary goal of this protocol. The primary goal still remains cancer control, both loco-regional and distant. And if during the point of this protocol there is any conflict between these two goals, it is obvious that cancer control takes precedence. There are two approaches to watch and wait for rectal cancer. The first is the accidental approach, where we have a locally advanced primary lesion, and the neoadjuvant therapy is given primarily to decrease local recurrence, and we then incidentally observe in about 15 to 20% patients a complete clinical response. But today with good MR, we know from the Mercury group that we can identify a group of good prognosis rectal cancers where surgery can be done upfront. Now, if we introduce neoadjuvant therapy to this good prognosis group with the intention to achieve a complete clinical response and preserve the organ, that is what we term as intentional watch and wait. In reality, watch and wait can never be truly intentional, because we can never guarantee that any patient will actually achieve a complete clinical response. With that perspective, let us just take up two cases to see how we actually go through this protocol of offering and monitoring a patient on an organ preservation protocol. First case, 65-year-old lady, hypertensive, diabetic, bleeding PR. Lesion is 2 into 2 centimeters polypoidal lesion, 3 centimeters from the anal verge, anteriorly based 11 to 12 o'clock, mobile lesion. Scopy is just showing that lesion rest is normal. Biopsy, moderately differentiated MSS, non-metastatic, and that is the MR. Polypoid lesion, very low down. It's on the anterior wall, and we see the same one here, but on the axial we can clearly see a node that is there. The final MR staging is T2N1, MRF negative, sphincters free, and no high-risk features per se. Now this patient comes first to the radiation oncologist. I think we just have one on the panel, Dr. Reena Engineer. Is organ preservation feasible for this patient? And is this going to be an accidental or an intentional watch and wait attempt? Go ahead.
Definitely, like now we have enough experience, like we're doing organ preservation in our center for more than like 15 years now. So initially we used to, you know, like yes, have an argument because this is a T2, it could be operated, radiation may not be required, but then this will be now in this day and era, it is definitely a case for intentional organ preservation.
Short course or long course, madam?
So traditionally it is long course and this is what we practice, but yes, in a trial setting or in a research setting, we are also studying short course with chemotherapy, TNT approach.
Okay, if we go for long course, do you think that the long course standard 50.4 grays is enough, or do we need to boost this with some intraluminal RT dose escalation?
So yes, by just giving 50.4 gray, we expect like if we don't do TNT, there will be a probability of 30-35%. But if we do that OPRA approach where they gave long course chemoradiation followed by chemotherapy, the organ preservation rate was 55%. So yes, I would give, but intraluminal RT, there is like two aim of giving. So like you can induce more response as we do in our center, and you can reduce the risk of regrowth. So even after all this, you know, if you don't give intraluminal boost, now the studies are showing the regrowth rate is like, or during wait and watch, is like to the tune of 25-30%. Some studies it is 35%. But when we give this radiation boost of brachytherapy or intraluminal boost, this can be reduced by at least half, so 15-17%. So I would definitely, but we will, as we do in our center, we go step by step as per response, as per the tolerance.
So if we look at the data from the International Watch and Wait database, we see that 91% are getting long course. And if we look at the recent Star Trek trial that was presented in ESTRO in May, that did show a difference, long course giving 80% organ preservation as compared to short course 61%. The OPERA trial is the trial that actually supports the intraluminal contact X-ray boost. This trial actually took very good prognosis tumors, small tumors, less than 5, nodes less than 8, and the standard radiation was actually not enough. They divided this into 2 groups, giving half a boost with external beam radiation and half with contact X-ray brachy. It is important to appreciate that essentially this OPERA trial was for T2 N0 low rectal cancers, because about 65% were T2 and more than 70% were N0 and all were less than 6 centimeters. And they showed excellent results. With intraluminal boost, tumors less than 3 centimeters, they had 97% organ preservation. Although they had significant bleeding that was there, subsided on its own by 3 years because of the effects of radiation. And results also that stood at 5 years, 79% organ preservation. But if you look at the group that got external beam boost, they are having a regrowth rate of 44%. Now, if we look at this isolated group of T2N0, 44% regrowth rate, I would consider a bit too high if we are considering for intentional watch and wait. My take from this OPERA trial is that if we are using RT alone in this intentional watch and wait, we do require some local RT dose escalation, contacts X-rays if you have it, or HDR brachy. Now, if this patient comes to the medical oncologist first, would you opt for watch and wait, only chemo? Can we avoid RT if we are using chemo to achieve a complete response? Dr. Rakesh?
So I usually, whenever I go with the chemo approach only, avoiding RT, I do assess imaging every 2 monthly to see how the response are going, because some patients usually do not respond to chemo. So these patients
No, but as an approach, would you choose chemo alone for a watch and wait, or?
No, sir. No. I will, only chemo I usually try to avoid to go for the wait and watch.
What about TNT? TNT for organ preservation?
Yes, I do agree with the TNT approach for the organ preservation. That is my preferred approach.
So this patient is T2N1. If I were to operate upfront and I get a final histopath T2N1, what would be your adjuvant?
So T2N1 node positive, upfront surgery, sir. No new
Upfront.
adjuvant.
I'm doing upfront surgery, T2N1.
So in this patient, I go with the adjuvant chemotherapy, sir.
How many months?
4 months, sir. Rectal cancer, 4 months, sir.
Okay, so you would not give the full 6 months. You would give maybe short because lower is stage 3.
Yes, sir.
Yeah, so that's fine. Now, supposing this patient is T2N0 and I operate upfront, would you give adjuvant chemotherapy?
Upfront T2N0, no, sir.
No. Dr. Sushil, so if in the adjuvant setting you're not going to give adjuvant chemotherapy for a T2N0, would you use TNT for a T2N0 to achieve organ preservation for this low rectal cancer?
Am I audible? So before going to the wait and watch approach, how I would look at it is that I would decide at the upfront whether what is my endpoint. My endpoint is to give the survival. Then I would like to go with the TNT approach either.
No, sir. This is T2N0. T2N0, early rectal cancer. My goal is organ preservation. I'm thinking of TNT only for organ preservation.
Yes, then organ preservation is feasible because it is fitting into the inclusion criteria of the organ preservation. There are no MRI defined high risk features. It's early stage.
Dr. Sandhya, any thoughts?
So if it is for organ preservation, then I would prefer a TNT approach, and if it is not for organ preservation, then only chemotherapy followed by surgery is a good option because that has shown benefit. But of course, in between chemotherapy, we should assess the response, and if they are responding like more than 20% from baseline, then surgery, and we can avoid radiotherapy for long-term benefits.
So we are seeing a little change in mindset from the medical oncology. It is that what would not be required in the adjuvant setting is being applied in the consolidation setting purely with the intention to achieve organ preservation. So that is something that is interesting and something that is changing. We know from the prospect trial that we can avoid radiation in a select group of patients, but the PAT-CR, although similar in both the RT and the non-RT arms, is quite low if we are considering organ preservation. If we look at whether systemic chemotherapy actually works to achieve local control, we have this series from Haber-Gamma where she showed adding chemo to long course radiation increases complete response to 65%. From MSKCC, 2, 4, and 6 cycles of chemo increases PAT-CR from 18 to 38%. And from the OPERA trial, consolidation chemo versus long course versus induction chemotherapy, we get organ preservation up to 54%. So as a principle, systemic chemotherapy does act on local organ to achieve some response. The trials for TNT for organ preservation, Rapido and Prodige, we should be careful. This is TNT for locally advanced rectum where organ preservation was actually a protocol violation. The OPERA and the STELLAR are the 2 trials that we have today. But if you look at the patient groups in these trials, these are not the early intentional watch and wait that we are seeing the T2N0. Majority of these are T3, N1, and N2, although most of them were low rectal cancer. STELLAR did show that adding TNT increases CCR to 11.1% against 4.4. And this is the only data I came across for T2N0 using TNT. This is a retrospective study from Haber-Gamma's data herself, where adding 6 cycles of chemo to long course chemoradiation in T2N0 increases complete response to 67%. As a rational TNT for organ preservation, this is how we usually used to treat rectal cancer: the NACT-RT and the surgery to achieve local control, and the adjuvant chemotherapy to tackle the risk of systemic metastasis. Shifting the adjuvant chemotherapy to the consolidation phase using systemic therapy to achieve local control will avoid surgery in 54%. We know that from the OPERA trial. But it is important to keep in mind this group of patients, the T1, T2, T3A, B, N0, especially if we can preserve sphincter, where surgery alone as a single modality achieves the same control. You have 6 weeks of long course chemoradiation, 3 months of chemo, and 46% will still require surgery. Surgery alone in this group can achieve the equivalent of a CCR immediately in 100% of patients. I think this fact needs to be explained to patients when they choose intentional wait and watch for this early rectal cancer group. We come to the surgeons in the panel. We've heard all the arguments. Dr. Vivek, watch and wait, upfront surgery, what would you go?
The lesion is just 3 centimeters from the anal wall.
3 centimeters,
yeah.
polypoid,
So,
anterior wall.
Anterior wall, yeah. So
65-year-old lady.
Yeah, so if it is a polypoidal anterior wall lesion and it's a T2 lesion, I think, and 3 centimeters from anal wall would still go ahead with a intentional
watch and wait?
Watch and wait, yeah.
Great. Dr. Kazi?
Same, the figures that you explained, we would give those figures to the patients as well. Explain what is the chance of organ preservation with giving chemoradiation. And if they still want to go ahead, we go ahead with chemoradiation.
What would be your...
It is T2N1.
T2N1, yeah.
It is T2N1 3 centimeters, which would be an upfront ISR with most positive, which would warrant adjuvant therapy in the post-op period as well.
Okay.
So the patient is not free from adjuvant therapy in this setting.
Dr. Prithvi, I'll make it a little more complicated for you. Let's make it T2N0. Watch and wait or upfront surgery? No, Dr. Prithvi.
So I think in that case, I'll explain to the patient and that his choice would
What would be your surgical option for this lady? 65-year-old, 3 centimeters anterior wall.
if she wants to trade off the risk of...
No, what is the surgical procedure would you do if for upfront surgery?
For 3 centimeters.
3 centimeters.
Not ISR, definitely.
I think it's going to be an ISR. It's going to be really difficult to get your margin. Huh?
67 years female.
65, yes, exactly. So, would you go for surgery or intentional watch and wait?
ISR possible.
ISR is technically feasible, but her rates of having Layard syndrome and all is very high in a 6-7 years female with ISR. So, considering that, then I would not go for surgery, but I would give a chance of...
Let's get Rajesh's call on this.
Yes, sir. So, the question is whether, what is the surgical plan?
No, what would you do for this lady?
T2N0.
Yeah, we can...
T2N1.
T2N1.
Yeah.
No upfront surgery for sure.
Yeah.
Some kind of a neoadjuvant chemoradiation.
With intention of organ preservation?
Then we have to talk to the patient whether she is willing for the surgery or not. Technically, the organ preservation is anyways possible accidentally also and intentionally also, because the sphincters and everything is free. After the neoadjuvant treatment, we can always get a distal margin. If it is 5 millimeter, 1 centimeter, that is also adequate. So we are anyways preserving the rectum. What we are looking for, whether the patient is willing for a non-operative management, then the question will be whether we go for an intentional total neoadjuvant therapy in this kind of case.
So we discussed in MDT, and our plan was to go ahead for organ preservation for this lady, intentional watch and wait. She got standard long course chemoradiation. We planned for brachy 2 weeks after RT. We didn't plan for TNT for her. She's 65, only single node, low risk for distant mets. Received the radiation, had a very good response, just a small mucosal lesion after 2 weeks for completing radiation. Completed the brachy, reassessed after 6 weeks. She's got just a small ulcer, nothing palpable on PR. The MR is showing very good response, just T2 hypointense fibrosis at the area where the tumor was. Dr. Engineer plan. They responded well. Just T2 hypointense fibrosis, no residual T2 intermediate lesion. Dr. Reena Engineer.
So definitely all these patients have to be taken to MDT. It's not an individual decision. And yes, this looks like a good response. This is 8 weeks post RT. Definitely we will prefer to observe, but again we will discuss with the patient if they can come for follow-up, if they're willing for this intense follow-up and the plan, then definitely we would go ahead with watch and wait.
So what would the ideal follow-up be for this patient?
So world across for 2 years, it is supposed to be 3 to 4 months as per the institutional protocol, doing CEA, MRI, sigmoidoscopy and digital rectal examination by at least 2 clinicians. So this has to be followed 3 monthly, and then because 95% 75% of the recurrences or regrowths which have to happen will happen in 24 months. And then thereafter, we can increase the follow-up to 6 months up to 5 years.
So that is the difference in the follow-up schedule between a watch and wait and a TME surgery. This is not an easy protocol, both on part of the surgeon and the organ preservation team as well. Patient should know this, and this is the essential component of this protocol. Patient was willing, went on to the protocol, post-RT 5 months, no complaints, sigmoidoscopy just showing a small ulcer, DRE no growth, MRI showing good sustained response, showing some fibrosis there. We plan to continue watch and wait. We called her up after 3 months as per the protocol, now 8 months. She's complaining of pain and bleeding while passing stool. Dr. Reena Engineer palpates a small ulcer. I palpate a 3 into 3 centimeter lesion. My impression is local regrowth. That is the sigmoidoscopy, which is showing an ulcerated lesion at the area of where the tumor was. It was not there on the last sigmoidoscopy. The MRI is showing some T2 intermediate mucosal lesions, new onset that were not there before. Dr. Engineer, plan. 8 months post-RT and brachy.
So, as radiation oncologists, it is our duty to educate our fellow clinicians that this could be, I'm not saying this is definitely, but this could be RT related ulcer. I have given brachytherapy and we see a typical white exudate and patient is having bleeding, but MRI is not very definitive of a regrowth. Endoscopist is also not saying a regrowth, it is an ulcer. So the radiotherapy, brachytherapy ulcer happens typically between 8 to 12 months. So we have to be very mindful of this fact, and then there is no need to rush for surgery at this point. We would again discuss with the patient and maybe we can have a closer follow-up after, rather than calling it 3 months, we can call it 2 months if we are not very
Dr. Kazi,
convinced.
Dr. Engineer wants to wait. You have a suspicion of local regrowth. What do you want to do?
I'm not willing to take that chance at this point.
Dr. Vivek, would you wait?
No.
Prithvi? No, operate APR, ISR?
APR.
APR. Rajesh?
APR.
Yeah. So it's very difficult to win an argument with Dr. Reena Engineer. So she convinced me that it was a brachy ulcer, but I did not agree to wait because she won the argument. I agreed to wait because there was a doubt of local regrowth, and I weighed my surgical option. My surgical option was probably APR now. It's 3 centimeters big ulcer there, which is coming down to 1 centimeter. 3 months down the line, my surgical option probably is not going to change. If my surgical option is going to change in waiting, I will not wait. If the sphincter is at risk, I will not wait. But in this condition, I said, it's APR today, it is APR after 3 months. Let's wait and see how this evolves. Post-RT 11 months, symptomatically better. The ulcer has healed on the scopy. The MR is also good. That was a brachy ulcer. We plan to continue watch and wait. Post-RT 2 months, PR is absolutely normal. And that is the scopy, which is absolutely normal. So that is the first case, a win-win situation. Madam, we will go ahead. We will go ahead. There's another one. I'd finish it. I got 7 minutes. 35-year-old lady. Now this lady was treated outside.
Sir, what is the message?
Let's finish and then we can discuss afterwards. The second case also is good. T3N0 treated outside. The growth was palpable 1 centimeter from the anal verge. Comes to us after completing long course chemoradiation. That is a lesion there. Polypoid, the baseline MR. What if this patient was MSI high? This patient was MSI stable. Dr. Aparna, we test this patient for Lynch. She's 35. Organ preservation in the context of Lynch syndrome. In hereditary colon cancer, we think of prophylactic surgery. Does organ preservation really fit in that logic?
Absolutely. 35 years old, irrespective of MSI being, you said it was stable here, I would still test her.
No, we'll just consider it as high.
At high?
And we test for germline mutation, she comes back as Lynch.
Perfect. Even if she comes positive, it's organ preservation. In Lynch, we don't have the option for prophylactic surgeries for colon. We don't have that recommendation unless it's a really, really strong family history and we see a very young presentation, or somebody's had the cancer and then there's a recurrence and it's under the age of 35. It goes to a tumor board, a multidisciplinary tumor board, to make this decision. But as per my guidelines, if you are germline positive for Lynch, we would not be recommending prophylactic, it's organ preservation.
Yeah, so there's no clear evidence at present, but I think as of now it is justified. If the patient has a complete response, we can put these patients on organ preservation. Patient comes, she's post-RT 20 days, there's minimal disease. We plan for brachy, she completes the brachy. She's 6 months post-brachy, excellent response. Just some mucosal edema. If you look at the RT, the MRI just shows a fibrosis at the area of the tumor. We counsel this patient for watch and wait, and we put her on the protocol. She maintains a complete response for 1 year, 9 months. She comes on her follow-up. She's coming every 3 months, now 6 monthly. Still a sustained response. Her main question is she wants to increase the duration of follow-up. She's 1 year, 9 months. Dr. Prudvi, she's got 4 children. She comes from the Northeast. It's extremely difficult for her to continue the follow-up. She's had an excellent response, total control, CCR immediately after brachy.
I think for the watch and wait protocol, the follow protocol is non-negotiable. She has to come through every.
Just talk into the mic, please. I can't hear you. Go ahead.
So for the watch and wait protocol, the follow protocol is non-negotiable. She has to be on 3 months follow-up to pick up the early regrowths and thereby to prevent the distendments.
Yeah, so I agree with you. We discussed with her. We gave her 4 months. We called her back after 4 months. She kept with the protocol. She's on regular follow-up now, 2 years, 10 months, still controlled. That is her scopy. That is her MR. Nothing on the MR. She's now begging you, make it 9 months, 12 months. I've already finished 2 years, 10 months. Please help me. Dr. Vivek?
No, she'll have to follow up as per the protocol only.
Yeah, so we did insist on the protocol, and she comes back 3 years, 5 months, and now we see a 1 into 1 centimeter nodule at 6 to 7 o'clock, 2 centimeters from the anal verge. Sigmoidoscopy picks that nodule, and you can actually see the nodule very clearly on the MR at the site of the tumor posteriorly, and on MR it's definitely a local regrowth. So as time passes, the message here is we just cannot get lax in that protocol. The non-operative management is that protocol. So if you're not willing to do that protocol, we should operate. Right? Dr. Prudvi, patient comes with local regrowth, your first step.
Sorry, sir?
Patient comes with local regrowth, your first step.
Biopsy center. We ask
what?
Colonoscopy, and then we do biopsy and prove.
Sigmoidoscopy is showing the growth. No, biopsy, I'll come to that, but the first step is actually to check for distant metastasis, because local regrowth from the International Watch and Wait database comes to about 25%, but distant metastasis, local regrowth is an independent factor for distant metastasis. Patient has local regrowth, the MET workup is reflexive, we have to get the CT done. Biopsy, Dr. Reena Engineer, Dr. Prudvi said he wants to biopsy that lesion. Would you biopsy this?
No, we usually don't, because it is evident, you know. Like
so when would you biopsy? Is there any role of biopsy in watch and wait?
We generally don't do, but then when there's lot of confusion and within 2 years there is some signal on an MRI, there's still residual ulcer, patient doesn't want, patient also insists, so those very rare cases we do a biopsy. But most of the time we don't do biopsy, because it may, even if it's negative, it doesn't mean that there is no tumor in the rest of the area. Even if it's positive, the tumor may not have the propensity to grow. So like it confuses more rather than it gives us. So we don't do biopsy routinely.
So that is it. Probably the only situation we would probably consider a biopsy if your investigation is equivocal and further waiting does not alter the surgical plan. That is where we would do a biopsy. If we get a positive, we would go for surgery right away. If it is negative, we go for a short-term follow-up. Dr. Kazi, your surgical options for this patient, let me just regroup. She's post-long course radiation, 3 years, 5 with brachy, 3 years, 5 months, 3 centimeter from the anal verge, posterior regrowth in the posterior wall. Surgical options for this patient? ISS is effaced. Could be post-RT changes. Radiologist is not willing to commit. The main problem here is the radiation oncologists come with maybe slight sense of guilt. And we are not able to save the organ. Can we save the sphincter?
I wouldn't take the chance. I wouldn't take the chance.
APR?
APR? ISS is removed. It is on MRI.
ISS is effaced.
It actually also depends on the rectal examination.
Mobile 1 centimeter nodule, posterior wall. Does posterior or anterior give you any?
Safer sometimes.
Yeah, you have the hiatal ligament and tissue posteriorly which you can get your CRM. Yeah.
We can go ahead with an ISR also.
Would you go for?
Go for ISR if the patient is motivated, understands the risks.
Okay, Dr. Rajesh, save the sphincter or APR?
Ideally APR, but if the patient is keen on preserving the sphincter, we can go with ISR. We can take out the right side levator also, right-sided extra levator. She is young, she will be able to manage.
Yeah, so just looking at the patterns of failure, if you have a tumor here, it is to remember all the patterns of failure, the local, the mesorectal nodes, lateral pelvic lymph nodes, as well as the distal mets, surgery for all salvages. There is a role of local excision. Margins for surgery are usually based on the baseline evaluation and not on the response evaluation MRI. We'll skip this. We know this from Rapido, where changing the margins based on response evaluation MRI actually led to higher locoregional recurrence. Results of salvage are actually very good. We'll skip local excision because time is out. The challenges for surgery are mainly the fibrosis that sets in. We know that if we wait for longer time, we have higher response, but this T2 hypo intense fibrosis that comes in the primary also comes in all the surgical field. Evidenced again from Rapido, where they had higher breached mesorectum, 21% against 4%. But results of salvage surgery are pretty satisfying. R0 resection rate is 97%. And survival rates are all above 90%. We counsel this patient, we are not sure, as you saw on the panel, ISR or APR, patient has to be counseled for both, but this patient is not willing for surgery. This is something that we see on this watch and wait protocol often. I'm going to skip comments from the panel because of want of time. This mainly has to do with how we counsel the patients at the outset. We counsel them that non-operative management is a way to avoid surgery. The wait and watch protocol is a protocol of intense surveillance to identify the 25% of patients that actually require surgery. And in that sense, surgery is not salvage, but an integral part of non-operative management. We counsel patient is willing for surgery. If by chance we operate in a watch and wait protocol and we get a histopathology of path complete response, we look from Haber-Gamma's data. The path CR do not behave oncologically as similar to the clinical complete response, and therefore a histopathology response of path CR is not a failure but a success. To summarize just the essentials of this watch and wait protocol, path CR is not the same as a CCR oncologically. We cannot guarantee a CCR for every patient, especially when we consider intentional watch and wait. Non-operative management for early rectal cancer does require some RT dose escalation. Surgery as a single modality is curative in this select group of patients. There are 4 patterns of failure while monitoring a patient on watch and wait. All have to be kept in mind. Surgical options are largely TME, local excision in a few. Surgical template is based on usually our baseline MR. The longer we wait, the longer we get complete response, but more difficult is the salvage. And surgery is not real salvage, but an integral part of non-operative management, and patients should be counseled regardingly the same. Thank you.
Excuse me, sir. I have a couple of questions. Require your suggestions. One thing is, whenever any locally advanced rectal cancer patient comes to the...
Can you just speak into the mic? Yeah.
Yes. Whenever any locally advanced rectal cancer patient comes to the tumor board clinic, what is your approach? Like, you'll be deciding whether this patient will be going for the TNT followed by surgery or non-operative management, because that decision has been taken in trials in the upfront, not kind of incidental. Because when suppose the patient is fitting into the Prodige trial, we give FOLFIRINOX followed by NACT-RT and then followed by surgery. There we cannot tell that since the patient has clinically complete response, let me put in the non-operative management. We cannot do that because the protocol is fixed at the upfront. So how do you go about that?
Yeah, so what we see, you're talking about locally advanced rectal cancer, where TNT is given primarily to decrease the risk of distant metastasis. That was the primary intention for both Rapido and Prodige. And their patient group also fit that criteria. So they had T4, APR involved, N2 disease, lateral pelvic nodes, EMVI, and tumor deposits. These are the factors there, high risk, where you give TNT to decrease the risk of distant metastasis. You're asking if in this protocol you get a complete response at the primary, that goes to the first approach. That is the accidental watch and wait, which is also validated. So the difference is that we see this as an incidental finding, where we have not given our neoadjuvant therapy to control the local disease. But if you have a complete response, it is still safe to keep them on watch and wait. Our main intention of the TNT here is to control the distant metastasis. The change in our reasoning here has come for the T2 N0s requiring the ISR and the APR, where we can give chemotherapy, extrapolating data from our TNT trials to increase local response so that we have organ preservation. But if the tumor is little higher, where we can comfortably do an LAR, surgery as a single modality therapy offers excellent control instead of putting these patients on watch and wait.
Okay. So my second doubt is that whenever especially in the second case, it's a T3N0, so it's by
T3A, less than 5 millimeters extramural invasion. So T3 is ABCD.
Okay.
So AB is one and CD is a different category. Yes.
Yes.
Yeah.
So, but still, like as per the definition, T3, T4, or N2 is considered as a locally advanced rectal cancer, and these patients have been included in the trial. That's how the trials have done the inclusion criteria. So, whenever this patient comes to us and we have offered NACT-RT in this case, post that, why didn't we consider for the chemotherapy? Because we have to finish the protocol, because it's a local, if at all we are going for the OPRA approach, initially we can follow the, we have given some kind of NACT-RT and then followed by chemotherapy has to be given, but why didn't we give? Is there any reason? Because it's a T3A or?
Yes, so all the RT trials never had MR. The Mercury group came back after the German, Polish, Dutch, all the trials. The MR came later than that. That MR segregated the T3AB and C and D. So once we have segregation, the T3A, N0, N1, Mercury group showed surgery alone achieves equivalent results. We probably don't have to go for radiation in these patients. So it is the T3BC where we give, and then we go for TNT, that is fine. So the early rectal cancers, T3AB, we go for an intentional watch and wait. And the locally advanced, we go for TNT, decreasing local recurrence and distant metastasis.
Okay. Also, how I look at it is that in the upfront, because the endpoints for the TNT approaches as well as the organ preservation approaches is different. The primary endpoint for the TNT approach is the survival, mostly either DFS or DRTF, whatever. But the primary endpoint for the organ preservation is the organ preservation. So now we need to decide whether we will go for the giving the survival benefit or should we go for a organ preservation, because the primary endpoints are different in both these trials, and I think we cannot mix it. So
yeah, so that clearly depends on the type of rectal cancer you're dealing with. If it is the early rectal cancer, T3AB N0, T1, T2, T3AB N0, N1, that low rectal cancer you're going for organ preservation, you can use TNT. There is no role for upfront APR for these patients, or even ISR in an elderly lady. You can go for TNT, but just reduce dose, 3 months of chemo, that is fine. But when we treat locally advanced rectal cancer, their object is absolutely right, it's different. The endpoint is not organ preservation. That is why the organ preservation that we see in those TNT approaches is only accidental. It is only accidental.
Can I make one quick comment? Because like around 8 years back, when these patients, we were not doing organ preservation, all across the board, when the patients post neoadjuvant chemo radiation, whether they have any kind of response, partial, incomplete, whatever, so 40% would drop out in our Tata Memorial Center if they were offered APR. So they would refuse surgery irrespective of the response. But when you give them hope that yes, even if they are locally advanced, 10-15% chance of organ preservation, their acceptability rate is better. And now we see the default rate for APR now is dropped down to 15 to 18%. So that's an achievement in itself. So from day one, you know, you can give them hope. You know, there could be some chance of organ preservation. If they are very advanced, 10 to 15%. If they are early, then up to 70 or 80%. So please, you know, like this is for the very low rectal cancers.
I extend my heartfelt gratitude to all the chairpersons for your time and for guiding this session. A big thank you to
I had
Senthil
just one
sir.
question for Reena ma'am. Ma'am, with addition of intraluminal brachytherapy for increased local control, do we come across more radiation proctitis? And
Yes,
what is the
definitely.
incidence and how do we treat
in
it?
In OPERA trial, 65% had grade 3 radiation proctitis, which continued up to 3 years. So we have to, we have to learn how to differentiate between radiation proctitis versus residual disease and follow them up and treat them well. They land up with bad proctitis.
Thank you, ma'am.
A big thank you to Senthil sir and Ashwin sir and all the panelists for highly engaging and practical discussion. I sincerely apologize for last minute changes and I truly appreciate your flexibility and understanding in this matter. Now, moving on to the next session, I would like to invite the chairpersons for the session, Dr. Pushkal Dwivedi, Medical Oncologist, Bilaspur, Dr. Alok Swain, Medical Superintendent and Head of Anesthesia, Balco Medical Center, Dr. Vivek Baghel, Consultant Nuclear Medicine, Balco Medical Center, Dr. Ravindranathan, Executive Director, JLNH and Research Center, Bhilai, Dr. Mayank Devangan, Professor in Surgery, RIMS, Raipur, Dr. Shreyas Reddy, Radiation Oncologist, Apollo, Jabalpur, Dr. Gaurav Sir, Consultant Radiologist, Balco Medical Center, Dr. Dipanjan Biswas, Consultant Surgical Oncologist, Balco Medical Center. We now have a special talk on ctDNA and precision oncology in colorectal cancers, choosing wisely. It is my honor to invite Dr. Aparna Parekh, Program Director for GI Medical Oncology Program at Mass General Brigham, Boston, a force in GI oncology with a focus on young adults with colorectal cancer, to deliver this session. We welcome you, ma'am.
Thank you so much to the organizing committee for having me today. It's truly a pleasure to be here. So today I will give a brief overview of CTD and colorectal cancer, really focusing on the minimal residual disease setting. And my take-home message is, as I hope you see the data, choose wisely, because I do not think that this testing is ready for prime time use in certainly all patients. Here are some of my disclosures. So the big problem that we all recognize quite well across solid tumors is that many patients who get curative intent therapy still have recurrent disease. So if you look across the top 3 solid tumors in the United States, breast cancer, colorectal cancer, and non-small cell lung cancer, about 30% of patients who are treated with curative intent still do develop recurrence. So, when I talk about this, even with patients, we have to start to think about what these assays are actually telling us. So our current surveillance approaches have limited sensitivity, albeit have gotten much better. So if you look at a chest x-ray, 10 to the 9th cancer cells, CT scan, 10 to the 7th cancer cells. And now with ctDNA, we are getting as low as even 1 part per million in our ability to detect residual disease. A talented surgeon perhaps can see 10 to the 3rd. But the biggest question for ctDNA in this setting is, does better detection of minimal residual disease actually improve outcomes? And I'll make the case that as of 2025, not yet. So for many of the trainees in the room, just to level set, what actually is ctDNA? So ctDNA is one of many different blood-based analytes that can be used to detect minimal residual disease. And ctDNA is tumor-derived fragmented DNA, and it's released by various cellular processes and cell turnaround, and is circulating in the bloodstream. All of us have normal cell-free DNA that is being shed from normal cell turnaround, but ctDNA is, again, the tumor-derived fragments. Some of the characteristics of ctDNA, very short half-life, on the order of minutes to hours. So its concentration in the blood is highly responsive to tumor changes. Many, many things impact the ctDNA in the blood. Different tumor types shed a different amount, different sites of metastases. Liver metastases, for example, shed a lot more DNA in the blood versus lung or peritoneal disease. And our current assays are, getting better and better, but still not perfect for detecting all patients that actually do have high risk for recurrence. And if you look across solid tumors, I think what is no longer really arguable is the predictive ability. The prognostic ability, not necessarily predictive with response to treatment. So if you look across, again, the top 3 solid tumor types in the US, the positive predictive value is anywhere from 90 to 95%, and in some tumor types even more. So you have a high confidence that if you can detect ctDNA in the blood, the cancer does have a high chance of coming back. The time from recurrence, again, varies by tumor type, from once you first detect ctDNA in the blood to radiographic evidence of disease. But if you look again across these solid tumor types, it's less than 18 months, but for some tumor types, much, much shorter. Every time I update this slide, I have to look on a week-to-week basis. There are many, many companies that are developing assays for ctDNA measurement, and it's a rapidly evolving landscape. There are 2 general approaches: the tumor-informed approach, where you sequence the patient's tumor, you pick mutations, and you track those in the blood. There's whole exome, and now many of the tests are moving to whole genome approaches, where you're tracking thousands of mutations per patient. And then there's tumor-agnostic approaches, where you do not need to have knowledge of the patient's tumor. And I think to me what is quite remarkable is, despite the limited clinical utility data, the rapid uptake in the United States with these tests. Just for level setting, the pathway for Medicare reimbursement for diagnostic tests is very different than the pathway for a drug. And so CMS has endorsed ctDNA testing, which is why we're seeing this tremendous uptake. But again, I think quite limited data in terms of clinical utility. So when we think about ctDNA as a biomarker, the way I like to think about it is for de-escalation of care, you want a highly sensitive assay. So to feel good that you're not going to give chemotherapy to someone who actually needs chemotherapy, you want a test that is very sensitive. And then for escalation of care, again, to give someone treatment who otherwise would not get treatment, you want a highly specific test. And then for surveillance, I think really depends on the scenario. So in colorectal cancer, as a use case, I think, like many other tumors, is highly prognostic. So data set after data set, you see hazard ratios of 20 to 50, and nearly 100% of patients with positive ctDNA in colorectal cancer will indeed develop clinical recurrence without any systemic therapy. And this is, again, when you compare it to other known prognostic variables in colorectal cancer, T-stage, N-stage, even BRAF status. So ctDNA is certainly more prognostic than any of other clinical pathological variables. One of the challenges, and I think this is really important as we frame this discussion about choosing wisely, is that post-op ctDNA in colorectal cancer, the current assays, and again, the assays are getting better, but with the first generation of tests, it is only capturing about 40 to 55% of recurrences. So if you look across some of the larger data sets, again, the sensitivity is what we see time and time again. And when you're looking at promotional materials and marketing materials from companies, pay attention to this, because in all the promotional materials, what you'll see is what's on the left. Serial sensitivity, so sensitivity is of 90+%. But Does it matter if you are testing serially? So do I care if a patient is ctDNA positive a week before their CT scan that is showing radiographic recurrence? So not surprisingly, as you're testing people longitudinally over time, getting closer to your radiographic recurrence, your ability to detect the ctDNA is, or the recurrence is higher. And we've seen this, right? So serial testing does improve sensitivity, but does that really matter at that point? And again, when you look at just single postoperative sensitivity, still better than T-stage and lymph node status and tumor differentiation here on the right. So still better than those pathological variables in terms of recurrence prediction, but certainly limitations for single time point testing. And we see this across tumor types. So, landmark testing, if you look across different solid tumors, versus surveillance testing, again, around 50% versus 90%. So in terms of, again, surveillance, this is, I think, where we are, is that, the first generation of tests is certainly promising, but not yet sensitive enough, particularly for de-escalation of care. So many approaches, more mutations, more blood, broader epigenomic coverage are all being considered to try to bolster the sensitivity, but I think still a ways to go. So then the next question is, does adjuvant chemotherapy actually clear ctDNA? And this is just with standard of care. And if you look across 3 of the largest data sets that we have that is asking that question of adjuvant therapy, what you can see is that, if you're MRD negative, generally you're doing well. So with and without adjuvant chemotherapy, you can see the 2-year disease-free survival and the 3-year disease-free survivals in that, 87 to 89% range. With adjuvant chemotherapy for the MRD positive patients, we are able to clear some patients, right? So the 2 and 3 year DFS is around 40%, but certainly we're not clearing everyone. So our current adjuvant treatments, are effective, but modestly effective in terms of actually treating chemotherapy. And then many, many trials are ongoing across the globe in terms of switch therapy or escalation, post-definitive therapy, including post-chemotherapy. The Pegasus is a small phase 2 study in Europe that is showing a signal of FOLFIRI post-FOLFOX or CAPOX, limited short-term, limited follow-up, but is showing that you are able to clear a certain amount of patients. Whereas much larger studies such as Dynamic 3 and Altair showing escalation with Lonsurf post-surgery, noting some of these patients had chemotherapy and some did not. And then Dynamic study looking at assay-prompted escalation, including escalation with FOLFOXIRI, did not show a benefit of escalation. And I don't have time to go into some of the nuances of these studies today, but again, suffice it to say that we don't have yet a clear data set that is showing that escalation matters. At ESMO, we're going to see the de-escalation data for Dynamic. But again, I do want to make, a small point, is that what we do now in terms of escalation, is TNM based, obviously, and ctDNA does improve our prognostication. And if you look at the PPV of our TNM staging, it's only around 60%. And so, I'm not advocating by any means that, ctDNA is the holy grail here, but we still, with our TNM staging, are treating a lot of patients who don't need chemotherapy with chemotherapy. So what do I do outside of clinical trials? And again, people ask me all the time, do you test? And I say, yes, we test because we have many trials in this space, but very specific cases where I'm actually using this to guide treatment decision making. So in a stage 2 colorectal cancer patient, a T4 patient, I'm still talking about chemotherapy for, even if they're negative. But any stage 2 patient who happens to be ctDNA positive, I would recommend adjuvant chemotherapy. I think in terms of a stage 2, again, T4 and 0 or other high risk features that is negative, discussion. Stage 3 ctDNA negative, I'm still giving adjuvant chemotherapy. I'm not de-escalating care. But again, in certain scenarios, an elderly patient, you're not quite sure what to do with, if you're not loving giving adjuvant chemotherapy for that patient, or certainly giving platinum as well, you might defer that patient. And then for surveillance, really need to discuss the purpose of surveillance. What do I do with that information? And currently I don't have any data what I do with that patient besides a clinical trial. And when we look at ctDNA compared to imaging and CEA for surveillance, actually imaging plus CEA in this data set, outperform the ctDNA. And again, imaging, especially in my world, colorectal cancer, if you find a limited lung metastases, you can still go after that with curative intent therapies, whether it's surgery, SBRT, for example. But ctDNA is notoriously bad for picking up lung mets. The other caution about surveillance is, around, again, to this point of sensitivity, around 17% of cases across solid tumors that have radiographic evidence of disease are actually ctDNA negative. And then in around 30% of cases, the time from MRD to radiographic recurrence is actually less than 3 months. So again, are you actually meaningfully doing anything at that point in time when the patient really is, overtly metastatic at that point in time? In terms of surveillance, I think take-home messages, false negatives, you can miss recurrences that are still curative. What do you do with a positive test? You do get an occasional false positive, especially in the lower risk patient populations. I do not ever test in stage 1, for example, and we certainly don't have any data yet that early intervention changes the course of disease. These are expensive and clearly lack of equitable access of testing, so I would argue definitely not choosing wisely in terms of surveillance. So in summary, in terms of ctDNA and curative disease, I think unequivocally a prognostic risk factor, and again, high rates of recurrence without intervention. We do see clearance, and that clearance is indeed possible, but again, highlighting the fact that in terms of the sensitivity, we're missing many of the recurrences that with ctDNA testing. Adjuvant chemotherapy in ctDNA positive cases does seem to improve short-term outcomes in terms of 3-year DFS. We're still waiting for longer-term data. And zero data that surveillance testing has clinical utility. So in terms of sensitivity, I think we need better assays for de-escalation of care. But I do think if you were not planning to give adjuvant and you have a positive test, you could feel comfortable in escalating care with the standard treatments, nothing else beyond standard of care. So looking forward, I think the FDA is recognizing more and more that ctDNA is just part of now a path eventually, I think, towards regulatory approval. Last year, the ODAC ended up supporting the use of MRD as an accelerated and an endpoint for accelerated approval in the myeloma space, and that took kind of decades of work, but it was a unanimous vote by the ODAC. And we are trying to coalesce efforts in the U.S. to do a better job of the clinical utility data generation, because I think we're still a little bit far behind. So to kind of wrap up, to just summarize some of those efforts, I think we're really trying to think around trials that enroll patients with MRD. I think incredibly valuable. These patients have a lower disease burden, less likely to have resistant metastatic clones, less likely to have previous toxicity from therapies. And again, early stage disease has different vulnerabilities to treatments. And then from a trial design perspective, you need many fewer patients compared to standard adjuvant trials, because your time to your recurrence endpoint is very short. And we're realizing that ctDNA rejection or clearance could be an early signal of anti-tumor activity. And this was the model that the HIV investigators took, right? So with viral load, it was recognized that viral load changes were a highly relevant and reliable prognostic biomarker for HIV progression, and ultimately with antiretrovirals, viral load declines was the endpoint for regulatory approval. So MRD trials are very hard to do in the US because there's not a great system for systematically testing patients, even though the testing is happening. Trials rely on individual investigators at sites, and many institutions actually don't have an infrastructure to maintain the testing. So we have put together a kind of consortium, including now the Japanese investigators, to try to generate some of the clinical utility data that we have desperately needed, like our colleagues in Australia and Japan. And with that, that is all I have. I'm happy to take questions.
Ma'am, I have a question. So choosing between 3 months and 6 months of CAPOX, can ctDNA be used to choose between 3 months and 6 months of CAPOX? Like, can we do it at the end of 3 months and see if the ctDNA is negative? In the adjuvant setting, yeah, so for choosing between 3 months versus 6 months of CAPOX, so will it help to choose the right patient?
Yeah, I mean, so I think, you know, first of all, in the stage 3 patients, right, it is sort of depending on the risk, high risk, low risk, 3 months of CAPOX versus 6 months of FOLFOX, as we know from the IDEA data showing non-inferiority of 3 months in the lower risk patient populations. You know, and I think what's tricky with that is, you know, if someone is positive at the outset, I would just err on the side of 6 months of FOLFOX treatment. But I don't think we know if that patient is midway through, for example, and is still ctDNA negative, is that patient actually still going to benefit from the adjuvant therapy, and are they just destined to be patients that are going to recur or not? So I don't use it necessarily to guide 3 months or 6 months, but if a patient wants the testing and I'm, you know, unclear at the outset, I will, if they're positive, I will err on the side of 6 months. And, you know, I think even with the IDEA data, I think a topic for another discussion, but, you know, I think in a non-inferiority design, you accept a certain loss of efficacy too, and I see a lot of younger patients, so I sort of tell people, you know, the median age in my practice is in the 30s, and so I think I do tend to use these tests a little bit more, and have sort of erred on the side of 6 months with a low threshold to drop the oxaliplatin. We also, I think in the US, for some reason, the CAPE tolerability doesn't seem to be quite as good. And now that we have data that, you know, dropping oxali even after you know, around cycle 8 with early treatment discontinuation still maintains efficacy. My approach, especially for the younger patients who are positive, even in the low risk stage 3s, is you know, shoot for 6 months of FOLFOX, and at the earliest signs of neuropathy, just drop the platinum.
Thank you, ma'am.
Thanks for this wonderful talk. That we are listening just last 2-3 years about the ctDNA. Means what you think that why it is still not in NCCN and ESMO, especially in stage 2 colorectal cancer, where there is lots of confusing whether to give adjuvant chemo or not.
Yeah, I just came off the NCCN guidelines, and I think it took the committee a while to even acknowledge the prognostic value, right? So I think now in the guidelines, at least it is there as a prognostic biomarker. I think the predictive data, I think given, you know, again, dynamic was not necessarily showing the dynamic study by Australia was not necessarily designed to show that, you know, giving treatment actually compared to no treatment has, you know, it showed non-inferiority of a ctDNA guided approach, but was not designed to definitively answer the question of treating a stage 2 positive patient. So I actually think it should be, and I will not be surprised in the next year or so if it ends up in the guidelines for the stage 2. But just because there hasn't been the level of evidence that I think NCCN typically likes to see is why we haven't seen it in the guidelines yet.
And is any specific standardification means which lab or is any standardization where we can ask for that, whether that lab report is, we can replicate that results, what we are getting in the US or what we are seeing in the India, how we are going to ascertain that what we are getting report from our lab is how that means that any standardization.
Yeah, I mean, I think there has to be some just basic acceptance of what at minimum, the analytic thresholds of the different lab assays. But I think any of the tests that you're considering using, I think you do need to see some clinical validation. I don't think the analytic validity would necessarily justify immediate use. But I think there are, and we've actually put together some work around what are the minimum specifications you want to see around analytic validity. But certainly analytic validity doesn't necessarily equate to clinical validity either.
And one last question, madam. Like in the tumor markers, where like suppose CA, those patients where at the time of presentation that CA is high, that is very good for the follow-up. I am talking about the colorectal cancer. But those patients where the CA is normal at the time of presentation, it doesn't look very reliable marker for the follow-up. The same thing applies for the ctDNA also?
Yeah, I mean, so in general, your ctDNA detection rates when your tumor is intact is really high. And so, I guess your question is that a good way, if you're CEA negative, can you follow ctDNA, or is that what you're asking? Again, I think the limitations of the sensitivity are still there for follow-up. And again, we do CEA, but you could argue like what the every 3 month CEA that we're doing, is that actually clinically indicated as well? We do it makes us feel good, but I'm not sure, what do? You get an elevated CEA or a ctDNA and then you just scan a little bit early. What I do in my practice for a positive patient is, I do get a liver MRI. I think many times when you're positive and your CT scans show no evidence of disease, the first place I tend to look a little bit deeper is the liver, and you'll often find it. So it's not necessarily correlated with CEA, but I think still limited sensitivity is not perfect.
Where we have the most robust data in all solid tumors? Like you have discovered the colon, lung, and I think the breast. So in which solid tumor is the most robust data about ctDNA in the follow-up and all that?
Sorry, which?
That most robust data of ctDNA in follow-up in all solid tumor, among all solid tumors.
No, I mean, I think there is different sensitivity across all the tumor types. I just use the top 3 incidence cancers as the examples, but across solid tumors, I can't think of one that doesn't have some data in the prognostic setting. And actually now in bladder cancer, a positive data with adjuvant atezolizumab in the ctDNA positive patients too. So actually further ahead even than colorectal cancer in bladder cancer as a now predictive biomarker response to treatment. But surveillance, I can't speak to which tumor types have put them in the NCCN guidelines. I don't think any have, to my knowledge. I think, again, only colorectal cancer is, I think, where it is for prognostic use. Thank you.
Thank you, ma'am, for forward-looking talk on evolving role of ctDNA and precision oncology. Now, continuing with the same choosing wisely topic, I would like to invite Dr. Christopher Jackson, founding member of Common Sense Oncology and medical oncologist and professor of cancer medicine at Mercy Cancer Centre, Mercy Hospital, New Zealand, who has influenced cancer research, policy and patient access to treatment globally. For his talk on managing resectable colorectal liver metastasis, choosing wisely. I would also request Dr. Vivek Chaudhary sir, who is the Dean of PTJNMC, to please chair this session. Over to you, sir.
Thank you. Kia ora tātou, which is in New Zealand we say kia ora or hello. So lovely to see so many people here, and it's wonderful to be welcomed here to the CONCLAVE, to this Choosing Wisely event. I wonder if the choosing wisely that this audience is doing is listening to my talk instead of having lunch, or if it would be wiser to choose lunch over my talk. Only you can judge that by the end of the discussion. Colorectal cancer is an important condition in New Zealand and indeed globally. It was fascinating to hear the talk earlier today indicating that it only counts for 5% of all cancers in India. In the New Zealand context, it's the second most common cancer and the second leading cause of cancer death. It's one of the few cancers where the resection of metastatic disease can indeed result in cure for a proportion of patients. And this data from Renee Adam's group, the TransResectMet database, shows that people who undergo resection for colorectal liver metastases can be cured. The number of patients who are cured is closely related to the characteristics of the cancer. That is 1 to 3 metastases, 4 to 6 or more than 10, the size of the metastases, and whether or not patients are able to undergo secondary resection after their first. And often when I'm talking with my patients about resection for colorectal liver metastases, I tell them from the start that it's a marathon with a number of resections likely ahead in their future. The data on colorectal liver metastases, though, when we think about it in the context of our patients, it's important to remember that every single patient who we see in this context is somewhat unique. As you'll know from these 2 CT scans, one of only 2 or possibly 3 liver metastases is very different to the lower picture of multiple scattered large liver metastases with vascular invasion. Patients have a number of factors to consider. The primary tumour may be in situ. The patient may or may not have adjuvant therapy, including an oxaliplatin-based regime, which may influence the ability to give further therapy. The number of metastases is clearly an important factor in determining the patient's prognosis. There may be invasion of the vascular structures, such as a hepatic vein or artery. We have to consider how much remnant liver will be left, 30% or more, 2 contiguous segments, and how many segments will be left behind. And is there any extrahepatic disease? Whilst limited extrahepatic disease can be, may not necessarily be a contraindication to surgery, in some instances it is. And as clinicians, we'll all be aware of those situations where abnormalities on scans are just uncertain as to whether they're metastatic disease or not, and sometimes a trial of chemotherapy can help clarify that. Patients also don't just present with one disease, often they have multiple conditions, and local availability of ablative therapies and expertise is an important factor when choosing wisely about how to proceed in this situation. I just wanted to reflect on the evidence for the use of chemotherapy in the context of colorectal liver metastases. Way back 20 odd years ago, we had the first data on the use of post-operative chemotherapy following on from hepatectomy. And this was a pooled analysis of 2 studies with patients who by today's standards we would consider had very, very good prognosis tumours. 2/3 only had 1 liver metastasis and were randomised to receive adjuvant chemotherapy or surgery alone. Those who received adjuvant chemotherapy after surgery had an improved median progression-free survival of 27 months versus 18 months favouring chemo, but the overall survival was not significant. Approached, but was not significant. It was around this time, 2008, when oxaliplatin data in the Mosaic study was published, where most people moved from 5-FU to include an oxaliplatin doublet as their backbone at this stage. So even at that time, when we had data for 5-FU in the adjuvant situation for liver metastases, people were already moving to the doublet and moving beyond the evidence. The next important landmark study that was published was in perioperative chemotherapy. At the time, There are a lot of thoughts about why perioperative chemotherapy may be helpful or harmful. At the time of the study, perioperative therapy was gaining favour in esophageal cancer and in gastric cancer. The arguments for using perioperative chemotherapy included that it could potentially improve the R0 resection rate. Certainly if a tumour was close to an important vascular structure, having shrinkage of the tumour away from the vein may lead to preservation of that vein, and that may improve the chances of resection. Some patients who were unresectable could be converted to resectable by good tumour shrinkage. An argument that was often floated in many MDMs around the world was that giving some chemotherapy might test the biology of the tumour and tell us more about which patients should proceed to surgery. The theory, again, is that early treatment of micrometastatic disease may be one of the main reasons why perioperative chemotherapy is an advantage. And indeed, putting cells into G0 or killing the cells in G1 or G2 may be advantageous. But of course, perioperative chemotherapy comes with harms as well. Liver surgeons will tell you readily that if you give an irinotecan-based chemotherapy prior to liver surgery, you get steatosis of the liver, and you get an appearance like this seen on the right-hand side of the slide. And if you give excessive oxaliplatin chemotherapy, when the surgeons operate, the liver is often blue and congested from venous congestion, a condition called sinusoidal obstruction syndrome, which again worried the surgeons about post-operative liver failure. And we learned from early expeditions that giving more than 16 weeks of pre-operative chemotherapy resulted in a significant increase in post-operative liver failure. The first study of perioperative chemotherapy was the EORTC, or the Nordlinger study, which looked at patients who had colorectal liver metastases and randomised patients to surgery alone or perioperative chemotherapy with a fluoropyrimidine and oxaliplatin backbone. Again, by today's standards, these would be considered relatively good prognosis patients. The majority had 1 to 3 liver metastases only, which in the hands of most surgeons these days would be considered a very favourable case. 2/3 were metachronous, so presented after their primary had been resected, again a more favourable biological profile. After perioperative chemotherapy, it was reassuring to see only 2 perioperative deaths in the chemotherapy arm versus 3 in the observation arm, suggesting that perhaps perioperative chemotherapy was indeed safe. And whilst again there was a benefit for perioperative chemotherapy in terms of progression-free survival, there was no significant gain in overall survival. And these were exceptionally good risk patients. I'm just going to pop up the overall survival curve here. Here it is now. Remember this curve. We're going to come back to something which looks very much like this in a few slides' time. Overall survival of 55 versus 63 months with a hazard ratio of 0.87 and crossing over at the early points of the curve. In adjuvant chemotherapy or in the perioperative setting, the endpoint that really matters is whether or not you improve the rates of cure of the patient. Simply keeping the disease away for longer in the setting of a curative intent is simply a lead time bias, and it's overall survival that we really must strive to prove in these studies. So the absence of overall survival at that time was still a concern. However, despite the concern over that endpoint, the authors themselves said, although our results were not statistically significant, we believe that perioperative chemotherapy with FOLFOX should be the reference treatment. You could argue that was indeed a very strong and a bold claim for a perioperative or curative intent treatment that hadn't actually proven curative intent or improving overall survival. We then went into the era of escalating therapy. We looked at a number of triplet-based regimes, which unfortunately none of those studies were really randomised in a good way. But we did have a good study called the New Epoch study, which looked at chemotherapy doublet with a biologic. Cetuximab was the agent of choice in that study. This is a study design. Patients who had liver-limited colorectal liver metastases, KRAS wild type after KRAS became the standard for cetuximab patients, they had to have their primary out and could have been left or right-sided before we knew about the prognostic significance of sidedness in relationship to the treatment with cetuximab. There were several stratification factors, 4 or more metastases, prior oxaliplatin therapy, N2 or grade 3 tumours. 257 patients were randomised to a backbone of chemotherapy with or without cetuximab, followed by surgery, and the same chemotherapy post-operatively. The majority of patients had oxaliplatin-based chemotherapy regimes, although a small proportion did have FOLFIRI. Otherwise, the arms were well balanced. The trial was closed after an interim analysis of 123 events, which showed a somewhat surprising result. When John Primrose first presented these findings at ESCO, he said, "The very first time I looked at these results, I thought we got the database round the wrong way. I thought we'd mislabeled those results, and somehow what we had seen was a false finding." What they found, incredibly, was that patients who were treated with more intensive chemotherapy, with the chemotherapy with cetuximab, had a worse overall survival than those who were treated with chemotherapy alone. In that situation, it's a very, very rare finding indeed to know that a combination with a biologic which improves overall survival in incurable patients actually was shortening survival in those in the perioperative setting. So recurrence was sooner, which is a real alarm bell at that time. Again, looking at the endpoints, the overall survival, the progression-free survival was worse with the doublet. However, the response rates were better with chemotherapy and cetuximab than they were with chemotherapy alone. Again, suggesting if you only look at response rate as your important endpoint in a study of perioperative chemotherapy, you may be missing a trick. When, of course, you find a result such as this, you start to look for what are the subgroups who are benefiting or not in that situation. And it looks that the patients who were the best risk, those who had fewer metastases, good differentiation or metachronous, actually derive the most harm. So the good risk patients do worse. So the findings from that study really suggested that chemotherapy and a biologic may be harmful. So we therefore had two studies which showed PFS may be beneficial for 5-FU-based chemotherapy or perioperative 5-FU oxaliplatin, but adding cetuximab was harmful. And still, we hadn't proven overall survival was achieved. And, of course, it wasn't compared to surgery alone. Then came the JCOG study, the Japanese Cooperative Oncology Group. This group enrolled patients who had the primary tumour resected, colorectal liver metastases of unlimited number, age of 20 to 75, liver only, and were allowed prior oxaliplatin provided it had been administered 3 months in advance. Patients were randomly assigned to surgery alone or surgery followed by FOLFOX6 for 12 cycles or 6 months, initiated post-operatively. The protocol was amended midway through due to worse toxicity in the FOLFOX arm than was anticipated, and they were unable to deliver the dose intensity they wanted, so the dosing of FOLFOX was changed. Again, that may be difficult to see on the screen, but the patient characteristics were mixed synchronous metachronous. Again, almost all had 1 to 3 metastases, and most of them were under 5 centimetres and were mostly untreated. So again, a reasonably good prognostic group of patients in this context. And what it found was what they expected to find in the first instance, and that was that DFS was improved with the addition of adjuvant chemotherapy. The same that was seen in the Mitri study early on, the same that was seen in the Nordlinger study early on. We had seen improved disease-free survival. But when they looked at the outcome that mattered, overall survival, they found that the patients who were treated with chemotherapy, if anything, did very slightly worse. And the disease-free survival benefit that was seen did not in fact translate into an overall survival benefit at all. Again, a surprising finding that was unexpected. When they looked at the subgroups, they found that those who were previously untreated and had synchronous disease did least worse with chemotherapy, suggesting if there was a group who might potentially benefit from adjuvant chemotherapy, it might be those in fact who had the worst tumour biology at the start. The authors offered 4 possible explanations why there might be a discrepancy between disease-free survival and overall survival. First of all, if there's a mismatch in post-protocol therapy, that might explain why there's a DFS-OS gap. What does that mean? Well, basically, if the patients enrolled in the study and the patients in the chemo arm get oxaliplatin, but when they relapse, they can't have more chemotherapy because of toxicity, that might mean their survival gain is compromised. Chemotherapy, theoretically, could increase the toxicity, causing shortened overall survival, but we didn't see that in terms of toxic deaths. There could be something called the ATRES phenomenon, which is adjuvant therapy-related shortening of survival, which shows selection pressure for resistant controls. But we never saw that in stage 2 or 3 disease. It may also be that adjuvant therapy may in fact make detection more difficult. So the fact that the liver itself may change in context, in colour, in combination, you may find it more difficult to actually detect the recurrences when they do occur. So, in summary, what do these studies tell us about how to approach chemotherapy in those patients who have liver-limited metastases for colorectal cancer? Well, what it tells us is that the studies, we have to be very careful when we interpret them. Surrogates like response rate, R0 rate, and disease-free survival have not delivered overall survival gains. And overall survival is what really matters when we're looking at a curative intent patient population. Adjuvant 5-FU improves progression-free survival. That's what we know. The evidence for fluoropyrimidine with oxaliplatin is at best weak. In good risk patients, perioperative fluoropyrimidine oxaliplatin improves PFS, but not OS. And adding biologics in patients you're aiming to cure is harmful. So, it may well be that our enthusiasm for chemotherapy, in fact, outstrips the evidence. And before we reach for the chemotherapy prescription pad, next time we have a patient with colorectal liver metastases, maybe we need to think a little bit harder. And finally, this is my home in the sunny town of Dunedin. Thank you for hosting me in your home. I hope I have the chance to return your wonderful hospitality at some stage in the future. Thank you very much.
Sir, excuse me.
I thought you might all want to go off and have your lunch and choose wisely for your lunch. But
that was wonderful talk. Only thing that, what's your opinion about that liver resection in that someone having the favorable profile for the immunotherapy, I mean, MSI high, PD-L1 positive, metastatic CRC, that role, that we have not discussed anything about the IO in the same scenario.
So in the MSI high population in particular, is that your question? Yeah. So the MSI high population is one that was never stratified out in all of these studies because we didn't know about the prognostic significance of MSI high. But what we now know is, as I know you're familiar with, is the extraordinary data you have with PD-1 inhibitors alone, where 60% of people can be cured with monotherapy and as many as 80% of patients can be cured with combination therapy, which I would argue outstrips the survival with surgery in any of those studies. So whilst we don't have randomised data at the present time, the biologic plausibility plus the long-term outcomes in that patient population, to me, would suggest that perhaps surgery should be the adjuvant, and perhaps we should be using PD-1 inhibitors or PD-1 CTLA-4, and only patients who don't respond or progress should proceed to surgery in that situation. Again, it hasn't been tested in a randomised way, but we have the data that we have. Would that be your approach as well?
Yeah, sure.
Yeah. Thank you.
What imaging you use as a follow-up in a case of liver post-resection? Would you go with a CT scan or you would go with an MRI with?
Yeah, that's an absolutely fantastic question. How do you best surveil these patients for the future? And I think that is a resource stratification question as well. In our practice, we use CT scanning the most. I think it's a very good question as to whether or not MRI would have made more of a difference in the JCOG study, if that's the theory that oxaliplatin may change the appearances of the liver. Throughout Europe, for most of the course of the early 2000s, ultrasound was preferred in that context and thought to be more reliable. But imaging itself, like circulating tumour DNA, the frequency of imaging, the intensity of imaging, and the modality of imaging remains one which is more based on opinion than on evidence.
Because, sometimes we do MRI liver and we find additional lesions, which are not clearly picked up in dynamic CT scan.
Yes.
It changes a lot. But in a post-resection case, when you have a large number of surgical clips and everything, then MRI doesn't become that important. So I just wanted to know whether there is a difference in using different type of contrast agents. Like in MRI, you have blood-based contrast agents, you have hepatobiliary contrast agents.
Yeah.
Does that change anything in prognosis? Like you do hepatobiliary contrast agent for better detection of recurrence, something like that you try, or you just go ahead with the standard CT?
For the first question, for the surgical planning component, so those patients who were evaluating for surgery, we absolutely would do 3 modalities: MRI, CT scan, and PET scanning. Absolutely. MRI probably picking an extra 10 to 15% of lesions. And then PET CT also picking up an extra 15% of lesions that you wouldn't expect. But PET scan picking up extra hepatic disease that may actually mean surgery itself is unfavourable. So PET-CT helps the extrahepatic disease and MRI helps identification of that. So that's an important component of that. Restaging the patients before they go to surgery, we make that as an individual decision. If someone has 2 or 3 large lesions only on CT, PET, MRI, all we're looking for is response, and so we just do a CT to restage and then go to surgery. But if you've got very small lesions, you're wondering if they're going to disappear if you ever find them at surgery, so they may require more intensive imaging. So it's very much a case-by-case individual patient approach. And those who have had liver surgery, we're still using CT because, resourcing is a big issue.
Thanks.
Thank you.
Great talk, Chris. So I am curious, in your practice, though, I think you've nicely shown the data of the lower risk patients and the lack of benefit of perioperative or adjuvant chemotherapy. But in reality, if a patient is walking into your clinic, no prior adjuvant therapy, solitary liver met, are you giving?
What would we do now? I think certainly the tide, I think, has turned in our practice, and we're going more and more to surgery straight up front in those patients. Although I think the patients, when you go back to my very first slide, which was the original data, which stratifies out the patients who we cure, the ones who we're actually curing are people who've got 1 to 6 metastases who are largely under 5 centimetres. The rest of it, I think, is actually disease modification. When you look at the long-term follow-up, the long-term survivors are actually under 5 to 10% if you're looking at patients who've got more than 5 lesions or who are already large. So I think we're not curing as many people as we think. Of course, we see these people in our clinics and we remember them. The one who had 15 lesions and we took them to theatre and they were cured, still 10 years later, we remember them. But the data doesn't actually support that that's a large group.
So upfront surgery and then no adjuvant, or are you giving adjuvant?
So I would argue that the patients who've got large volume metastases or high volume metastases should get systemic chemotherapy because they're probably incurable. They should get chemotherapy first and then use surgery as an adjunct. Rather than surgery being the goal, it's an adjunct. And tell the patients we're doing this to modify the duration of your illness. Probably won't cure, but it probably is going to extend your life. I think they live longer with surgery, but do we actually cure them? And I think it's important to be honest with the patients about that long-term data, because the long-term data is not good in those adverse patients. I think it's different to those good risk patients who are the 1 to 3 metastases, who probably, chemotherapy is probably not all that helpful.
Yeah, I mean, it's hard because it's, even in the NCCN guidelines, it's still recommended. And so that one liver met patient, I think we're all still giving chemotherapy. I think it makes us feel better, but, I think talks like this, I think, are great because I think we spare potential toxicity for those patients. So I think sometimes we're treating ourselves for those lower risk, truly curative patients with surgery alone.
I think that's right. That's why we practice evidence-informed practice rather than evidence-restricted practice. Because if we follow the evidence, perhaps we shouldn't be giving it to anyone. But of course, there are patients who will always benefit from the approach. But I think, in general, we have to reflect on the strategy and the strength of our strategy. And the strength of the evidence in those good-risk patients is perhaps not as strong, and it shouldn't be our default go-to. And we should be more selective with that approach. And of course, again, the BRAF mutant patients, for example, are ones who I would consider adverse and who may go to chemotherapy first because they relapse quickly early on as well. So we're putting the molecular context in there a lot more these days as well. The tumour-sidedness is playing into that as well, synchronicity, uncertainty around liver lesions. There's all those factors to consider in those complex decisions also. But isn't it a great time to be a clinician? Yeah. Well, thank you very much. Thank you. I'm conscious of
what will be your approach if there is a significant extrahepatic disease? I mean, suppose that there are some paralytic lymph nodes which are having significant uptake on PET scan. So, do you consider it as curative or palliative?
So the data on resection for paralytic lymph nodes, if they're synchronous, is terrible. They do very, very, very poorly if they have synchronous paralytic lymph nodes. And the number of patients who survive who have retroperitoneal lymph node dissections for isolated paralytic lymph node recurrence is only very, very few. So I think you have to be highly selective about RPLND in those patients. Synchronous liver disease with retroperitoneal lymph nodes, highly selective situations. Liver and lung, very common. Our peritonectomy service will still take occasional patients with peritoneal disease and the odd liver disease. But equally, I think it may be more disease modification, it may be more hope than evidence. Yeah. Thank you.
Excuse me, sir. Thank you for the talk, such a wonderful talk. My question is, suppose a patient comes with multiple liver lesions and it is unresectable. Then is there any role of trace or SIRT in the management of that patient?
So the question is regarding the use of SIRT, SIRT, in patients with initially upfront use. So we participated in the global SURFLOX phase 3 clinical study. Others would have participated with other products there, but unfortunately that trial of chemotherapy with SIRT versus chemotherapy alone was plumb negative, and there was no gain to first-line addition of SIRT in that context. We still use it for patients who have liver-confined disease after several lines of therapy, so we would still use SIRT occasionally, and possibly as a chemotherapy-sparing measure. I think, though, with the publication of the Norwegian data on liver transplantation, it's probably going to mean that those later line patients who have still got liver-confined disease are probably going to be more and more selected for transplantation now, rather than those types of therapies. So I think that SIRT is a small niche now, although we do use that for occasional patients. Recently we had a patient who had chemotherapy refractory disease that progressed through 2 lines of therapy up front, and so we tried internal radiotherapy, a different modality, but it didn't work. So we use it in a very select group of patients there.
Thank you, sir.
Thank you.
We truly appreciate Dr. Jackson for such an excellent presentation.
Thank you very much. Thank you.
And giving us clear insights on decision-making process. Among us, we have Dr. Vivek Chaudhary, sir, Professor and Dean, Pandit JNMC Medical College, Raipur, Director of Regional Cancer Center, Pioneer Clinical Oncologist of Chhattisgarh and Patron of CG Oncologist Association. Sir, we welcome you and we would like you to chair the next session. So, our next panel address is Multidisciplinary Team Management of Hepatocellular Carcinoma, which is moderated by Dr. Vamshi Krishna, Consultant Medical Oncologist and Director of Medical Oncology at AIG Hospital, Hyderabad.
Should I call my panel?
Yeah, I'll call.
Okay.
This session features our expert panel, which I would like to call Dr. Amar Prem, Consultant Surgical Oncologist, Jharkhand Cancer Center, Ranchi, Dr. Ajit Mishra, Surgical Gastroenterologist, ILS Hospital, Raipur, Dr. Pranav Chadda, Consultant Radiation Oncologist, Kokilaben Dhirubhai Ambani Hospital and Medical Research Institute, Dr. Amol Patel, Consultant Medical Oncologist, Army Hospitals, Delhi, Dr. Deepak Ramraj, Consultant Surgical Oncologist, Ramaya Memorial Hospital, Bangalore, Dr. Sania Pandorwala, Consultant Gastrointestinal, Hepatopancreatico-biliary and Peritoneal Surface Surgical Oncologist at KIMS Hospital, Mumbai, Dr. Papuji Meher, Associate Professor, Radiation Oncology at AIIMS, Raipur, Dr. Rajiv Ratan Jain, Associate Professor, Radiation Oncology at Regional Cancer Center, Raipur. Over to you, sir.
Thank you so much. I can count 1, 2, 3, 4, 5, 6, 7 people on stage. So someone, okay, everyone is here. Perfect. I can call all 8. Excellent. So these are my disclosures. I think this is the trend. I have decided not to stick to the trend. Dr. Sendil already showed his view on being in a panel with only surgical gastro and surgical oncologists. So I stick to that. I will not put the same slide, but I'm in the same unique position of being a medical oncologist, moderating a whole bunch of surgeons and surgical gastro guys. So let's see how this goes. This was a 65-year-old male, no comorbids to speak of, HBsAg positive but on meds and HBV DNA pretty much not there. He came with some mild abdominal pain, evaluated an ultrasound, found to have a liver lesion. This was the triple phase PET CT. So there was a triple phase CT along with the PET. Well-defined lesion, segment 5 and 7, measuring 10 centimeter into 3.8 centimeter into 11 centimeter. So large lesion, but confined to segment 5 and 6. Lesion showing enhancement in the arterial phase and a washout. So for whatever reason, patient took some alternative therapy for 4 months. He did not have any new symptoms. And then he came to us in April. This time again he was evaluated, LFT normal, performance status 1, child Pew was A, HBV DNA below levels detectable, right, with this lesion. So if I can just start off with my panel, Dr. Amar Prem, what would be your workup for this patient?
What's the AFP level? Have you done, not done?
We have done the AFP level. AFP was around 150 odd, nothing very high, but it was a bit elevated.
So this appears to be HCC itself.
It is a HCC. Yeah, it's a clear-cut HCC based radiologically. So we are comfortable with the diagnosis. So this is the MRI done now. So in case you want to know, this was the MRI done now. So you can read the report. Large well-defined lesion, 12 centimeters, segment 6 and 7. You are also having a small lesion just next to it in the segment 7. So everything confined to that. There is no involvement of the vessels. There is no involvement of the bile ducts. Everything is free. So Dr. Amar Prem, anything else you would like to know?
So, no, I think workup wise appears okay.
Workup wise anything else?
No. Appears
no? Okay, very good. So can I ask Dr. Ajit, surgical gastro, what would you like next in this patient?
So
you can see the images. I just put 2 images. Could not download the video, but this is the images.
Yeah. So this is the well-defined lesion.
Yes.
And as the PET CT was not showing any metastatic disease, AFP is also 100. So the intent will be curative. Right now, I would like to rule out significant portal hypertension. So I think there is no splenomegaly. Platelet count is also normal.
No, all that are normal. There is no
and
features
no
of CLD.
Then I think he can be operated
Okay.
with the form of hepatectomy. And I think right hepatectomy would be feasible if the FLR is good. So I need a volumetry.
You want the volumetry.
Yeah.
Okay, fine. Anything else? Okay. Dr. Deepak, would you agree?
That's what we'll calculate.
Can you just speak into the mic? Can't hear. FLR, okay. Sorry, I didn't hear that.
Performance status is good.
Performance status is 1.
Yeah, then we can plan for surgery.
Plan for? Surgery. Okay, excellent. So all surgeons are saying surgery. Dr. Sanaya?
Based on your MRI, I will add a CT thorax for the staging completion.
It is negative. It is a non-metastatic liver confined disease, segment 5, 6 and 7.
But since you've said there's another discrete lesion.
Just next to it in segment 7, 9 millimeter.
But that makes it 2 lesions that includes multifocality. Your AFP is slightly borderline high. These patients can undergo upfront surgery, but I would prefer to do a TACE, which might it might light up other lesions even in the other lobe, because that might have lipoidal deposition, and there is chances of multicentricity, and it might downstage and then plan for surgery.
So you would like to do a TACE to look at other lesions in the other liver? I did not.
It's going to be a downstaging procedure, and apart
For
from
TACE,
that,
okay.
multifocality will also be ruled out.
All right.
In the same lobe as well as in the other lobe.
All right. So you want to do a downstaging procedure. My question is, a TACE for a night 11 centimeter lesion is kind of just out of the place. 11 centimeter lesion, you cannot do a TACE. That's my understanding.
So you can do it, but it may require more than one session. What happens is patients are usually not affordable for tear. That's the reason why that I said TACE.
So the tear studies have, we don't have a new interventional person on the dais, unfortunately.
No, we don't.
The intervention person is not there. So can I ask Dr. Deepak or Dr. Ajit to comment on this, because 11 centimeter tear is actually at 8 centimeters. The cutoff for all the tear trials is 8 centimeter. So 11 is kind of pushing the boundary. Would you agree with the TACE, or you are happy with doing upfront surgery?
Yeah, because the AFP level was not very high. The lesion is also not a infiltrative type. It's a very well defined lesion.
Correct.
So in this particular CT scan and with the other reports, my option will be go ahead with the surgery.
Okay. So Dr. Pranav, we keep, yes, Amol.
Though I'm not representing the interventional radiologist, but sometimes is the anatomy, the blood vessels, and such kind of lesions which are borderline for tests. though not in my institute, but I have seen a couple of patients responding well to the test, and
To
after that,
to which test?
to such kind of
Kind of thing.
such kind of lesions, wherein the anatomy is favorable, like single vessel is fitting, and the radiologist feels that the test might be possible. So we are in an evolving field in terms of the tears and tear. I hope the other.
No, I agree that downstaging is an acceptable option, but TACE for a 11 centimeter.
I agree with
that's
you.
The okay. Dr.
Majority
Pranav
will not be done, but sometimes the particular blood supply in that region might be a deciding factor.
So, Dr. Pranav, we keep talking of downstaging and we keep ignoring radiation people. I mean, can we do anything in terms of radiation here?
No, I think the size.
Size is 11 centimeter, but aside from that,
even though.
So, what would be the size at which you are comfortable doing SBRT to the liver?
Generally 3 to 5 centimeter, or if there are 2 or 3 lesions each less than 3 centimeters, would be, and with the particular checklist that it should be the CTP score should be A or B or B intermediate, that is 7. That is what we look for, certain checklists that we point out, but not this case. This case.
No, so the reason why I am bringing about this is, none of these studies are actually done in this sort of a patient where 11 centimeter lesion, which is operable. The surgeons are saying it's operable. So why do any downstaging at all? So Dr. Pranav, your thought on that?
For me, if I have to approach this, and I go by the guidelines, and so there are 2 aspects to this, either it being resectable versus transplant, whether it's for a transplant as well.
So that's the next option I have put. None of the panelists have actually said we can do a transplant.
Yes, so that is what my question would be. So this falls maybe into the transplant category, but we need to check the liver functional reserve. That is how I would think of. But that will be more of a surgical question, but no radiation. This is what I think.
Okay.
As either a bridge therapy or a downstaging doesn't make sense here.
Okay.
For this case.
So Dr. Rajiv, can I ask you, the same patient lands up, it's a resectable lesion as per the surgeon, but would you think of transplant at all, or would you also go for a downstaging with any modality that you want?
Sir, I am radiation oncologist.
Yes, sir.
From my side, radiotherapy is not an option for a 11 centimeter.
Okay.
Okay. As per surgeon, if he requires transplant, I think this will require transplant because it is quite large.
Okay.
Won't be done only with the dissection.
Okay. So Dr. Sanaya, your thought on? Yeah. Yes, please.
The criteria
Thank you,
for SBRT.
Yes.
It is a residual functional liver volume.
Exactly.
That we go ahead with, and if the residual liver volume is okay, and we can always reduce the doses as per the residual volume. That's what matters. Size is no criteria for radiation. Yes, generally up to 15 centimeter I have given SBRT, but remaining rest of the functional liver should be good.
Absolutely, point taken. It's actually the residual liver. 700 cc is what my radiation oncologist keeps telling me, that if I have 700 cc, I'm safe to give as long as the LFT is fine. So that's the other criteria. So I will go back to Dr. Amar. You said you would be happy to operate, but why not a transplant? Any reason why not a transplant? Just because the function is good?
Your liver functions were absolutely normal. HBB DNA was like in non-detectable range. So all these criteria are perfectly suited that this patient can undergo resection. Had it been that my liver functions were deranged, or I would have found that liver is cirrhotic, or my liver volume was inadequate, in all these criteria I would definitely have considered. But in this case, looking at the scan and liver volume also appears fine, my first option will be surgery.
So Dr. Ajit, your thought on this, again the same question to you. You are a surgeon, so you can operate, I understand that, but your other liver surgeons may be able to say that why not do a transplant? So your thoughts on that, and this is the FLR which all of you have been asking for. So this is the FLR, total liver volume around 1200, and the right lobe which you will be removing is around 639. So you are having a decent liver left behind. You are having close to, I guess, 550, 600 cc.
Yes. So the volumetry analysis shows a very good left lobe with MHV. In general, we try to preserve MHV with the recipient. This patient, if would have a decompensated liver disease, then there may be a question of doing a transplant. But at the same time, in any guidelines, 10 centimeter mass is not a transplantable SCC. So transplant is out of question with this size, because if you say BCLC, if you say any guidelines with the 11 centimeter tumor, you don't go ahead directly for the transplant. Then at that time, you might have to downstage to Milan's or UCSF.
So it's very interesting because, you know, our guidelines are changing, you know. 1 year back, our radiation oncologist would have said 11 centimeter, like even now some are saying SBRT not possible, but the guidelines are modifying and you learn as you go across. So I am always a bit confused as a medical oncologist that, you know, you're saying we'll not do a transplant, which was, let's face it, transplant is the only curative option which has the best results. You're having 60-70% cure with a transplant. With a resection, you will not get a cure of that percentage. But just because the criteria says that 3 and less than 3, whereas the criteria are changing even in Japan and Korea.
Criteria is based on the data. So whenever you increase the size, so if you do a transplant at 3 centimeter nodule versus 5 centimeter and the 10 centimeter, the possibility of recurrence is very high. And the transplant, if you are running a cadaveric transplant, you are wasting an organ which could have been used for the non-SCC patient. And if you are using a living donor, then you are again risking one living donor family to the patient who is having very high recurrence. So at that time, you need to select a very good biology patient, and therefore at that time you need to downstage and at least 6 months of period where you can see that there is no significant increase in the AFP and the size of tumor. Then you can actually think about transplant.
Okay,
but
so you're saying is basically a bit of logistics as in terms of the liver as well as this. Okay, Dr. Sanaya, your take on this.
So I think I absolutely agree with what Dr. Ajit is saying, but we have the criteria are increasing, extending. As of now with the extending Tokyo, if it's not poorly differentiated, any size can be transplantable.
So
but
that was because we have no liver transplant surgeon on the panel, because I have heard liver transplant. You're a transplant surgeon? Okay, perfect. So because the transplant surgeon I have heard say that as long as it's in the liver and nowhere out, I can transplant.
So
that is what some have told.
Absolutely right on the fact that your outcomes will not be as great as you are expecting. So might as well operate and keep transplant as a salvage option.
Perfect. Dr. Deepak, you agree with all this? Excellent. So for whatever reason, we also discussed and agreed all with the surgeons. So this patient actually went for a upfront hepatectomy. We did not do any downstaging because, as all the surgeons have said, it's operable. So we went ahead and did a surgery. This was a non-anatomical resection, solitary. The final size was 11.5 centimeter, and like everyone says, that's not really the size that matters, it's the residual liver that matters, it's the functional liver that matters, not the size of a lesion as such. So this was a HCC confirmed on IHC as well, and the final report came as T1B NX. Okay, so I'll ask Dr. Deepak, since you are one of the first who said will operate, what do you think is the outcome for this patient? What will be the 5-year survival for such kind of patient, percentage wise? It's T1B, so you know stage 1 you would call it very happily, but 11 centimeter. Can you just speak into the mic, please?
Even the
margin is 0.1, but that was okay. Yeah. So what's the 5-year survival in this, in your, as per you? Or is 5 years too much? Shall we say a 3-year survival? 60% 3-year survival. Okay. So Dr. Amol, now comes, you know, the pure medical oncology part where I'll breathe a sigh of relief, and now we are in familiar territory for at least medical oncologists. Would you give adjuvant therapy here?
So the data is not good in the adjuvant setting.
Okay.
Sorafenib trial was negative.
The which trial?
Sorafenib trial was negative.
Okay, sorafenib, we are new age medical oncologists. We talk only immunotherapy. We don't talk of sorafenib.
There was no OS benefit. There was some PFS, but then I don't think so there is the data for the IO in adjuvant setting at this moment.
So, okay, this is where the things become interesting. There was some interest coming up. Now, when you look at adjuvant studies, you have the Checkmate 9DX which hasn't come out. You have Emerald 2 which hasn't come out. But you did have the IMbrave 050. Now, IMbrave 050 was a phase 3 study. They looked at patients at high risk following resection or ablation. And the cutoff they have used is a size of 6 centimeter. So, now that way it fits. The initial study did show some small benefit, but the overall survival is not there. So, as of now, it is not recommended, and Dr. Amol is perfectly right. So, this is the ESMO updates of HCC which came out this year, and in that they have very clearly written that as of now, adjuvant systemic treatment with TKI or ICI based regimen is not recommended. Adjuvant chemo is also not recommended after OLT, which is always there. So, this is the latest guideline. So, as of now, no adjuvant. Not because it is not needed, the recurrence is going to be there, but the treatment upfront does not help. That's the idea. Excellent. So, let's, Dr. Deepak, you have operated. How do you follow up these patients?
Can I ask here one question?
Yes, please.
So, somebody asked about this close margin. So anybody would consider here as a consolidation local RT.
A transplant?
So
no, not transplant.
the-
Local therapy. Here.
So the
Local
only-
radiation.
Local radiation.
Only
Local
problem
radiation.
with that histopathology report was it mentioned non-anatomical resection,
Yes.
which we are not comfortable with in your histopathology report. But any margin, if it is negative, is more than enough. You will not consider adjuvant.
Correct. So there is no role for adjuvant radiation as well. It is not a place like head and neck where you will say there is a closed margin, so we will radiate. So that's what. And again, to decide which part of the margin was closed, we don't know. Radiating that much of the volume of liver will be difficult. Dr. Pranav, am I right in that?
Yes, absolutely. Does it make
Perfect.
sense?
So, Dr. Deepak, how will you follow up this patient? Very simple question. How do you follow up such patients post-op?
We have a PIVCA and AFP value from before. We follow them with PIVCA and AFP.
So, is PIVCA a standard approach? I mean, everyone seems to do it. The reports seem to be all over the place. We have seen all kinds of reports of PIVCA. Is it a standard?
It's not a standard, but we recently started doing it.
Okay,
and we've
fine.
noticed that in some patients where AFP was not elevated, PIVCA is elevated.
Okay.
So those, I mean, it's easier to follow up such patients.
Okay,
I
fine.
think it's the marker of vascular invasion. So patient with, it's the marker of vascular invasion. So AFP negative but PIVCA high, the high possibility of vascular invasion.
Yes, but in a post-op setting, how useful is it? Because you know, a patient may turn up to...
AFP, then follow it with the AFP. If the PIVCA was done previously, then...
What about imaging? How often would you do imaging?
So in general, 6 months. 6 months.
6 monthly. Okay, perfect. So the other, Dr. Sanaya, would you also do 6 monthly? Would you do 3 monthly? What's your...
3 monthly. 3
monthly?
ultrasound, a CT scan at 6 months and 6 monthly scanning.
So unfortunately, we are medical oncologists, so we don't believe in ultrasound. We'll either do a CT or a PET or something like that. So anyway, this patient followed up. He had a rising AFP. It went up to 21, which is not very high. But because it was rising, an ultrasound did show something, and then this is what showed in the whole body PET CT. We did an MRI to confirm. There were multiple recurrences all along the resection surface, few along the surface and few outside. So these are the images. So you see the pre-op image showing that big lesion, now a post-op showing a lesion to the side of that. So this is a recurrence within 3 months, early relapse. So what can we do in that case? Dr. Sanaya, your thoughts?
Before that, all cases should be sent to Dr. Sanya now. She predicts.
So the thing is, this looks like probably we missed a positive margin on pathology. We've given it as 1 mm. Maybe there was some region where it was probably positive.
I will call you, Dr. Sanaya, to meet my pathologist and tell her this thing. I'm sure she would love to hear that.
So now that since it is a very short DFS, I would want to give TACE and then operate.
TACE for multiple lesions, it's not one, there are multiple lesions.
There are multiple lesions, both lobes, or it's only along the same surface?
So there are multiple HCs in the segment 7, segment 8, segment 5, few small observations along the resected surface. So it's a multifocal recurrence is what has been mentioned. Multiple confluent in this. So TACE is...
Then, no, I assumed it was just along the resection surface.
Okay. So,
in this situation now, I don't want to give any form of local therapy. I'm going to consult my medical oncologist.
Perfect.
Yeah.
So, Dr. Amol, your thoughts, what are your options? We will take this in 1 minute because if we start discussing immuno, we can go on forever.
So today is one versus rest of the team. Huh?
I'm there with you.
You are there. So he's fit, and I hope it is he's maintaining that child score.
He's fit.
So child score A, and obviously I would now discuss the systemic options. And everybody's favorite Atizo-Bay would be.
All right. So Dr. Amol says it's everybody's favorite. We have a lot of options. These are right now enough options. Now, if you see the study, they have Atizo-Bev, you have Durva-Tremi, you have Nivolumab, Ipilimumab, you have Toripalimab, which is available in India along with Bevacizumab, and you do have Tislelizumab, which is also available in India. You have 5 at least immunotherapies. Now, the reason why we all say that it is a favorite is because the PFS is there. It's around 2.5 months. The overall survival is around 6 months. Now, more importantly, the progressive disease is only 20%, the overall response rate is higher, whereas in Durva-Tremi, your PFS is actually not been met, it's just the same. Your OS is longer, but there is a progressive disease of around 39%. Nivo-IP has a progressive rate of close to 40%, and it also shows you a higher OS, but no PFS. So Nivo-IP was also used against lenvatinib, which is why the PFS is so high there. Toribev is a Chinese mainly data, so the OS is however longer, it's around 24 months. Tislely has close to 40% and no OS benefit, no PFS benefit and absolutely no OS benefit as well. So for us, Etizobev remains the favorite for these reasons, not that we love Etizobev or for any other reason. So agreed with you, it will be all Etizobev at this point. So we have 10 minutes to discuss the next question. 38-year-old gentleman, abdominal pain, again a HbS-Ag positive. He had a single liver lesion, CLD, A6 with PS1, AFP was around 200, there are no varices on endoscopy. This is the finding. So pretty different report. You can see that the liver looks dirty, it's a cirrhotic liver. You have an ill-defined infiltrative lesion now, along with a contiguous PVTT, so LR5, and also some metastatic deposits in the right lobe of the liver. This is left and the right lobe. So BCLC-C with PVTT, no extrahepatic spread. What would you do in that case? Dr. Ajit, you would wash your hands off?
Yeah,
Refer
so
to?
No transplant, no resection.
No transplant. Okay. Why no transplant?
At this moment, no transplant.
At this transplant. Okay. Fine. So at this moment, no transplant. So you would refer to? Medical oncologist. Oh, good. I think medical oncologists have made our way in HCC when surgeons start referring to us. That's a big thing. Dr. Deepak. Systemic therapy. Okay. So Dr. Sanaya, my question is, at this point, should this decision be taken by one person or should we bring in an MDT? Yeah. Because an MDT should include everybody, and we have 3 radiation oncologists on the panel. So what would be your choice at this point? Would you give only systemic? Would you give it some local therapy as well?
Yeah, so there is data that the portal vein thrombosis could be attacked with radiation as well, but that can be taken in a decision with MDT and the medical oncologist and radiation oncologist concurrently.
Okay. Dr. Pranav, radiation oncologist on board now. Would you do anything for that, PVTT?
Yes, so radiation can be given to a PVTT condition, that is feasible.
Okay.
That is feasible, but I'm weighing my options versus.
So in this case, would you be willing to do it? Because again, the IR people are not here on the panel, but the IR people are there everywhere else, and they are happy to give TARE for this.
I'll pass, I'm sorry.
You'll pass,
yeah,
okay.
I'll pass. I'm sorry.
Okay. Would the other radiation oncologists on the panel have any comment to make on this, SBRT versus TARE?
SBRT can be considered, even if it patients of PVTT also, but it's either or. If we can go for SBRT or TARE as well.
Okay, so SBRT or TARE both are equally good, is what I understand.
TARE would have a problem of a non-target embolization in case of PVTT. This would be the only thing against TARE, but as I said, I'll still pass.
You will still pass, okay. So, Dr. Deena, I know you will say SBRT can be done, and I completely agree with you. We will agree that SBRT is probably equal because there's no trial comparing the two.
So this is a very infiltrative lesion on the scan that we have. But usually in those cases with portal vein thrombosis, they can consider TARE along with SBRT to downstage for
TARE
liver
with
transplant.
SBRT, exactly. So I think we are seeing what happens in practice. The surgeons are knowing what happens in practice. Is there any evidence for it? And that's where the things become a bit interesting, because there's no real strong data for most of this thing. Now when you look at locally advanced disease with a VP4, it could be a multicentric single lobe, just a TIV, it could be any of these things, or it could include an extrahepatic disease. So whenever you have a VP4 with single all this, LDT is coming into the picture now. You have to do some liver directed therapy now along with systemic, or you could do systemic followed by an LDT. That's how we normally take it. If of course it's extrahepatic, it's only systemic, you can add LDT later. So Dr. Amol, systemic, LDT, transplant, any role for this in such a patient with no extrahepatic except a PVTT?
So if the patient does very well with the systemic therapy, and let's say he passes on maybe 6 months or more than that, maintains the disease remission for a long time, such patient can be offered the transplant. If
can be offered. Dr. Ajit?
Logistic money and
so
other things
VP4 lesions are generally not a candidate for doing a transplant, because the survival rate, if you compare VP1, VP2, VP3 versus VP4, the survival is very poor. So in general, even the aggressive surgical group from the Taiwan, they also do not do transplant for VP4. As sir said, very highly selective patient who has showing a complete disappearance of lesion with the SBRT and showing a 6-month follow-up with no disease, probably can be taken for the trial basis, but as far as the literature is concerned, it is not recommended for VP4.
So there are case series right now from Dr. Soin's team where they are doing transplant following SBRT, TARE and immunotherapy, which is why I brought the case.
Their majority VP1, VP2 and VP3. Still, their group also not advocating VP4 per se because it shows a very bad tumor biology.
Fair enough. Okay, agreed with you. Though they are doing it, but I agree that this is not great. Excellent. So, Dr. Pranav, again back to you. PVTT versus TARE. I mean, what's your thought? Are you doing SBRT to the PVTT?
Yes, that we can.
You can do that. Okay.
Yes.
So the reason why I bring again, there are plenty of cases. There are several studies which have actually shown that if you can safely do SBRT to PVTT. Again, it requires some expertise and it requires some confirmation from the radiation side, but it can be done. Now, interestingly, there are reports of these, and these were the contraindications which you were talking about earlier. That yes, there are some specific contraindications. Things mainly which lead to the intractable ascites, the poor liver function, hepatic decompensation. Those are the places you would avoid, but otherwise you can do. Now, this was the NRG trial 1112, which showed that there was an overall survival advantage when you added radiation to just sorafenib versus the SABRE. So, you can add SABRE to PVTT especially. Yes, Dr. Pranav.
There was advantage only with the stratification of the dose. So the dose ranged from 27.5 gray, to 50 gray. So what I could make out was that if you increase the dose beyond a point, then only it gives an overall survival, not the entire cohort.
So you give the higher dose. I mean,
no, but there were some patients there which received a lesser dose.
Yeah.
So with regards to the feasibility, yes, an 11 centimeter can be given radiation, but will it translate into an overall survival benefit? That needs to be seen. That is how I would think of. So the higher dose is warranted. This is what I think.
So it's nice to know somebody who has the weapon but doesn't want to use it because he feels it doesn't work in all cases. Good. It's nice to meet such radiation oncologists also who would be hesitant to use sometimes. The reason why I can bring it, this is an interesting study, the Trendy trial. This is a phase 2 study, and this trial closed early because they just did not get enough patients. But whatever was there in this study did show that SBRT patients did better than TACE. So at least in our practice and we are kind of going into a lot of treatment with SBRT, and in fact I regularly push my colleagues to just give the SBRT. They refuse many times, but I push them to start giving SBRT because it does make a difference in our later treatment when it comes to the immunotherapy. Again, this was a trial, I thought I would discuss it with the IR person, but nobody is there. So this was about a dosisphere study which is incessantly quoted to say that TARE is better. Now the dosisphere actually was not a study of TARE versus anything. It just looked at those patients who had around 30% lobar disease. These patients, if you could give higher dose, what Dr. Pranav was talking about SBRT as well, they were found to do better, which to me sounds very normal. If you give more dose of radiation, obviously they'll do better. Again, most of the patients who did well actually underwent resection. So the messages from dosisphere is that if you want to improve your survival, you have to give higher dose, and number 2, you have to try to resect them. If you cannot resect, it will simply not work. That was the messages taken from this. Right, so our patient received SBRT to the PVTT, and these are the images which show the pictures, so anyone who is a radiation oncologist will probably understand it. After SBRT, Dr. Amol, what would you do? This patient has received SBRT to the PVTT. Obviously, it is not a transplantable candidate. Would you add immunotherapy? Would you wait for further evaluation?
After a certain time with the response with a new lesion.
So you would not add immunotherapy. You would want to see the response. But Dr. Pranav just said that, you're having only SBRT is not a curative option by itself in a PVTT. I think that's the message which everybody is giving. So Dr. Sanaya, would you agree with that? You have given SBRT. Would you be comfortable with that, or would you also want to do something else?
So I think I would want my medical oncologist to start the patient on some form of systemic therapy.
Okay, perfect. Again, I agree this is not an adjuvant therapy, it's actually planned multimodality therapy. If I can copy a word from prostate, I think this is what we should start saying. This is a planned multimodality therapy. You should continue to give something else. So typically what we are doing in such cases where you have a PVTT or you have more disease, you should add immunotherapy. And this is what we did. This is the patient who had received immunotherapy, and then we did a comparison. So as you can see, the disease seems to have disappeared and the portal vein is now bland. So Dr. Ajit, at this point, would you want to do anything else? It's 6 months on immunotherapy, doing very well, complete resolution. Images are just, don't look too closely at them. It's a clean image, I can tell you that. It's a CR on imaging?
So now the disease is only on left side, and looking at the CT and the spleen size, so I will see for the how is the liver function actually. If it is,
so you would go for a resection?
So I'll think about resection, right?
In a CLD patient, post-immuno, post-RT,
So
a
that is
resection
why-
would be.
So left lobe, if you resect the left lobe, the remnant would be around 60% still. So left lobe resection can be done, provided the patient should not have any prior decompensation.
So with
I have to
a
see
with a
in that
bland
line.
thrombus in the LPV, RPV, and a bifurcation.
So in the current CT.
No, this the report, above report. The report says that there is still there's a complete resolution, but you still have some thrombus in the LPV, RPV, as well as the bifurcation. So I'm not sure surgery is feasible. Dr. Deepak?
Yes, it's not possible.
No surgery. So would you
there
push
is
for
still
a transplant?
thrombus on the right side or the bifurcation, then we will not go ahead.
Correct. So would anyone want a transplant here?
No.
Anyone in the panel? No? Sanaya, Dr. Pranav, Dr. Amu?
6 months down the line, if he's doing
6 months, yes.
I will probably explore that option, but it's with too many asterisks attached.
Too many asterisks
Yes,
attached.
you have to explain everything very, very clearly, only if you're considering transplant.
Okay. So this is what the ESMO says, that you can consider if it is a liver limited disease, though like you said asterisks are there, but fortunately or not, my liver transplant surgeons do not look at too many asterisks. They decided the patient has undergone a LDT. This is on 18/2/24, and as of now patient is still alive and doing well. So on follow-up, and we did not give any adjuvant immuno after transplant because we didn't know how to give it. So this is what the case happened. We did do a transplant. We have now a few patients, around 7 to 10 patients who have undergone a transplant following immunotherapy and some local liver directed therapy. So it's not a big number, but we do have some patients on this. And that is somewhere what the ESMO also says, that whenever feasible, if you can pen for transplant, go for it. Otherwise suitable for resection, no liver disease, go for resection. That is the recommendation now. So whenever possible, ultimately the most important thing of course is that it has to be a multimodality approach. You cannot decide one by one, you have to decide, and wherever possible, try to push for a liver transplant because that's the only curative option. Of course, with all asterisks, due considerations and explanations and consent, that should be the thing. So as they say, always treat the patient as a whole, not the whole in the patient, and MDT, MDT. That should be the...
Was there any residual disease in that transplant specimen?
As far as I know, there was not. I don't remember the exact report, ma'am, but I think there was
exactly.
no.
Immunotherapy is wonderful.
Yeah, agreed. I agree with that, with you on that. So again, thank you everyone, and if no further questions, I would like to call and welcoming everyone for our annual conference in
I have
Hyderabad.
only one comment,
yes.
that though there are lots of studies and lots of centers are doing transplant for BP4 lesions, but again the biology is the king.
Agreed.
So the waiting time should be minimum of 6 months, as you have rightly waited for
Yes.
6 months. The second thing is there are lots of child A patients due to Hep B and Hep C who decompensate because of development of tumor, and then suddenly they will have a PS3, PS4. And what I have seen that many patients are denied of any treatment because of their performance status has gone down because of development of HRS, jaundice, something, and they are actually the real candidate for transplant. So I think the performance status should be looked upon also on the liver factor, not just tumor.
Agreed. Completely agree with that. A patient is deserving a transplant, none of us would stop. Of course, the availability, cost, all those come into picture. Completely agree. So thank you everyone, and thanks to the organizers for having us. Thank you everyone.
Thank you.
Thanks to all the panelists and the moderator for sharing your experiences. So as we are running late, so it will be a working lunch, and those who have not had lunch, please proceed with that. So now I would request the next starting of the multidisciplinary management of genitourinary cancers, and I would like to request our chairpersons for the next session, Dr. Vivek Chaudhary sir, Professor and Dean, Pandit JNM Medical College, Raipur, Director, Regional Cancer Center, Raipur, pioneer of Clinical Oncologist of Chhattisgarh, and the patron of CG Oncologist Association. Dr. Mayank Devangan sir, Professor of General Laparoscopic Surgery at Raipur Institute of Medical Sciences, Raipur.
Dr. Nawaz Usman sir, surgical oncologist KMC Manipal. Dr. Amol Akhade sir, medical oncologist Nair and Fortis Hospital Mumbai. And Dr. Seema Gulia ma'am, medical oncologist Homi Baba Cancer Center Chandigarh. I request all the chairpersons to be on the And for our session, we begin with the panel discussion on advancing multidisciplinary team approaches in bladder cancer, which will be moderated by Dr. Madhav Tiwari sir. He is a uro-oncologist and a robotic surgeon, Apollo Cancer Center, Raipur. So the session brings together an expert panel who include Dr. Tushar Dhani sir, consultant urologist, Lotus Hospital, Raipur. Dr. Jaswant Jain sir, surgical oncologist, Mittal Hospital, Raipur. Dr. Sunil Kaushik sir, consultant surgical oncologist, American Oncology Institute, Raipur. Dr. Puneet Seth sir, radiation oncologist, Mittal Institute of Medical Sciences, Bhilai. Dr. Satvik Khadar sir, medical oncologist, Apollo Hospital, Indore. Dr. Azam Nawaz sir, consultant urologist, Nawaz Urology Hospital and Litho Center, Bhopal. Dr. Aparna Srivastava, ma'am, consultant medical oncologist, Narayana Health, Kidwai Memorial Institute of Oncology, Shimoga. Dr. Gaurav Gupta sir, consultant radiation oncologist, Bansal Hospital, Bhopal. Dr. Aruni Ghosh sir. Dr. Shrikant Raghavan sir, surgical oncologist, Max, Delhi. I request all the panelists to please come on stage. Dr. Pradeep Chandrakar sir, medical oncologist, Sri Venkatesh. Clinical oncologist, Pandit JNM Medical College.
Hello.
I would request to please post a chair on the stage as we have panelists.
Hello, very warm good afternoon to everyone, and thank you to Balco Medical Center for inviting me. A very warm good afternoon to all the panelists and chairpersons as well. So, my name is Madhav. I work at Apollo Cancer Centers, Chennai, as a uro-oncologist. So, today I would like to discuss a very interesting case with the panel, and hopefully everyone can take away something about bladder cancer. So from the surgical team, we have Dr. Nawaz, Dr. Jain, Dr. Kaushik, Dr. Dhani. From the radiation team, we have Dr. Seth, Dr. Chandrakar, Dr. Gupta. And from the MedOnc team, we have Dr. Kader, Dr. Srivatsa, and Dr. Kose. Right, so this is our index case. He's a 36-year-old gentleman, an office assistant. He's recently married, has no kids. So he came to us with multiple episodes of painless gross hematuria over the course of 2 days, right? So just to start off, I would like to ask the panel first with the surgical team, how would you investigate this patient right in your office when he comes through? Yeah, please. Dr. Nawaz.
As the patient has come for the first time to our office, we will do just the basic investigations, the routine tests, a coagulation profile, and an ultrasound. And then we will proceed. If the sonography shows there is an exophatic growth in the bladder, then we will further proceed with further investigations. Okay?
Sure.
I would just like to add one more thing. I would like to specifically take the history of smoking.
He's a non-smoker.
Okay.
For this case sake, he's a non-smoker.
Okay.
Teetotaler, non-smoker.
Yes.
Anybody else from the Medonc team, for the radiation team, if you have a patient coming to you, would you do anything different?
Yeah, 36-year-old gentleman, office assistant, looks like has no risk factors for bladder cancer. So we evaluate him as for all other causes of hematuria. We will try to root out all other causes. And meanwhile, we also get a complete urine examination to confirm hematuria, and a basic ultrasound we will to get it done first. And if that shows an exophytic mass in the bladder, then we evaluate in terms of bladder cancer.
Right, excellent. So we have some mandatory investigations. These are culture, because trust me, more often than not, a UTI is the most common cause of frank blood in the urine. We also would do a cytology right up front. Yeah. Office-based cystoscopy is very controversial topic in India, because most of us don't have a flexible cystoscope. We have one in our clinic, so we would scope everybody who comes through. And then the point I would like everybody to take away is, if the guidelines say if you have gross painless hematuria, please go ahead with a contrast enhanced CT. Yes, as an extension of our diagnosis, most of us do end up doing an ultrasound, but if you go by the guidelines, they will recommend go straight ahead with the CT. So any other investigations?
Yeah, if the
doctor
if
from
we
the
have got usually office cystoscopy is done with a flexible scope. Of course, I do it, but in most of the cases we do it in the theatre with a rigid scope.
Completely.
And if we find an exophytic growth, and on gross examination by cystoscopy, if it appears to be a deep-seated tumor, or so we investigate him further, and the basic investigation here which is required is MRI, that is the vesical imaging and RADS, reporting and data system. Excellent. Right, straight away, because subsequently I'll be taking this patient for a TURBT, and in this TURBT, after resecting it, doing a good resection, taking superficial and deep tissue separately, I'll also resect the prostatic fossa to look for any extension to the prostatic fossa.
We'll come to that part, sir.
Okay.
We'll come to that on the case base. So I would like Dr. Ghosh right at the end. Right. So I believe you work at Baths, right? You're from Baths Medical Center, right?
Oh, yes.
Yeah. So would you do anything different there? Would you go ahead with an MRI for this patient? There's a very famous trial called the bladder path trial, what you've done in the UK. Would you recommend an MRI for this patient? It does not happen in India, but would you do it in the UK?
Considering the pathway, yes. But again, you need to look at resource stratification as well. I think MRI in this case would be a luxury, not an absolute necessity. I would say, so you have to understand resource stratification, choosing wisely.
Excellent. So just a small word, there is a trial in the UK called the bladder path trial. What it basically does is save time for patients who have muscle invasive disease, where they would do an MRI right up front. Based on the MRI, they would proceed directly to a cystectomy rather than a TURBT. If the MRI says it is looks like non-muscle invasive, they would undergo a TURBT. 59% of patients saved time. So that's a big number in muscle invasive bladder cancer. So yes, we are justified in asking for an MRI. What about a contrast enhanced CT of the chest, or what is the role of FDG PET? Anybody from radiation oncology, medical oncology?
So we would still go for CT caps for staging, and FDG PET possible, but with CT cap is standard of care for staging still.
Dr. Seth? For argument's sake, let's say it's muscle invasive.
Yeah.
Would you recommend a PET? Or would you stick to CT chest and CT? Right.
We should go for alkaline phosphatase and see if it's we are dealing with a high grade thing or not. If it's a alkaline phosphatase more, then that cases only if we are predicting a kind of a metastatic picture or it's a very advanced case, then only we prefer PET-CT. Otherwise, it should not be done routinely as per NCCN guidelines.
Sure, excellent. So I follow the EAU guidelines, and just for a quick recap, cystoscopy is necessary for a diagnosis of bladder cancer. Whether you do it in the office or you do it in the theatre does not matter. We should always opt for cytology to rule out carcinoma in situ. You will see why in this case going forward a cytology was important. And like Dr. Nawaz said, we should, if you are going for a TURBT, get the prostatic urethra biopsied as well. So as far as imaging goes, as per the guidelines, we can opt for an MRI, you can opt for a CT scan, does not matter. Both are equivalent. The MR is only useful when you want to differentiate T1 from T2, which is exactly what that trial from the UK was wanting to do. Most of us in India would end up doing a contrast abdomen and pelvis so that we can look for the upper tract as well. FDG as of right now has no role, but in India we like to do it left, right and center. You will see going forward why, but as of right now no, unless you have some met what you are unable to pick up from the CT. So another important message is MRI, if it is to be done, should be done before the TURBT, right? So Dr. Srivatsa, is there any role for molecular profiling in this day and age?
High-risk tumors, there is a difference in molecular biology, but we don't do the molecular testing upfront when we have diagnosed a disease. So
Anyone on the panel who is opting for molecular profiling?
Not in muscle invasive. Initially, we don't require for treatment.
Dr. Ghosh, what about the UK? What do you practice there?
So ctDNA, urinary tract DNA is still not standard of care, but we just recently did a systematic review where we focused on early bladder cancers and late urothelial cancer perspective, not the other tumor types of ctDNA and UTDNA showing 6 times more, and it was statistically significant data, more efficient than standard of care, but that was just a hypothesis testing. We did it from the Barts Cancer Center. We're going to publish it soon in EUO, but it's still not standard of care.
No. Okay. So excellent. These are some of the markers what we have for bladder cancer, but as per the guidelines, there is not sufficient evidence to use any of this. Only if you are suspecting an FGF3 alteration, especially for patients who are unresectable or have metastatic disease, you would go ahead and test for the FGF3 mutations. Right, back to this gentleman. So he came to me with a diagnosis of a large bladder tumor. The creatinine at the initial presentation with the other surgeon was about 5. There were 2 attempts made at a TURBT. Only 20% of the tumor was resected and the left renal unit was stented. The creatinine fell down to 1.6 and then again creeped up to 2.3. They also attempted a nephrostomy on the right side, which changed the creatinine very minimally. So as of today, his creatinine, as of right this moment, his creatinine is about 2.4, 2.3, 2.4. And this is the report he came with. Again, this is a standard report what we get in our country, a large tumor with the pathologist giving us a report of low-grade papillary urothelial carcinoma. So I had this report reviewed at Apollo, and even they said this has a focal high-grade foci, right? So a large 7, 8, 9 centimeter tumor with a report of a low-grade papillary urothelial carcinoma. So I sent a cytology. So only 20%, if we look at this, only 20% of the tumor was resected outside, not the whole thing. So in all likelihood, they have not biopsied the muscle. So and this is the report we had with a high-grade foci. So I come back to cytology. I always send a cytology as a routine for anybody who I suspect has a bladder tumor, and it came back positive, right? So I also do an ultrasound myself in the clinic, and this was the tumor left behind after the first TURBT, the second 2 TURBTs. So I also do a flexible cystoscopy in the OPD. Is this playing? Yes. So as you can see, this is the bladder neck. The bladder is completely filled with tumor. The entire posterior wall is filled with tumor. You cannot even see the stent on the left side. Even the stent has become encroached by the tumor. Right? So we're proceeding after this to an MRI. I don't have the MRI films, but it was a large broad-based tumor involving both the UOs with hydronephrosis on the right side. Like I said, he came with a PET done outside, an FDG PET, and as you can see, it's a very large tumor. Very large tumor, and a doubtful tumor in the left lower ureter as well. Right? So the story so far is he has had 2 TURBTs. There is 80% of tumor still inside the bladder. The histopathology report says low-grade TCC with high-grade foci. He has a left side stent and a right side nephrostomy in C2. The creatinine is still on the higher side, 2.3, 2.4. He has ongoing hematuria on and off with a hemoglobin level of 9.4. Right. So the next question is for the surgical team. Would you go in and re-resect this tumor? Would you restage this disease, or is there no need?
No, I think in this case, as we know already, there is high-grade foci, and cystoscopy is showing large broad-based mass with high creatinine and bilateral hydronephrosis, which itself is a telltale sign that it is a muscle-invasive disease. So I would not offer him restage TURBT at this stage, because already his creatinine is going up, he is having persistent hematuria. So I would not like him to further delay his treatment.
Excellent.
I fully agree
Dr.
with what he is saying, because even if it is, we have no biopsy proof, but then among the indications of radical cystectomy, apart from muscle invasive, there is something called as high-grade tumors or tumors which you've seen as hydronephrosis is already there. So even I would go with what Dr. Dani is saying and we'll go ahead with the surgery.
You would go ahead with it, okay. Dr. Nawaz?
Yeah, it's a large bulk tumor occupying the whole of the bladder, and despite the fact we don't have a biopsy report showing muscle invasive bladder cancer, we would like to upfront go in for a radical cystectomy
some form of
and
treatment. Okay.
with the lymph node dissection. And in this case, I would ask the patient, because he's 35 years old, I would suggest him SPC, that is sexual preservation cystectomy, if possible at all.
We'll come to that, sir. So this is the importance of a cytology, because that is positive. So even if we say this is a non-muscle invasive tumor, it is so large you cannot complete the TURBT. So T1, G3 tumors, he is a candidate for early cystectomy, even if we say this is non-muscle invasive. So you have something for your medical legal proof, you have a cytology and you have an MRI. Based on that, you can go ahead even with chemotherapy, even with surgery. That is the point I would like to, for everyone to get through. So now I would like to get the radiation oncologists involved. You've seen the CT, you have seen the PET. Would you consider bladder preservation in this patient or sandwich therapy?
We can consider for sandwich therapy, initially neoadjuvant 4 cycles and followed by concurrent chemoradiation.
Dr. Seth, your opinion on it?
Yeah. We can.
Dr. Gupta, Dr. Seth? Yes, 2.3.
So, not a candidate for nurturing chemotherapy, and then comes to macrochemotherapy, as this was urology is not feasible. Radiation, per se, now we are dealing with a large volume disease and this viscosity can't be done. So upfront, radiation is not go.
Excellent, great. So these are the absolute contraindications: tumor associated with hydronephrosis, lymph node positivity, obviously ineligibility of chemotherapy, right? But for discussion's sake, in what scenarios would you recommend trimodal therapy over cystectomy? And is trimodal therapy as effective as cystectomy? A question to the radiation oncologist here, for everyone.
I mean, for early T2 stage or T3 stage in which there is no hydronephrosis or no CIS involvement, and say good bladder function, that case.
Good.
And also in case.
And what would you use as a radiosensitizer if you were to do TMT?
We can use either cisplatin or gemcitabine, both can
Excellent.
be used.
Excellent.
And usually concurrent chemoradiation we can consider in those patients who are, for some reasons they are inoperable, either because of the old age or medical conditions. In that case also we can consider for concurrent.
Right, excellent. A very different question to the medical oncology team.
For
all three
these,
of you.
whether to undergo surgery or radiation, the patient has to consent for a radical cystectomy, and so many times it happens that the patient doesn't want a radical cystectomy with, if you can reconstruct the bladder and all, it's okay. Otherwise the patient may disagree. So in such cases, we have actually considered durvalumab with gemcitabine and carboplatin also, though it may not be there in the guidelines.
Excellent.
Sometimes in real world
that is
it
my
happens.
next question to all the medical oncologists. Do you think that we will see more and more immunotherapy jump into TMT? So question to Dr. Khader, Dr. Ghosh,
Yeah,
everybody.
so although not an official trial out now, but last month only, there was a press release of Pembro plus EV in cisplatin ineligible patients, keynote 905 I think. So they have, it has shown interim results which benefited, there's EFS benefit, but it's just a press release now, so maybe in future when the whole trial is out, and that is specifically in cisplatin ineligible patients. So that's a chemo-free regimen which we can use in such kind of patients.
Right, excellent. So I don't think this patient is a candidate, but excellent. I think going forward we'll see more and more immunotherapy jump into TMT because the results of TMT are as good as radical cystectomy. Both have equal overall survival in the correct patient if you are using it in the correct patient. And even the guidelines say long-term survival rates are comparable to that of cystectomy. Radiotherapy alone should not be offered as that is as part of bladder sparing treatment. It should have chemotherapy within it. And like you said, all patients who opt for, Dr. Srivatsa said, all patients who opt for TMT should be counseled in a multidisciplinary team setting.
Sorry, just to add on the role of immunotherapy, just in the adjuvant and neoadjuvant setting, another trial to look at would be the Niagara trial because of its innovative design. So neoadjuvant cases, just treatment intensification of a muscle invasive bladder cancer setting with 4 cycles of GemCis. You have durvalumab in one arm, and then so that was arm 1, durvalumab plus standard of care versus after post-radical cystectomy, you would have the adjuvant setting durvalumab versus placebo, and strengthening of treatment intensification with immunotherapy increased clinical efficacy endpoints. So they had a dual EFS, and that's one of the primary endpoints, and pathological complete responses secondary endpoints. So that's a trial to look at.
We'll come to that as well. So now let's move back to this patient. What next? Please remember his creatinine is 2.3. So neoadjuvant chemotherapy, what for this patient? Yes or no?
No.
No. But for argument's sake, let's have a discussion on neoadjuvant chemotherapy. Dr. Khader, how would you risk stratify the cisplatin eligibility? Is there a strict GFR cutoff, or do you look at the patient as a whole? What is the criteria?
So if we go by the trial, so they have 3 criteria. The creatinine clearance should be more than 60, and if I remember correctly, the it's specific criteria as per the trial, but clinically, we obviously look for creatinine clearance, and that should be ideally by DTPA GFR and not by Cockcroft-Gault. And second, but sometimes patients who have a reduced GFR, let's say between 40 to 60, where cisplatin split dosing is also acceptable, splitting the dose between day 1 and day 8 of cisplatin. Patient performance status, other comorbidities, cardiac comorbidities we have to look at. 2D echo ECG, because with cisplatin we have to give lots of fluids. So that is one more thing which we have to keep in mind before seeing whether the patient is eligible for cisplatin.
Okay, good. Dr. Srivatsa, as this patient is ineligible for cisplatin, would you still offer carboplatin to this patient?
Yes, in real world we do use carboplatin both as a radiosensitizer along with radiation.
No, I'm talking for
neoadjuvant also.
Would you still recommend carboplatin for this guy?
We can still use based on AUC. We can still give gemcitabine and carboplatin.
Okay,
but actually they have lot of thrombocytopenia and sometimes they bleed also, so it's a little tough.
Dr. Khader, your opinion on carboplatin, to be used or not to be used?
As per the guidelines, carboplatin should not be used, but yes, giving something is better than nothing, because we know direct surgery followed by adjuvant has not that great results. Yeah, so case to case basis carboplatin can be given, but explaining the patient that it might not benefit.
Right, so guidelines recommend no carboplatin, right? Anyways, if there is a patient where you can use neoadjuvant, this is the ABC meta-analysis which shows excellent response with neoadjuvant chemotherapy. Dr. Ghosh, what about DD-MVAC versus gemcitabine? What would be your preference?
Strengthen.
DD-MVAC or gemcitabine cisplatin? What would you recommend for argument, for discussion's sake?
So MVAC versus gemcitabine cis is a nice comparison which I would like to see, but my favorable option would be gemcis.
Yes, because MVAC is also tough.
Would it not?
Okay. Yeah,
I think would be interesting for the results.
Most of us are giving gemcis, but we have excellent evidence from...
In usual practice, the patients are not this young. They are always older than this
I know, that is why I've selected this case.
And MVAC is tough because there is doxo, there is again cisplatin, and dose density is also tough because of neuropathy.
So would you say younger patients like this?
Maybe, yeah,
because
MVAC may be better.
I don't know what we are seeing here or what you are seeing in your practice. In our practice, we are seeing patients sub 50 now with muscle invasive bladder cancer. We have at least 6 or 7 of them lined up. So what would be your recommendation for them? Still gemcis or dense dose MVAC?
Younger patients, if they are cisplatin eligible, then MVAC is okay.
Right. Dr. Khader, your opinion on this?
Yeah, I agree. Younger patients, DD-MVAC is preferable.
Right.
But
so
yeah, it comes with a lot of toxicity.
We have evidence from the Vesper trial that dense dose is better than GC, but like you said, it is more toxic. Right. So now, sorry. Yeah, this is the recommendation. Neoadjuvant cisplatin, the benefit is at 5 to 8% overall benefit. Anybody who is eligible for cisplatin chemotherapy should be given cisplatin chemotherapy as per the guidelines. Now, Dr. Nawaz, Dr. Dani, Dr. Jaswant Jain, would you consider upfront cystectomy in this patient?
Yeah, as we already discussed, patient is not a candidate for bladder conservative surgery, the trimodality treatment, neither for the neoadjuvant. So probably the best thing for him would be upfront surgery.
Right.
Yes, I would consider upfront cystectomy. Already kidneys are dying in spite of diversion. Stented and PCN nadir creatinine is 2.3. He has broad-based large mass. He is bleeding repeatedly, continuously. So I would not like him to wait for it. I would offer him upfront cystectomy only.
Right. So we have a really nice paper by the TMH group by Dr. Gagan Prakash and his team, where we all know neoadjuvant in India is still not being used, and it is not the golden goose. So we have this data from TMH, what says a significant proportion of patients who are even, who can get neoadjuvant, don't get neoadjuvant. And this is a wonderful paper if anybody wants to read it. And their data shows that upfront cystectomy, even in the setting of locally advanced bladder cancer, the overall survival is not so dissimilar to those patients who have had neoadjuvant chemotherapy. I believe this was about 250 or 350 patients. So they have done fairly good.
The OS is similar, but the R0 resection rate is higher.
Of course, but those
PCR
patients
rates.
were those who were ineligible for NAC or did not agree for neoadjuvant. Dr. Ghosh, Dr. Srivatsa, would you recommend upfront immunotherapy in a young cisplatin ineligible patient, or is this still experimental?
No, the neoadjuvant immunotherapy is for cisplatin eligible patients who are planned for gemcitabine cisplatin. Addition of durvalumab, it's better. It has higher PCR rates, higher R0 resection.
Right.
The initial 4 doses of durvalumab gemcis should be followed by adjuvant durvalumab also.
Okay. Dr. Ghosh, would you routinely test for PD-L1 status in these patients, or is that not mandatory?
I would wait for Niagara results and the keynote results, which talk about treatment intensification in the setting. I don't think we're there yet for level 1 evidence, both in ESMO and EAU, in the early setting for upfront PDL and TMB testing.
Right. Dr. Kadir, say you do start these patients on some form of immunotherapy, whether it's added with the chemo or on its own. We'll come to the Pembro talk later. How would you, what are the immune related side effects we should be worried about for these patients?
So most commonly what we see with immunotherapy is fatigue, transaminitis, sometimes rarely diarrhea or pneumonitis. These are some worrisome side effects which we should check regularly. But most commonly what we see is fatigue, which is very, very common, but most of the time it is manageable. Mild transaminitis, skin rashes, we do see commonly.
Okay.
So just in addition to that, eye-related hepatitis. So I work in a very busy acute oncology center treating IO toxicities and stuff. So 40 cases a day easily. IO hepatitis, IO pneumonitis. Recently, in the last month, I diagnosed 5 cases of HLH, immune-related HLH, and 10 cases of ICR-related myocarditis, which is again a challenge. Again, you've got the IO tox MDT, and we're seeing a rise in IO toxicities as per usages, multiple primary types, not just GUs.
Right. Great. Thank you. Excellent. So we have some data that immunotherapy before radical cystectomy, whether you do immunotherapy, whether you do neoadjuvant, they tend to do well, equally well. It's not much difference between them, whether they're doing chemo or whether they're doing immuno. But we have the Niagara trial, what you were talking about. This is the update for the Niagara trial, where they have a 32% risk reduction of EFS and a 25% reduction in risk of death, right? So it is now FDA approved, durvalumab along with gemcis. We also have Pembro with erfotumab vedotin. This is also now recommended for cisplatin ineligible patients, right? And they also have seen good EFS, OS, and complete response rate versus surgery alone. So this patient was cisplatin ineligible, financially ineligible. What next, everybody?
I think cystectomy.
Right. We all know where we're heading. We're heading to cystectomy.
Yes.
So the surgical team, we've done a radical cystectomy, open lap or robot. Very quickly, what would you do?
Open.
I don't have much of the experience, but I think robotic would have been a better option in this case.
Right. Dr. Dani, Dr. Navas?
No, see, I am comfortable in doing open, so I will offer him open only. There are no significant difference in the results. However, that recovery is faster in minimal invasive. So if robotic is available, definitely I'll offer him.
So we have 2 wonderful trials from the one from America, one from UK, the RAZOR trial, which says robotic cystectomy is non-inferior. The emphasis is on non-inferior, which means open is still gold standard. And then we have the trial from Jim Cato in the UK, the IROC trial, which says the only benefit that you get is early recovery and less blood loss, but all of this is limited to 90 days. After 90 days, whether you do open or robotic, it's all the same. So the message should be, we can do anything, open, lap or robotic. Extent of lymph node dissection, Dr. Dani or Dr. Jain?
We do a standard,
extended.
Standard lymph node dissection, because results have shown that extended or super extended yield no more better results than a standard lymph node dissection.
Right. Completely agree. For the want of time, we'll just move forward. So this is the paper from C.R. Danishmand in the US, and it says that extended has not shown any better outcome compared to standard. However, there's a caveat. For this patient, we did an extended because he is 36. Most of the patients in this trial were significantly older. So again, the guidelines say offer radical cystectomy to anybody with teeth. Would you like to say something?
No, in this patient, one more thing I wanted to ask, what we did for the left ureter? We did the frozen or not?
For the?
Left ureter, there was an uptake in the
frozen
PET
for all ureters. Everything is sent for frozen.
So, okay.
Frozen, yes. It came back negative. It came back, the report didn't say negative, it says dysplasia, but we went ahead and did it.
Okay.
So again, guidelines say radical cystectomy for everyone. Hospitals who perform at least 20 radical cystectomies should be attempting radical cystectomies. If you're not doing 20, you should not be doing that. Standard lymph node dissection, not extended. And treatment should not be, this is the most important thing, treatment should not be delayed for more than 3 months from diagnosis, which is what we really struggle with in India. Other things I don't think really matter. This is the report. So he underwent a robotic radical cystectomy with ileal conduit diversion. He came back as PT2N0, and our pathologist said only 14 node removed. Normally when I remove a prostate, they say you have removed 30, but for some unknown reason when I've removed so much, they said you have removed 14. Anyways, so this patient came back as PT2N0 margin negative, right? So question to medical oncology, radiation oncology, surgeries.
What is his creatinine now? Post-op, what is the creatinine?
Creatinine has remained stable. The nadir is now 1.8, 1.6. So adjuvant chemo, immuno, PT2N0 margin negative.
Margins are all clear.
Margins are clear. N0 disease.
No radiation then, yeah.
Right. Okay. So guidelines say chemo is for T3 and above, or patients who have not received neoadjuvant, but he is still not eligible for neoadjuvant. So this is a catch-22 situation. We have data from Ambassador and Checkmate that says, okay, what about adjuvant Nivo and adjuvant Pembro?
Adjuvant Nivo was what I was going to utter. That's NICE approved in the UK, and that is an example of standard of care, so more into that region of thought, basically.
So would you recommend Nivo for him?
Not for him, but there is a role of adjuvant Nivo, but not for him.
Excellent.
Yeah, that is for T3 and T4 for Nivo, Pembro, or even for chemotherapy. It has to be T3, T4 or node positive.
Or patient who has not had
No,
anything.
it's not like that. If the patient has not received neoadjuvant, so upfront surgery, post-upfront surgery, it should be either T3, T4 or node positive. And if he has received neoadjuvant, then YP, T2 and above.
Right, okay, thank you. I think we have run out of time. Thank you, everyone.
Thanks for this.
I request all the panelists and the moderator to please stay on stage for a picture. I request the chairpersons to please add up to the stage and take a picture. Thank you everyone. Now I request for the next debate panel session, Dr. Karnu Charan Patro sir on the localized prostate cancer surgery versus SBRT-RT. I request the chairpersons to please be seated for the next panel. So go on.
So, good evening everybody. I think post-lunch session, slightly excitement debate is waiting for you. So, today we are going to debate about the surgery versus radiotherapy in the prostate cancer, localized prostate cancer. In the thank you, Balco team, for inviting me for the conference. So we have a panelist, group of panelists. I can invite, taking the privilege to invite Dr. Srujana from the AIG Cancer Hospital, Hyderabad. Then Dr. Ramesh Kothari is from local, from Sanjeevani Hospital. Dr. Sarthak Tandon is from the Rajiv Gandhi Cancer Hospital, radiation oncologist. Dr. Manish Sidha, radiation oncologist from Indore, Jupiter Hospital. Dr. Sunil Chopade, medical oncologist from Jaslok Hospital. Dr. Anavarshan Sekhar, medical oncologist from the Actrek Mumbai. Dr. Sai Sriyasa, uro-oncologist from Hyderabad Continental Hospital. Dr. Ashwin Sachdeva, I think he is not there. Dr. Ajam Nawaz, he is there. Yeah. Yes, sir. Dr. Amar Prem is also not there, I think so. Dr. Tushar, and Dr. Rahul sir also not there. Hope I called everybody. I didn't miss anybody. Please, if I have missed anybody, please say take the chair. So just without any discussion, we can go for the discussion. He is a 60-year male present with nocturia, urgency, frequency, not on any medication. PSA is 11. DRE, nodularity per rectal examination, both lobes. MRI and PSMA PET, localized disease. Tumor involves both sides, localized disease, Gleason 4+3. And it is an intermediate risk by DMICO classification and intermediate risk favorable by NCCN classification. So this is the risk grouping. So my talk is, my debate is the moderating the debate, radiation versus surgery. So in the debate, I will take the privilege to discuss about the credibility of the efficacy, cost, complications, continuation of treatment, casualness of treatment, and conflict of the mental conflict in the patients. So my first question to Dr. Srujana, can you I will go to some basics, then I will go for the debate. So diagnostic evaluation, how you prefer MRI and PSMA PET in the...
So I would ask for a multiparametric MRI and also a contrast enhanced PSMA scan.
Yeah. So according to the many articles, many things, PSMA PET to be done, not to be done. If you go to the ISMO guideline, the staging pattern, if it is intermediate risk, high risk, we have to go for the PSMA PET as well as the MRI evaluation. In multiparametric MRI is a must. We have to do to the localize the disease, extracapsular extension, neurovascular bundle involvement, all either T2MI, we should go for T2, DWI, DC and MRS has to be done. So you can see the hypointensity lesion in T2, diffusion restriction in the diffusion weighted MRI and dynamic contrast enhancement, you can see the tumor. So if you see the T-staged based MRI pelvis, the tumor involves both lefts, it is comes T2C intermediate grade. So Dr. Ramesh, do risk stratification you confine to the DMICO or NCCN still?
Yeah, we need to stratify this either DMICO or NCCN, either of it, depending upon Gleason score, stage, and PSA.
Okay. So incision slightly.
Incision is a bit high. DMECO is a bit easy to understand. Yeah, we can just, it can be like localized or advanced disease. Then it can be further subdivided into low, intermediate, and high risk.
So still I follow DMICO, but incision again many stratifications are there. So I Gleason, PSA value and stage. So it is coming as the intermediate risk calcification, but incision if you go for it is a intermediate favorable risk stratification. So before going to the either we should decide the surgery or go for radiation. Shall we estimate the nodal involvement by any nomograms and something, Dr. Sarthak?
Yeah, so traditionally what we used to do is estimate nodal involvement with Roche, but we don't do it now, especially in the PSMA era. We do it something called Briganti. I mean, you can use Yale as well, but as an institutional practice, we follow Briganti because it's easier to adapt to our radiation planning portals as well. So that's how we do it.
So even PSMA PET, MRI that does not have any nodal enlargements, but there is a risk of nodal involvement in the risk of percentage of nodal involvement, yellow formula, you can do that, and where you have to take the Gleason, PSA, T stage, and you can predict the nodal involvement, because if you don't take the nodal involvement estimation, if you do unnecessary surgery, patient will go for the again an adjuvant treatment for that thing. So any surgeons, you surgical oncologists, you want to put a word?
Yes, we would like to do first a biopsy. Now the standard biopsy is an extended sextant, 12-core biopsy. And then we go about with that, how the things are. The biopsy will clarify, first it will get the diagnosis, secondly it will give us the Gleason score. So with the Gleason score we can prognosticate the patient that what's going to be the future. It tells a lot, the Gleason score tells a lot about it.
Yes.
Right?
So again, Dr. Manish, can you put some formula about the nomograms by the extracapsular involvement, nodal involvement?
Okay, so extracapsular assessment is very essential when you are planning for patient for any radical treatment, whether it's for surgery or for radiotherapy. So there are different nomograms also, there are different formulas also which helps us to decide whether there is a probability of extracapsular extension or not. Besides, a good clinical examination is almost of paramount importance. You have to do a good digital rectal examination, as well as the MRIs that we are doing. They are good enough to give us an estimate about the extracapsular extension or not. So the basic remains the same. If you follow the basics, you are not going to falter.
So when you are going for the either surgery or radiation define, so please do the formula, Roche nomograms and ELA nomograms to predict the whether how much percentage are going to nodal involvement, extracapsular involvement and everything. So definitely it is not a unilateral decisions, it is a by uro-onco, med-onco, red-onco, oncopath, radiologist, nuclear medicine, they have to decide what to do further. All should be go to the multi-specialty parent. So we have three options, one go for the ADT plus EBRT, or you can, if those facilities are available, you can go accommodate brachytherapy or the radical prostatectomy with pelvic lymph node dissection. These three things are the main options for this treatment. I don't believe the active surveillance is the one of the options, but some guidelines, if there is a intermediate risk favorable, still they believe that intermediate risk favorable can go for the active surveillance. So if you see the algorithm for this NCCN guideline, intermediate risk, radical prostatectomy, radical radiotherapy plus ADT, brachytherapy and active surveillance is the one of the options you can see in this thing. Even this SIOG guideline also put a word in the active surveillance, but it is a very weak recommendation. So we have to think of radical radiotherapy versus prostatectomy. So definitely, if you are going for radiotherapy, we should add something neoadjuvant system, either by surgical or medical hormone ablation. Dr. Sunil, sir, can you still we don't prefer to go for the surgical? Can you tell about the medical hormonal ablation?
Yeah, so both are the options, but now we have a lot of medical options available, including GnRH agonist and GnRH antagonist. So both options are fair. There should be a discussion with patient about invasiveness and non-invasive options. Certain side effect profile with the medical options available that should be considered, and those are manageable, but definitely in long term we have to consider the side effect profile.
So surgical castration is not a recommended condition nowadays. It should be preserved for the castration resistant or very unaffordable patients. We should that, and medical castration is the standard. So Dr. Sekhar, can you explain whether you go for the agonist or antagonist? So there is a relugolix one is the oral antagonist is there. Yes, sir. Dr. Nawaz, sir.
See, apart from the side effects are significant. In agonist, if the patient is having some cardiac problem, which most of the patients of a prostate are elderly patients, one has to avoid agonists. One has to choose antagonists. Agonists are definitely cheaper in long term, but antagonist is the drug of choice if the patient is having any cardiovascular issues, because otherwise they retain fluid, they go into failures and things like that. Okay.
So antagonist only mostly it is to be monthly, has to be given, and it is slightly costly.
As he has rightly told, my colleague has rightly told, relugolix is now available. Even I am using it, relugolix, quite frequently, and the results have been very encouraging. And some of my patients, down the line 3 months, their PSA has gone to normal. You know, PSA above 60, 70, 100 has come to normal with relugolix only. So injectables have been avoided, and it's quite a cost-effective therapy also, right?
Sir, can you just have a light on the oral antagonist, relugolix?
I don't find any difference between tablet or injectable in terms of antagonists. If a patient is affordable and well educated, I go with tablet form only. Only in those patients where I find compliance will be little difficult, in those cases I prefer injection only.
Yeah. So what is the optimal duration you think the patient should go for the either intermediate risk or high risk population?
It depends on the risk category, sir. What is the risk category patient coming into it, and what modality of treatment we are choosing into the patient. So anywhere between 2 to 3 years we try to consider this treatment for the patient.
Okay. So we have a scenario one, surgeons plan for surgery. So Dr. Sriharsha, sir, can you, what principles, what do you feel, whether we go for robotics, lab or open, and what are the take-home message you will give, sir?
So nowadays I think it's only one choice, sir. It's robotic radical prostatectomy and a standard pelvic lymph node dissection, not an extended pelvic lymph node dissection. This patient being at 60, we can do a bilateral nerve sparing procedure. He'll have a fairly good outcome with a standard lymph node dissection that will give you full histology of everything, and that will be my choice. Robotic radical prostatectomy with a standard pelvic lymph node dissection with bilateral nerve sparing.
So how much it costs, sir, robotic and that lap prostatectomy roughly?
So the cost is actually quality of life of the patient, sir. Robotic actually fares better in that term. If we just say cost in terms of finance, it's a different story. But compared to the open and lab, the learning curve is also much better. The functional results are definitely better. If you ask me in the financial terms, the recovery and return to work is much quicker in robotic compared to open. Open era, the standard used to be 3 weeks catheter, where catheter used to come out at the end of 3 weeks and the return to work also is at the end of 1 month. Whereas robotic, the catheter comes out on 5th day and the return to work is on 8th day or 10th day. So that way it fares better.
So if radical prostatectomy, if there is no adverse pathological reports are there, it is a possibility of cure. More accurate staging, we can get it. Minimal collateral damage, but disadvantage most are the long hospitalization, recovery period, and erectile dysfunction, urinary incontinence is the most adverse effects they. So I think Dr. Ashwin is not there, and Dr. Tushar is Dr. Tushar. Yes, sir. So what are the complications you feel and how you explain to the patients?
Apart from the regular explained complications of surgery, which is common to any surgery, the specific complications, what we call it triad and pentriad of this, is most important is your urinary incontinence. That has to be addressed and patient has to be counseled about it. Now with the advancement of robotic procedure, the incontinence rate has significantly reduced. Now even if most of the time we have seen patient 1 pad a day highest, max. Otherwise they are continent and they will, most of them, they regain continence within 3 to 6 month period of exercise, pelvic strengthening exercise. So that should be counseled. That is because that is the most embarrassing complication after the surgery. Apart from that, then there is a erectile dysfunction. That has to be addressed. And that should not be given, I think in Indian scenario, the priority should be your R0 resection, then preserving your sexual function. So that, about that patient should be counseled. Our priority is R0 resection to make you disease free. In the process, if we are able to save your erectile dysfunction, we will. Otherwise, we will not consider that as a primary option. So these are the two main things. Apart from that, stricture in the anastomotic site, local site recurrence, there is a post-RP recurrence, and then other treatment options like salvage RT and all those things. Those things has to be briefed. But the basic thing is incontinence and erectile dysfunction. These things has to be explained well.
So though I am a radiation oncologist, I am not totally biased. So don't think otherwise. But still I favor radiation people. So what is the pathological report? We should see the location, capsular involvement, gleason, nodal involvement, seminal vesicle involvement, urethral and vas margin, and histological type. So Dr. Amar, I think he is not there, I think so. So sir, Dr. Nawaz sir, you can take this, how frequent after your surgery you go for the radiation in the post-op settings?
We follow up the patients with the PSA, and if required, if the PSA is going up, then we can always get a PET done. If the disease is, if the patient has got some initially residual disease, means extraprostatic spread and some surgery has been done, which nowadays is quite being done. Now, I'm sorry to accept this hardcore fact. Apart from that, if the disease is progressing, then yes, radiotherapy is also one of the good options to treat. And nowadays with our radiation oncologists doing, linear, with the LINAC linear accelerator, I think radiotherapy can yield very good results. So, but apart from this, we have got good chemotherapy also, which of course not my domain, but medical oncologists will tell. We have got first line, second line, abiraterone, then docetaxel and things like that, which will help out the patient to bail out from this recurrence of the disease or slowly progressive disease.
Yes, ma'am.
Yeah, I would just like to add a couple of things here. So what we usually do in our clinic is we usually assess the patient using a CAPRA-S score. That doesn't mean that we are going to act immediately, but the CAPRA score, if the patient is having high CAPRA score, that says that this patient has a very, very high chance of relapse and he might be needing a salvage radiotherapy. So it has to be an informed decision. At this point, you don't have any data supporting adjuvant versus salvage radiation. The data is more towards salvage radiation when the PSA comes to 0.2. But an informed decision making is the key, and you have to discuss the CAPRA score. Almost 30 to 40% of the patients who underwent surgery with adverse pathological features eventually will need salvage radiotherapy. That point has to be made loud and clear.
So, according to the data by Gajadhar et al., so it shows that post-op specimens, more than 50% of the specimens, either seminal vesicle involvement, extracapsular extension, nodal positivity, and obvious persistent artesian margin positivity is there. So what we suggest before going for surgery, better to go for a nomogram. When there is a risk of involvement of nodal extracapsular involvement is very less, we should go for the surgery. So even if there is these adverse pictures are there, we have to go for adjuvant hormonal therapy and adjuvant RT. So as madam told, post-op prostate, there are many nomograms like Mayo Clinic, Capra score, Stevenson nomogram, Decifer score. Now the genetic score also, many scores are there. We have to wait and go for the scoring system. If patient is affordable to do and find out who is in need of post-op radiotherapy. And when you are going for radiotherapy, any of radiation oncologist, when you want to go for radiotherapy, either post-op directly or wait for some period.
In adjuvant setting? You're asking in adjuvant setting? Then probably we'll have to wait. Adequate surgical healing has to be done. It is somewhere around a year or probably 8 months to a year. But if you're talking about an early salvage, then you need to start as soon as you see the PSA is rising. So that's the thing. That
so meta-analysis, artistic meta-analysis says that don't go for the adjuvant radiation after prostate surgery if there is adverse pathological reports. Wait for the urine problems to sort out. And when there is you can go for the salvage radiotherapy, one of the best option. Sir, I think Dr. Sriharsa, you can tell about, you can speak out something about the post-op RT when you feel patient should go, if you are indicating for the radiation for the patient.
So post-op RT, we usually counsel beforehand only, sir, because these days the prostate cancer is more heading towards multimodal than actually a single modal therapy. If it is a high-risk prostate cancer who is being opted for radical prostatectomy, we tell them that there is a fair amount of about 25-30% chance that he will be needing multimodal and a chance of radiotherapy sometime in the future. So when I say sometime, how much time in the future? So the follow-up is standard with PSA itself, unless there is adverse histology like margin positivity or other factors during the surgery. There we go for early adjuvant, which is already coming up in the guidelines. Otherwise, it's just salvage RT where the PSA starts rising. There you opt for post-op RT.
So even NCCN guideline, many guidelines, if you go and when there is adverse pathological report, wait for the PSA raise, wait for the urinary problems to sort out, then go for the radiation if it indicated. So now after surgical oncologist, I am focusing on the radiation oncologist. So definitely we go for the neoadjuvant hormonal therapy as before. So Dr. Srojana, can you tell about what is the radiation era changed from the open prostatectomy to the robotic prostatectomy? Like that the 2-3 months of radiation to the 5 days of radiation, you can highlight what is the methods of radiation?
So from the time I started training in 2010, so the era was 3D CRT. The issue was we were not able to dose escalate. But if you look at all the standard, all the contemporary data, so based on the dose of the based on the dose of the radiation, your outcomes are definitely improving, which is called the main outcome. What they looked at is the biochemical progression-free survival, which is definitely more. So now if you go to the current era, so we are doing IMRT, IGRT and also something called SBRT, where we'll be finishing radiation only in 5 days. But having said that, we need to choose the patient carefully, and then we have to advise for these 5 days radiation. But at any point of time, IGRT is a standard for all prostate cancers. One thing what we need to remember is these prostate cancer patients are long-term survivors because of the biology of the disease. If you don't take adequate precautions or don't take care in treating these patients, at down the lane, even at 10-15 years, they'll be alive and they'll curse you for the adverse effects what they have. So that is the reason we need to be very careful when we choose the modality. And also at the same time, if you're adding radiation, obviously for intermediate risk, we usually give up to 6 months of ADT. And for high risk, we give up to, based on the Middle Eastern data, we usually give only up to 18 months. All the guidelines, if you look at, they say 24 to 36 months, which is a very, very wide interval. 24 to 36 months is 2 to 3 years. There is a 1 year of change. So
only radiation, if you see the era changed from the 2 months of radiation to SBRT, 5 days of radiation.
Exactly. So it started from almost 7 to 8 weeks of radiation to 4 weeks of radiation. Now it has come to 5 days of radiation. Again, not everybody can get all these radiations, but depending on the patient to patient, you choose and take a decision.
And second thing, I think all cities, most of the all metro cities where they have a linear accelerator, they can do prostate SBRT easily, and it is a 5 days radiation. I think 2 months to 5 days is one of the good things, and the histoacrop guideline recommends you have to go for IGRT. Without IGRT, don't do the prostate. So there is a many trials called HIPRO trial, CHIP trial. They told it is a non-inferiority comparing to the old conventional trials with in the sense of morbidity and mortality. Radiotherapy, if you go to the NCCN guideline, you can even high risk population, you can do SBRT and per 5 days radiation if it is fulfilling your IPSS criteria, that scoring criteria. Dr. Ramesh, how to integration of brachytherapy, that not much famous in India, but some few centers do the brachytherapy integration. Can you, Dr. Ramesh, can you add something?
Yeah, brachy can be integrated with external beam radiation. Suppose when we are treating the prostate along with the lymph nodal region, we start with external beam radiation around 45 to 46 gray in conventional fractionation, and then we can add brachy. Brachy again can be added by like LDR or HDR, but to be very honest, very few centers in India are doing it. Most of the people nowadays hypofractionating, doing the SIB.
So slowly it is increasing, the skill is getting transferred. So hope in few years we will have the brachytherapy procedures. And Dr. Sarthak, expected complication of radiotherapy, the public wants to know what is the things you want to specify.
So while I am radiating the patient acutely, I'll be probably looking after, I'll be seeing and very careful about the urinary as well as the bowel symptoms. And I'm probably foreseeing somewhere around grade 1 to 20% of my patients to have these reactions, but not much. And they will definitely not have, as perceived, grade 3 reactions. Not more than 1% of patients have those. So I think it's pretty safe. And in terms of long term, I think these settle down to about 10% patients having mostly urinary problems and bowel problems.
So now the debate, discussions, fightings will start. The people just get ready whether radiation is better or surgery is better. Let's decide, let's audience decide. We will discuss about the cost, complication, continuous mental conflict, casualness of the treatment. So to address this, there is a good trial called PROTECT trial. It is a multicentric trial. It is given to active monitoring, radical prostatectomy and radiotherapy in equal 500 odd patients. And the primary and secondary outcomes, if you see over the 10 years and 15 years, almost similar. The efficacy is almost similar between the prostatectomy and radiotherapy. And if you see the prostate cancer survival, almost the things are prostatectomy and radiotherapy, active surveillance, they hugging each other. So I don't think find any. And metastatic free survival, definitely the active surveillance patient having more metastasis rather than prostatectomy and radiotherapy. Intervention over the time, if you see the follow-up period after prostatectomy, radiotherapy, the intervention is less compared to the plateau region, but active surveillance needs more intervention, and prostatectomy patient is need more intervention, so comparing to radiotherapy in the graph. So Dr. Manish and Dr. Sriharsha, you can fight each other and favor each other. So cost of the radiation versus surgery.
Shall I?
Yeah.
So there are a lot of things over here. Okay. Obviously, as a radiation oncologist and as a hardcore radiation oncologist, I have a lot of points in favor of radiation. It's economical modality as far as a country like India is concerned. If you are comparing cost, robotic surgery in tier 2, tier 3 cities also is now less than 5 lakhs rupees, and then the associated complications. And in majority of the patients, in 50% of the patients, you have to give radiotherapy after that. So I don't find any good reason to be offered the surgery for all these things. careful selection is definitely one of the most important thing. But if the patient is borderline or more than borderline, then and having subjecting patient to both the modalities with a lot of side effects, it doesn't make sense to me. Cost is an issue. As India, you can offer IMIT in 1 lakh rupees to maximum 2 lakh rupees, and the associated complications are also significantly very less.
So in radiation,
I have never seen a post-op prostate patients who have not come to me with a diaper.
In radiation, in the scheme patients, we do our hospital SBRT 1 lakh rupees or 99,000 and IGRT around 2.5 lakhs. Sir, Harsha sir, can you, what is your cost?
So actually the cost has two parameters, sir. One, cost to the institution, and second, cost to the patient. So the cost to the institution, like it's already mentioned there, the radiation equipment is quite expensive. And coming to the robotic surgery, the robots have evolved. They are not the same intuitive which is being offered for the last 15 years. Now we are having an Indian make robo, and we are having 2 Chinese robots which are already in Indian market. There are other 3 systems which are actually planning to come. So the cost has significantly come down. Now in a tier 2, tier 3 city, where like say in Andhra Pradesh, like Vijayawada or Kakinada or Machilipatnam, where you can do a robotic surgery, the cost of robotic radical prostatectomy can be brought down to 2.5 lakhs or 2 lakhs also, if you want to really.
So cost after treatment. So if you see the cost after treatment.
Cost after treatment coming there. So so the diaper cost for the urinary symptoms, that's a nice slide actually. So actually the diapers have gone down, sir. We are not asking the patients to wear diapers these days. We are asking them to wear incontinence pads. They are very small pads which will give us a better count when we see. The diapers actually absorb around 250-300 ml of urine in one go. The incontinence pads takes hardly 50-100 ml. So we are so confident on the surgery nowadays after the robotic this thing, etc. We are asking them to wear incontinence pads, and the number of pads actually gives us a better count. So that is the cost post-surgery, what I mean.
So post-treatment, post-surgery,
post-treatment, yes.
Post-surgery.
After 3 months, we hardly see any incontinence.
Dr. Kanu, I think you made me sit in between the surgeons, and I would like to add a few things as to what, I mean, supporting Dr. Harsha, by the way. So first thing what we need to discuss is the equipoise what we have. And also, more than the cost, I think you need to discuss the quality of life. If the patient is young, fit for surgery, organ confined disease, definitely I think you would, in conjunction with the surgeon, you should push the patient for surgery. At that point, you should not bring the
I am coming to that. The question is for you only.
Yeah, and also not the diapers, definitely.
I think Dr. Nawaz sir and Dr. Sujana,
the other thing,
I will take more 5 minutes. Yeah.
The other thing which I would like to bring over here is, in country like us and with different kind of hospitals and different kind of specialties and having conflict of interest, we don't follow protocol. We do things which are not good for the patient. For example, there are a lot of patients who receives neoadjuvant hormonal treatment and they go for surgery. And then after the surgery, the hormonal treatment continues. So you don't know ki, the patient is A type, B type, C type or D type. So that overlapping adds a lot of negativity to the.
So if you see the outcomes after 12 years are published in this PROTECT trial, it is shown that bowel issues are more with radiation therapy, but that does not need any medication or things. And bowel issues, either fecal incontinence or some other things, slightly more with radiation. Bowels. Sexual issues are more problems, erectile dysfunction or things are more problems with surgery according to the PROTECT trial. And urinary problems, again more problems with active monitoring, because they need more things, and the radical prostatectomy is the urinary issues are more, as you know before. And continuation of treatment, as I told before, because there's no much time, I just wait to finish. The continuation of treatment, after the radiation you have to give hormonal therapy, after surgery you have to go for the urinary patient has to visit many times to your hospital and those things. So continuation treatment, follow-up, that is the more important radiotherapy and prostatectomy. Convenience, Dr. Sarthak and Dr. Nawaz sir, can you
So I'll probably summarize with what everybody is saying regarding cost and complications is just about the CALI. what is the quality of life that you're losing per year? And I think that's important when you're talking about people who are losing their work when you're coming and getting treated. It's just not about the 5 days or 5 weeks. It's about the 2 years, 5 year spans, because we are expecting a DSS of 5 years or more. So I think in terms of convenience and in terms of preserving the quality of life and Cali scores, I think radiation
requires the outpatient department, surgery requires the admission. Sir, Nawaz sir, you want to put something?
Yeah, see, this is an ongoing discussion. If you put a localized cancer, prostate cancer, the radiation oncologist will always favor a radiotherapy. This has been, being followed everywhere. It's a hardcore fact. And surgeons would stress the patient, if the medically fit patients, to a radical prostatectomy or open prostatectomy, whatever it is, right? And as far as the outcome is concerned, once the patient gets a surgical complication, as my colleague has told, incontinence or things like that, or maybe a recurrence or progression of the disease, then patient always feels and gets a second thought that, no, why didn't I get a radiation done? So it's a, win-win situation. I would rather put it this way.
Another issue I want to discuss is the mental conflict. It is seen that almost a similar quality of life score because of the urinary issues. The quality of life score is slightly less with surgical oncologist, surgery. And in summary, the surgery versus radiotherapy, the bowel function is slightly worse in the radiotherapy and urinary problems in the surgery. And I am not going much. So there are many meta-analysis, surgery and versus RT, but I think there is a 4,000 crore of robotic industry. They will never allow to us to go for radiotherapy. They will definitely suggest surgery, but I feel radiotherapy is the one of the standard treatment. Casualness, no conflict, 5 days treatment, that is the fine.
And I think patient should be given the option first.
Yeah. The still multidisciplinary approach is required, and no offense, namaste. So, thank you very much.
Thank you.
Thank you very much, sir. I request all the panelists to stay and for a picture, please. So for the next session, I request our panel discussion and will be moderated by Dr. Vijay M. Patil sir, who is the professor, medical oncologist, Hinduja Mahim, Hinduja Khar and Sonak Thane, Mumbai. So he is going to have a panel discussion on oligometastatic RCC, standard of care. So meantime, I request all the chairpersons to please come. Dr. Shriniket Raghavan sir, who is Associate Director, Surgical Oncology, Max Super Speciality Hospital, New Delhi. Dr. Piyush Shukla sir, Radiation Oncologist, MMI Narayana Multi-Speciality Hospital, Raipur. Dr. Kamlesh Agrawal sir, General Urologist, Surgeon, Raipur. And Dr. Naveen Ram Daruka sir, Urologist and Kidney Transplant Surgeon, Arogya Super Speciality Hospital and Research Center, Durg. Now for this session, the excellent panel featuring would be Dr. Akhilesh Sahu sir, Radiation Oncologist, MMI Narayana Multi-Speciality Hospital, Raipur. Dr. Yamini Bhaviskar ma'am, Consultant Radiation Oncologist, Raipur. Dr. Bharat Bhushan sir, Consultant Surgical Oncologist, MMI Narayana Multi-Speciality Hospital, Raipur. Dr. Arpan Chaturmota sir, Surgical Oncologist, Sanjeevani Cancer Care Hospital, Raipur. Dr. Sujana Priya ma'am, Radiation Oncologist, AIG Hospitals, Hyderabad. Dr. Nishita Shetty ma'am, Consultant Medical Oncologist and Professor, Father Muller Medical College, Bangalore. And Dr. Papuji Meher sir, Associate Professor, Radiation Oncology, AIMS, Raipur. I request all the panelists to please join on this stage. Over to you, sir.
Okay, thank you. Thank Bhavna ma'am and Yashwant for this opportunity. So over the next 10 to 15 minutes, I won't bore you much. We'll be talking about oligomets RCC. Unfortunately, I don't know the specialty of each of you, so please feel free to jump in. So my first question is for Nishita. Nishita, what is the definition of oligometastasis?
So there's no clear-cut definition. As per the ASCO thing, it is 1 to 5 limited disease, not more than 5, 1 to 5. Okay.
So the definition of oligometastatic takes into consideration the number of sites, which according to the EORTC paper and the ISTRO-ASTRO should be less than 5 or less than 5.
it does not take into consideration with how many number of organs these lesions are. So 2 in lungs, 3 in liver, or 2 in brain, 1 in liver, or obviously it just takes into consideration this number of lesions. There is some size criteria are also not there, but most of this would say that the classic oligometastasis should be restricted to below 3 centimeters, ideally below 2 centimeters. And there is a treatment criteria also, where the ISTRO and the ASTRO guidelines put, which they say that functionally you can call it oligometastasis only if the radiation is, that is curative amount of dose of radiation by SBRT is feasible at each of these sites. So the point which I want to make is oligometastasis definition has a big gray zone area. The definition only says 5 lesions, but number of organs, size, and treatment criteria have been put by different people to make it more sensible. Now, my next question is to Yamini. Yamini, how would you define a synchronous oligometastasis versus a metachronous oligometastasis?
So a synchronous one would be where at the initial investigation, the patient has the primary tumor as well as the site of metastasis or within a year, and metachronous would be after 12 months.
Correct. So there are variable definitions here also. Synchronous at the time of diagnosis or within 6 months to 1 year according to different classifications. Metachronous if it happens after that. Now let me go to Bharat. Now Bharat, what is the difference between oligorecurrence, oligoprogression and oligopersistence? Dr. Bharat is not on the panel?
Yeah, so it is clear from the name only, oligorecurrence means if the patient comes to with recurrence after the nephrectomy, and oligoprogression, it progresses to from oligomets to I think multiple mets. And if it there is no change in the oligomets, we will call it oligopersistence.
So, but these three have different kind of notations for treatments. Now, when you talk about oligorecurrence, it by definition can only be a metachronous recurrence, where the disease has gone, like surgery has been done, and there are 3 or 4 lesions which are coming. Oligoprogression is more for the medical oncologist, where you are giving a systemic therapy and the patient has progressed at few sites. That treatment recommendation are different. Oligopersistence means that you are treating a oligometastatic disease, but those lesions are not responding, they are persisting. Each of them have different. For today's discussion, we are talking about oligometastasis. We are restricting ourselves to synchronous oligometastasis and metachronous oligometastasis, and we are not going to discuss about oligorecurrence, progression or persistence. Now, let me come to Dr. Mehra. Does every oligometastatic RCC requires treatment, or is there some oligometastatic RCC which can be kept on observation only? You said that, okay, no, I don't want to treat this patient, I will follow up this patient and will treat at a later point of time.
Depends on the site of the lesion, general condition of the patient. If the patient is well fit and we can patient can be kept on follow-up, we can follow up depending on the number and size of the metastatic lesions. Yes, but we can treat the critical sites because change in size may land up in severe symptoms. So we can treat with the, any kind of local therapy, and also its conjunction is systemic therapy.
Correct. So please understand that there are multiple retrospective analyses which are done for keeping these patients on follow-up, but there is a Lancet paper by Dr. Bryan in which patients were kept on active surveillance. And what was seen in that trial is, if you keep patients on surveillance, and minded this is only for clear cell RCC, large amount of patients were favorable and intermediate, what they showed that the median time to start of systemic treatment is around 15 months. And that was the follow-up schedule which they used. For the first year, they did the scans every 3 monthly. For the second year, they did the scans every 4 monthly. Now, if we dive deep in this data, what we come to know is, if you are going to treat patients who have favorable risk factors, who have, as was correctly pointed out, good performance status, disease is not at any critical site, and he is a good surveillance candidate, this remains a strategy for you. in which the patients can be kept for a long period of time on follow-up itself, and then you could choose when the patient progresses the therapies you want to choose. Now, this is one of the important armamentarium for oligometastatic disease, and especially for those patients who have a metachronous, which means they have been treated and you found the disease on surveillance scans where there are 2 or 3 nodules in lungs, or for those patients this seems to be an appropriate treatment option. Let me go to the radiation oncologist on panel, and Dr. Priya, what would be the role of radiation in all? So you are sitting in an MDT, you get a patient and he has been treated, let's say 10 years back, and 3 or 4 nodules have come up and each of them is 3 centimeters in size, and Nishita wants to give immunotherapy. Would you allow her to give immunotherapy, or you would say that I want to give SBRT first?
I will gladly send the patient back to Nishita, and I will ask her to start systemic therapy. And then if the patient is having an oligo relapse or an oligo persistent disease with a localized area where I can probably chip in, I will gladly take the patient back from Nishita.
I would love such radiation oncologists in my hospital. Yamini, is there a difference of opinion? Would you want this patient who has relapsed after 10 years to treat all 4 lesions, they are not in the no-fly zone, with SBRT?
So in the lung.
In the lung.
Yeah. So in the no-fly zone.
Yeah, in the non-fly zone.
So
I'll make it very specific for you. They are not in the no-fly zone.
So I would definitely consider SBRT to them.
Yeah. So the point I'm going to make is there are obviously a lot of retrospective articles, but there are 2 major articles, one from Dr. Tang and one from Dr. Hanan, and both of them had used SBRT in oligometastatic RCC. These were carefully selected favorable risk patients. These were patients which had a long DF5. They were in situations where the site and the size favored adequate doses to be given, and what was seen was freedom from systemic treatment was 91.3%, but by 2 years it was only 48%. So even there is a possibility that you can do radiation in these patients and again push systemic therapy for a year and a half also in this patients. Now,
Dr. Vijay, I just would like to add a point here. So whatever oligometastatic trials, if you see, I mean, I know RCC is not a part of whatever oligometastatic trials. So they started with systemic first. And then added radiation. So, based on the evidence. If you look at all the David Palmer paper, and if you look at any paper.
It is going to be an MDT discussion. What I'm trying to show you is that there are 2 studies, good high-level data, which shows that with giving radiation SBRT, you can put the systemic therapies for an year and a half, and that option also remains with the patient. So,
especially for a good IMDC score.
Correct, good IMD risk patients. So let's start with this case. This is a 75-year-old male, and this was a proxy visit which came for a second opinion, had diabetes, he has high creatinine, he has blood pressure but is on irregular treatment for that, there are no cardiac issues. He undergoes surgery in 2016 and he has a clear cell carcinoma. There is, and he is an occasional drinker. And there is a recurrence which has been seen. And these are the positions of the nodes, these are media standard nodes. The surgeon has seen. Is there a surgeon on the panel?
Yeah.
Yeah. Would you want to, this is like multiple paratracheal, pretracheal lymph nodes and proven biopsy that this is clear cell RCC, and the DFI of this patient I saw in 2025 is 9 years.
Yeah, so he has like bilateral paratracheal nodes, like mediastinal nodes, and what was his performance score? I think PS1.
Though he's 75, he's a very good fit patient.
Yeah. So it has come with a nodal metastasis.
Yeah.
So I don't think there is much role for upfront surgery because it has come with nodal metastasis, and that too in a different site. Like this node would have been in the vicinity of like in the paraortic area or something in the kidney, I would definitely have considered surgery for this. but it has come as a bilateral nodes, and that too in the mediastinal. The surgery will be too extensive to assess for both sides.
Prashant is here. Prashant is my good friend, and I know he operates a lot of thoracic. Prashant, would you? Proven, Prashant, proven. Yeah. Yeah. Because we were considering tuberculosis when we saw this first. Yeah.
That you can technically operate this patient. There's no problem. You can actually use the mediastinoscopy and approach both 4L as well as 4R and 7. I actually see the common nodes involved as per the diagram. So it's basically the 4R, 4L, 2L and 2L and subcarinal. All these can be accessed. So you can actually do a good mediastinoscopy and clear all these nodes. But in RCC, only mediastinal lymph nodes as a site, I'm not very sure whether you should surgery. But I'm also interested to know why RT is not feasible. That's what is written actually. So
that was the opinion given by RT. I'll let it answered by the radiation oncologist.
So this, there is multi-level nodal involvement here. I agree that the patient had a very good DFI of almost 9 years. But if you look at the literature, you have to dose escalate here a bit, and it's in the central mediastinum. So dose escalation in central mediastinum would be a bit of a problem. So if it's a solitary lesion, then probably it'll make our job easier technically.
Correct. It is in the central mediastinum. That's what our radiation oncologist told. So it won't be able to give adequate doses, and as such, RCC is considered traditionally a radio-resistant disease, so you need to give a higher dose in these situations.
So technically speaking, from the surgical point of view, you can actually clear, you can do a good clearance with an extended, with a VAMLA or a TEMLA. But I'm not sure about the, whether it really would make a difference in the outcome. I'm really not sure, because I have not come across something which has only mediastinal lymph nodes as the recurrence points. But technically with VAMLA, you can do a very good clearance.
So, Nishita, I'll come to you. This patient came to me for an opinion, and I'll put a better slide so that it's seen better. If this patient, we have now at least 6 options in RCC. And how do you choose one of these options?
So the main criteria for choosing is the risk stratification.
Correct.
Because at least we know what, when we should avoid unfavorable.
Correct.
So it's actually not that difficult, because majority of the 3 standard IOs you can use in all risk groups.
Correct.
And then again based upon the morphology.
Correct. So when we were discussing, actually Dr. Murad was of your opinion that if he responds better, I may consider going inside. So because he was elderly, I was first thinking of giving axitinib and pembro, so that but we chose for Lenva pembro because of slightly higher response rates this has, so that we are going to assess him after 2 months to do if any clearances wants to do. With that, this is my last slide, and I wanted to put here is oligometastatic RCC has all treatment options, right from observation, systemic therapy, surgery and radiation. And it will require a multidisciplinary approach to choose one of them. There's no right answer here, and I'm very sure that the choices would also differ upon institute to institute depending upon the technological advances you have and the expertise you have. With that, I open this forum for any questions from the audience and from the panelists also.
I know that you have a flight.
Yeah, if there is nothing, thank you all. It was a wonderful discussion. Thank you.
Thank you very much, sir. I request everyone to please be for just a picture. I request Dr. Yusuf Menon, sir, to please come and become the chairperson. Dr. Manjula Beg, ma'am, Dr. Chandan Bajaj, sir, and Dr. Vivek Tiwari, sir. Please head us and chairperson us. So we have a focus talk on do all hormone sensitive prostate cancer patients need triplet therapy, delivered by Dr. Deepak Dakara sir, who is a consultant medical oncologist, Tata Medical Center, Kolkata.
Thank you, Bhavna ma'am, Yashwant and Balco team. So the topic for discussion is, do all patients with metastatic hormone sensitive prostate cancer require triplet therapy? So before going for triplet therapy, I will discuss the background why this question arises. So metastatic hormone sensitive prostate cancer before 2004, the only treatment was androgen deprivation therapy. So all patients were given androgen deprivation therapy irrespective of whether they had liver mets or they had only bone mets or they had only lymph nodal mets. Androgen deprivation therapy led to CRPC after a few years in all patients, and once the patient had CRPC, they used to die in 2 to 3 years. And all patients were treated as one disease, like whatever was the Gleason, whatever was the nodal burden or bony mets or visceral mets, androgen deprivation therapy was the only treatment available. And after many years in CRPC, docetaxel was the first drug which was approved. 2004, this 2 NEGM trials came, and after docetaxel, abiraterone, enzalutamide, cabazitaxel, olaparib, lutetium, PSMA therapy, they all were used in CRPC. And in 2015, this treatment paradigm changed. CHARTED trial was the first trial which showed that in hormone sensitive disease, addition of chemotherapy to androgen deprivation therapy led to a significant improvement in survival. So this was a trial, androgen deprivation therapy versus androgen deprivation therapy with docetaxel for 6 cycles, 790 patients. The population which was taken in this trial was de novo metastatic disease in 72% patients. This trial gave the definition of high volume and low volume disease. High volume disease was considered as any patient who is having 4 or more bony metastasis, irrespective of Gleason score, irrespective of, and low volume disease was patients other than this high volume definition. There was an overall survival improvement in high volume disease only. Low volume disease patients did not have a significant survival advantage. The difference in high volume disease was 17 months, 34 months versus 51 months, and survival was better in metachronous disease. Low volume disease did not have a statistically significant OS advantage. So with CHARTED trial, it was clear that volume of disease and timing of metastasis were important. Low volume disease fared better, and patients with metachronous disease, they fared better. It was the first trial to show that addition of chemotherapy to ADT improves survival in metastatic hormone sensitive prostate cancer, and based on this trial, ADT with docetaxel became the standard of care in high volume disease. There was another trial at the same time, Sep' trial. It included metastatic disease plus locally advanced disease. 94% patients were de novo, and the 5-year survival was 49%. This trial showed overall survival benefit in both low volume as well as high volume. So CHARTED trial benefit only in high volume disease. Sep' trial benefit in OS in both low volume and high volume disease. There was another trial, GATTEC trial. It was ADT versus ADT with docetaxel for 9 cycles. 52% patients had low volume disease. There was no OS advantage. So 3 trials, different results. First trial showed benefit only in high volume disease. Second trial showed benefit in both high volume and low volume disease. And the third trial showed there was no benefit in none of this group. Then there was a meta-analysis of these trials. This showed that docetaxel appeared to improve PFS and OS for all men except those with low volume and metachronous disease. And the conclusion was men with low volume metachronous disease should be managed differently to those with other type of metastatic disease. After this, trials came for androgen deprivation ADT with AR targeted therapy. So there were 5 or 6 trials, abiraterone acetate with prednisolone, latitude and Sep' trial, enzalutamide arches and enzyme trial, apalutamide titan trial, and darolutamide aronate trial. So for latitude trial was done in patients with high risk population only. The high risk population was defined as patients who had visceral mets or Gleason 8 or more, or 3 or more bony metastasis. So 2 of these criteria should be present. This trial showed improvement in overall survival similar to the latitude, similar to the charted trial, 53 months versus 36 months. And STEMP trial showed a 5-year OS of 60% versus 41%. Post-hoc analysis of STEMP trial showed benefit in low risk disease also. So latitude trial proved in high volume disease, in high risk disease, and STEMP trial showed benefit in both low volume as well as high volume disease. So with the availability of these 2 trials, ADT with abiraterone prednisolone became the standard of care for both high volume and low volume disease. Enzamet trial also showed benefit in both low volume as well as high volume disease. ADT with apalutamide, this trial had 62% patients with high volume disease, 37% patients with low volume disease, and it also showed benefit in both low volume as well as high volume disease, but the benefit was greater in low volume disease. Darolutamide trial recently published, 669 patients, improved radiographic PFS, consistent benefit in both low volume as high volume disease. And the meta-analysis of this trial showed that it was an indirect comparison comparing the efficacy of these combinations. There was no statistically significant difference in the OS. So these 4 trials, they have not been compared with docetaxel, they have not been compared with each other. So indirect comparison shows that they have equal efficacy. So which combination to choose in doublets? So there is no phase 3 trial which has compared ADT with docetaxel versus ADT with abiraterone. ADT docetaxel versus enzalutamide, apalutamide, there was no trial, and ADT with abiraterone has not been compared with ADT with apalutamide or darolutamide. So from the above trials, it was proven that ADT alone is not a standard of care in metastatic hormone sensitive prostate cancer. ADT with chemotherapy or ADT with AR targeted therapy is the standard of care. Volume of disease and timing of metastasis are important prognostic factor. ADT with docetaxel is for patients with synchronous high volume metastasis. In low volume metachronous mets, it did not benefit, and ADT with AR targeted therapy is useful in both high volume as well as low volume. Now we come to the triplet therapy. There are 2 phase 3 studies, PEACE-1 trial and ARASENS trial. PEACE-1 trial is ADT with docetaxel plus abiraterone versus ADT with docetaxel only. It was 1173 patients. It included only de novo patients. Metachronous disease was not included. 36% patients in this trial were low risk, and the addition of abiraterone to ADT with docetaxel significantly improved the radiographic PFS and overall survival. Median PFS was 4.46 versus 2 year. Median OS was 4.7 versus 5.7 year, 1 year of difference, which is rarely seen in solid tumors. Median OS in patients with high volume disease, 16 months difference, 3.5 year versus 5.1 year, and median OS in low volume disease is immature. There is no trial to compare ADT with docetaxel with abiraterone versus ADT with abiraterone. Radiographic PFS, there was benefit in both low volume as well as high volume, but more benefit in patients with high volume disease. And in low volume disease, data is immature. Toxicity, the addition of abiraterone plus the addition of abiraterone to ADT with docetaxel did not increase the rate of neutropenia, febrile neutropenia, fatigue or neuropathy. So toxicity was not different in triplet versus doublet. For low volume disease, there was no significant OS benefit, and a sub-analysis was done which showed that older population derived less benefit. Patients more than 70 of age, they had less benefit. We come to another trial, ARASENS trial, ADT with docetaxel with darolutamide versus ADT with docetaxel. 1300 patients, 86% patients were de novo. Overall survival at 4 years was 62% versus 50%. Risk of death was reduced by 32%. And the benefit was seen in both high volume as well as low volume disease, and the benefit was seen in less than 75 year as well as more than 75. So there is slight difference in the previous trial versus this trial. That trial had only high volume, only de novo disease. This patient, 14% patients were non de novo, and less benefit in 70 year of age in the previous trial, and in this, whether the age is 75 or more, there was benefit. That trial showed benefit only in high volume disease. This trial showed benefit in both low volume as well as high volume disease. And OS benefit was more pronounced in synchronous and high volume disease and less noticeable in low volume and metachronous disease. There is no head-to-head comparison of ADT with abiraterone with docetaxel versus ADT with abiraterone. There is no head-to-head comparison between ADT with docetaxel with darolutamide versus ADT with darolutamide. And after PEACE-1 and ARASENS trial, ADT with docetaxel is no longer a standard of care. An updated systemic review and network meta-analysis of first-line triplet versus doublet that showed that the difference did not reach statistical significance in overall survival between the triplet and doublets. And in a subset analysis, they showed that high volume disease patients had a significantly greater improvement in PFS, whereas no significant improvement was observed in patients with low volume disease. So doublet versus triplet can only be answered through a randomized control trial. So metastatic hormone sensitive prostate cancer, it is not a one disease as it was treated previously. Now it is de novo high volume disease, de novo low volume disease, metachronous high volume disease, metachronous low volume disease, and the prognosis is different. De novo high volume disease have a worse survival, 42 months. Metachronous low volume disease has a better survival, more than 7-8 years, and visceral metastasis have worse survival, 2 to 3 years. And other than volume and timing of metastasis, there are other factors which play a role. So molecular markers like SPOC mutation, retinoblastoma gene, P10, BRCA, P53, these will come in the future very soon in the management and deciding what treatment to be given. Like patients who have retinoblastoma gene mutation, P10 loss, they have a poorer prognosis, so they might be doing better with triplet therapy. So the question is, do all patients with metastatic hormone sensitive prostate cancer be treated with triplet? The answer is no. The best candidates for triplet therapy are those who can tolerate triplet therapy, basically docetaxel who can tolerate, and patients with synchronous high volume metastasis or visceral metastasis. Patients with triple negative disease like retinoblastoma, TP53 negative and PLOS, they can have a better outcome with triplet therapy. And patients who do not benefit, they are low volume metachronous disease, clearly no. Low volume synchronous disease question mark, high volume metachronous disease question mark, and elderly patients question mark. Thank you.
Thank you, sir.
Yes,
Thank you, sir. Yes, sir.
In metastatic setting?
No. In a locally advanced setting, using a triplet therapy for downstaging followed by local treatment. What is your opinion on that, hypothetically?
It will definitely downstage, but I don't know what will be the advantage in overall survival and other things. It can be done theoretically.
So I am aware of a few centers practicing this policy, I mean off-label of course. So just a very... Anyways, very crisp and very robust presentation. Thank you so much.
Thank you.
Any more questions from the audience? Thank you, sir, for simplifying such an important and evolving area of prostate cancer treatment. Now we move on to a special talk on choosing wisely for GU cancers. It is my pleasure to invite Dr. Vanita Nurna ma'am, who is the professor and consultant medical oncologist, Tata Memorial Hospital, Mumbai, to deliver this session.
Thank you so much for the opportunity. I will try in the next 20 minutes or maybe less to talk about my thoughts about choosing wisely for GU cancers. Now, I'm a medical oncologist. There are so many things in GU oncology like robotic surgery, delivery of proton therapy, doing PSA screening, but none of this is my forte. I could give my opinion about robot yes or no and proton yes or no, but maybe that may not be so appropriate. So I will stick to systemic therapy, and I think the whole world is always, when we talk about choosing wisely, the whole world thinks about immunotherapy, I guess, right, and expensive drugs. So I'll give you my thoughts about few of the situations in GU-oncology. So I'll stick to 3 tumors. So I'll stick to kidney, prostate, and penile cancer. So starting with kidney cancer, an adjuvant therapy for clear cell RCC. So we have multiple strategies for adjuvant therapy for RCC. We have data for starting from the days of interferon, then TKIs, then immunotherapy. But currently the most robust data that we have is for adjuvant pembrolizumab as per Keynote 564. So I've just put up the major studies that were done. So we have data for Atizo, Pembro, Nivo, ongoing studies with Durva, Tremi, Nivo, Ipi, etc. But I'll just focus on Keynote 564 and what implications that has for our patients. So Keynote 564, the most recent update, so the 4-year overall survival update with 70% OS maturity, told us that giving a year of adjuvant pembrolizumab in patients who have completely resected clear cell RCC and were at a risk for disease recurrence, if they received a year of adjuvant pembrolizumab, they had an absolute OS benefit of about 6%. So from 86% with placebo to 91% with adjuvant pembrolizumab. So this was a statistically significant and a clinically meaningful benefit for adjuvant pembrolizumab. So, and in the subset analysis, it appeared that all of the pre-planned subsets did have a benefit from adjuvant pembrolizumab. Going back a little bit to the adjuvant TKI era. So we had many studies with adjuvant TKIs. The most, one of the most pivotal studies was the ESTRAC study with sunitinib. And that actually showed a DFS benefit. So in the ESTRAC study, adjuvant sunitinib led to about a 10% improvement in DFS at 5 years. So from 48% improved to 58%. However, there was no OS benefit. So the 5-year OS was pretty good in both the arms at 80%. So with all the caveats of cross-trial comparison, just putting the data of Keynote 564 against the ESTRAC study. So if we closely compare these two, the numbers look like they are pretty similar. So the 4-year DFS with 1 year of adjuvant pembrolizumab is 65%, and in the ESTRAC study, the 4-year DFS with adjuvant sunitinib was about 60%, so relatively in the same ballpark. And the 4-year OS for adjuvant pembrolizumab is reported to be 91%, and the 4-year OS with adjuvant sunitinib is 85%. So not doing so bad. The adjuvant pembrolizumab is approved. It has an ESMO MCBS score of A, and the NCCN guidelines lists adjuvant pembrolizumab as one of the standards of care in patients with stage 2 as well as stage 3 and metastatic, so M1 NED disease. But just to note that there are multiple options in NCCN, and you can see that NCCN still recommends surveillance as a pretty reasonable option for all of these situations actually. So concluding for adjuvant therapy for a clear cell RCC, adjuvant pembrolizumab for 1 year is the current standard of care in a patient with resected clear cell RCCs in all risk groups. But adjuvant sunitinib could be considered. Many of our patients cannot afford a year of adjuvant pembrolizumab. So adjuvant sunitinib may be considered in high-risk patients after a shared decision with the patient. Active surveillance still remains an acceptable option, or the use of shorter course, lower dose immunotherapy drugs or cheaper immunotherapy drugs as generics are coming down the pike relatively soon. Moving gears to metastatic RCC, and we just heard a lot about metastatic RCC. So putting the data just in one slide, so a little bit of a busy slide, but there are multiple first-line treatment options for metastatic RCC. We have data for IO plus IO, so Nivo plus Ipi as per Checkmate 214. We have data, and the most robust data I think that we have is for IO plus TKI, and this is what most of us use in the clinic. So we have Pembro Axi as per Keynote 426. We have Avelumab plus Axi as per Javelin Renal 101. And we have Nivo plus Cabozantinib as per Checkmate 9ER. We also have some data for pembro plus lenvatinib as per the CLEAR study. And then we have the older data, which was our good old TKI alone. So we have data for cabozantinib alone, and we have data for sunitinib or pazopanib as a single agent therapy, which actually has served as the comparator arm in most of these other landmark studies. So just focusing on the 3 regimens that we use most frequently in the clinic, so pembro axi, nivo plus cabo, or pembrolizumab plus lenvatinib. So relatively similar results, objective response rate about in the range of about 50 to 60%, CR rate of about 10%, and a median PFS in the range of about 15 to 16 months. The best data we have in terms of response rate and in terms of PFS is for the pembro lenvatinib. So pembro lenvatinib leads to an objective response rate of 71% as per the CLEAR study, and a CR rate of about 16% with a pretty long median PFS of almost 2 years. So pembro axi seems to be the safest regimen, most pragmatic, and is guideline favored in all of the risk groups, and probably the best real world option for our patients. Nivo plus cabo balances between safety and efficacy. Pembro plus lenvatinib is a very toxic regimen, so about 70% of patients had grade 3 and higher adverse events. So this is not an ideal regimen in LMICs with logistic challenges, supportive care, requirement for hospitalization, etc. So what do we choose in our real world LMIC data? So if axi, pembro or cabo, nivo are the best TKI plus IO combinations, how do they fare against the IO-IO combination? So we don't have a clear answer. So some points to consider. So if your patient requires an immediate tumor control, so if the patient is very symptomatic, has a high tumor burden, is in visceral crisis, then it's better to add the TKI. So IO plus TKI is a good option because that has a better response rate and a faster response. If the patient is fit, he's clinically stable, and your center can manage IO toxicities quite appropriately, then an IO-IO combination is appropriate. If the patient has a history of autoimmune disease, history of organ transplantation, or cannot tolerate severe IRAEs, then I would avoid an IO-IO combination, consider TKI monotherapy, or carefully chosen IO plus TKI. In our LMIC setting, the pragmatic choice often hinges on drug availability and cost. So oftentimes continuous IO plus TKI is not financially sustainable for most of our patients. It depends also on the acute care capacity. If the center lacks easy access to inpatient steroids or immunosuppression expertise, IO risk of severe IRAEs may be hazardous, and we require follow-up feasibility. So our patients who are on TKIs require to be followed up pretty frequently because of BP and LFTs, etc. So I just wanted to give you a little flavor of what we are doing at TMH. So many of our patients are unable to afford full dose IOs, and we have treated them with IO plus TKI, but the IO is low dose nivolumab. So low dose nivolumab plus cabozantinib. A mix of patients with clear cell as well as non-clear cell RCC in the first line setting. And the response rate was, so this is a small cohort, only 67 patients, but a very respectable response rate of about 60% in the clear cells, 50% in the non-clear cells, and a very respectable PFS as well. So in the clear cell, we did not attain the median PFS, and in the TKI plus low dose IO, and the median PFS in the TKI alone was 9.9 months. In non-clear cell, the response was a bit less, so the median PFS was 6.7 months in both TKI plus low dose IO versus TKI alone. So preliminary data from smaller studies show encouraging efficacy for TKI plus low dose IO, and this needs to be studied further. So to conclude, for RCC, TKI plus IO is probably a cost-effective option for LMICs with excellent response rate, good symptom control, good safety data, requirement for lesser hospitalization, clear improvement in overall survival, and applicability in all risk groups. TKI plus low dose IO appears to be a promising option, and we have some retrospective data. It needs to be further studied, and there's evolving data for the combination of TKI with newer affordable IOs. So moving gears to penile cancer. Now penile cancer is worldwide, it's a rare tumor, but it is actually a relatively common tumor in some parts of the world, including India. So India, South America, and Africa have the highest incidence of penile squamous cell carcinoma. In India, annually, we have over 10,000 patients with penile cancer every year. And in a patient with early resectable penile cancer, the most important prognostic factor is the presence of lymph nodes, so the involvement of lymph nodes. And the 5-year cancer-specific survival for patients who do not have nodal involvement is about 85 to 100%. But involvement of the lymph nodes, particularly N3 involvement, drops the 5-year cancer-specific survival to less than 10%, so 0 to 7%. So huge reduction in survival with involvement of lymph nodes. So this was a study that we had done in 2012, in which we found that delivering adjuvant chemotherapy with paclitaxel and platinum to patients who had high-risk penile cancer, so involvement of lymph nodes, so multiple inguinal lymph nodes, pelvic lymph nodes, or extranodal extension, led to an improvement in survival. So if patients were able to receive 4 cycles of adjuvant platinum and taxane, they had a median DFS of about 23 months. But patients who did not receive 4 cycles, they had a median DFS of 2 months. So a huge difference in disease-free survival. And this study was then incorporated into the various global guidelines, which then led to the recommendation that adjuvant chemotherapy should be given to patients with high-risk penile cancer. And we then just completed this study this year, which we presented at ASCO. So this was an open-label randomized non-inferiority study in which we compared platinum and taxane to platinum plus 5-FU for patients who had undergone curative resection for high-risk penile carcinoma. So this was the trial schema. Patients were randomized to platinum 5-FU for 4 cycles or to platinum taxane for 4 cycles. And then they were discussed in the multidisciplinary joint clinic for whether they required adjuvant chemoradiotherapy. So these were the efficacy outcomes. There was no difference in terms of disease-free survival or overall survival between the 2 different adjuvant chemotherapy regimens. But there was a huge difference in tolerability. So platinum and taxane was significantly less toxic with less grade 3 toxicities, less requirement for hospitalizations, and far better acceptability. So 4 cycles of adjuvant chemotherapy could be completed in 83% of patients who receive platinum taxane as compared to only 55% of patients for platinum and 5-FU. So this was the first ever randomized trial in high-risk penile squamous cell carcinoma after curative resection. The manuscript is under consideration, so it has been submitted. And we found that adjuvant chemotherapy with taxane and platinum led to a similar survival, but was with significantly fewer toxicities, fewer hospitalizations, and higher treatment completion rates than 5-FU platinum. And the receipt of chemoradiotherapy was an independent predictor for both disease-free and overall survival. So moving this to the neoadjuvant setting, so the standard of care currently for neoadjuvant therapy for a patient who has these large fixed inguinal nodes who cannot go directly for surgery is triplet chemotherapy with taxane, ifosfamide, and platinum. But very recently, this year, there was this provocative study that was published from China in which they gave a 5-drug regimen. So they used the triplet chemotherapy regimen and they added an IO, so they added toripalimab, and they added an EGFR inhibitor, so nemotuzumab. And they found very remarkable responses. They found that the objective response rate was 82% and the PAT CR rate was almost 50%, so 48% was the PAT CR from this regimen. Now this is a very promising regimen, but this is not cost effective in our setup, and it was a very toxic regimen as well. So this led to so we have planned this study currently, and the reason to show this is that we would be very grateful to collaborate with any center who would like to collaborate, who sees penile cancer. So this is patients who have locally advanced resectable penile squamous cell carcinoma but require neoadjuvant therapy, and they are randomized to the standard neoadjuvant, either 2-drug or 3-drug regimen based on fitness of the patient, or to this regimen of neoadjuvant chemotherapy, which is weekly platinum and taxane with triple oral metronomic chemotherapy and low-dose nivolumab. And the primary endpoint is pathologic CR. And just to show you this, we have used this regimen in several patients in our clinic. So this was a patient with a very, very advanced primary, large fixed inguinal nodes as well as large pelvic nodes. He received 8 cycles of weekly taxane platinum and triple OMCT and 3 cycles of nivolumab. This was the follow-up. He had a near PET remission, and he's awaiting surgery currently. And we had published this real-world data of the use of oral metronomic chemotherapy in patients with locally advanced metastatic penile squamous cell carcinoma. Again, a very well-tolerated regimen, only 18% grade 3 and higher toxicities, good response rates. Again, this is a small study, but gives you a flavor of what we can possibly do for our patients who cannot tolerate. A lot of these patients are very sick with penile cancer. They cannot tolerate triple drug chemotherapy, but this oral metronomic chemotherapy, low-dose nivolumab, has led to a lot of good responses with less toxicity. So concluding for penile cancer, the first randomized trial in the world for adjuvant therapy in penile squamous cell carcinoma from India shows convincing tolerability, good compliance, similar survival outcomes for taxane platinum chemotherapy over platinum 5-FU. Triple oral metronomic chemotherapy is active in patients with penile squamous cell carcinoma. This strongly warrants formal testing in prospective clinical trials, and we strongly encourage participation in clinical trials. Anybody who would like to collaborate, please come up to me afterwards and let me know. We would love to work together. So in the last few minutes, I'll just talk about prostate cancer. So in metastatic castrate-resistant prostate cancer, full-dose abiraterone at 1,000 milligrams taken in the fasting state is a standard of care. We asked the question as to whether lower dose abiraterone, so 250 milligrams with low-fat breakfast, leads to similar oncologic outcomes. We presented this data at ASCO this year, and we found that lower dose abiraterone, so 250 milligrams with low-fat breakfast, led to very similar oncologic outcomes, very similar toxicity, same quality of life. We also checked PK/PD, so pharmacokinetics. We found that, these are the survival outcomes. So very similar DFS, very similar OS. These are the PK numbers. So there was, with the full dose abiraterone, there was an 8-fold higher PK level, so higher drug levels with full dose abiraterone, but same oncologic outcome. So even though low dose abiraterone leads to lower drug levels, there is no difference in oncologic efficacy. So again, this somewhat challenges this traditional maximum tolerated dose, maximum drug level paradigm that we have for developing the approved drug doses. So lower dose abiraterone is a very good option in our setup. So this was in castrate-resistant prostate cancer. Moving to metastatic hormone-sensitive prostate cancer, we just completed a study with triplets, so with docetaxel, low-dose abiraterone, and ADT. We have just completed recruitment this month, and we are awaiting analysis of the data. Dr. Deepak just told us about, do all patients require triplet therapy for metastatic HSPC, and we don't know the answer to that. The standard of care as per Arisons and PEACE-1 is yes, everybody requires triplet therapy, but this adds a lot of systemic and financial toxicity. There are very limited post-progression options, and many of our patients, up to a third of our patients, have PS2 or greater and may not tolerate triplet therapy. So that leads us to my last couple of slides. So we have just started this study at Tata Hospital as well as at Varanasi. So this is the MAP prostate study. So MAP is molecularly adapted therapy for prostate cancer. So this is a phase 3 investigator-initiated open-label RCT, and patients are randomized. So patients have in the first-line setting for metastatic HSPC, and patients are randomized to the standard triplet therapy, or to arm A, which is a cohort in which we are doing upfront NGS. So NGS is tissue NGS preferably, or liquid NGS is possible. And then based on what we find in the NGS, so if the patient is in cohort A, which means that we detect at least 2 out of the 3 mutations, so TP53, RB1 and PTEN. So that is a chemotherapy sensitive cohort. So they will be treated with ADT plus taxane plus minus platinum. If they do not have 2, so they have 1 of these mutations, then they are a hormone sensitive disease and they will be treated with just hormone therapy. So ADT plus either ABI or abiraterone, enzalutamide or apalutamide. Or if they are in cohort C, which is HRR positive disease, they will be treated with ADT plus ARPI plus a PARP inhibitor. So to conclude, the largest randomized data comparing low dose versus standard dose abiraterone in patients with metastatic CRPC showed comparable efficacy, good safety, and similar survival outcomes. In patients with metastatic HSPC, triplet regimen with low dose abiraterone has been systematically tested, and molecular characterization of tumors in patients with metastatic HSPC may help us to guide more effective treatment modification or de-escalation in patients who have better expected outcomes without impacting survival. So thank you, and I will end.
Thank you so much, ma'am, for that practical and insightful perspective. Now I request Dr. Prashant Penunmandu, sir, Medical Director and Head of Department, Surgical Oncology, SVICCAR Tirupati, to share his insights on a talk on optimal management of gastric cancers. It's my pleasure, sir, to welcome you.
Can I have my slides up, please? So at the outset, I would like to thank Dr. Bhavna, Dr. Divakar, Dr. Shravan for having me with you. And over the next 15-20 minutes, I'll be taking you all through optimal management of gastric cancer. Actually, it's made my job easy because over the last 2 decades, being a surgeon, nothing has changed in the optimal management of gastric cancer, and it has remained D2 gastrectomy, and it is still D2 gastrectomy. So luckily, we have done a little bit lesser. We have started doing lesser surgeries now, which actually has increased outcomes. So introduced 5th most common cancer, and it is one among the top 6 cancers in India. That is something which is very important. And Mizoram, Chennai, Mumbai and Delhi, are the highest incidences of gastric cancer. Even in southern parts of Andhra Pradesh too, the incidence of gastric cancer is quite high. As you all know, surgery for gastric cancer, probably if you ask me, is there any one modality of treatment? I would say surgery is the only proven modality of treatment, and importance is to remove all gross disease. But unfortunately, there's a lot of controversies as well as confusion regarding this one single most important treatment. We don't get to see these kinds of tumors in our country, but yes, a small note on early gastric cancers. These are diseases that are those confined to the mucosa or to the submucosa, wherein you can treat them with endoscopic resections or maybe partial gastrectomies or wedge resections, if not amenable or feasible for endoscopic resections. So these are some of the indications when you got to do an EMR or you got to do an endoscopic submucosal dissection. We'll not get into the details, but overall you need to have a very good, well-differentiated tumors and less than 2 centimeters. You can also perform ESD up to maximum up to 3 centimeters. This is something, these are very important gastrectomies. So now coming to gastrectomies, the Japanese guidelines have defined them as standard and non-standard. Standard is something which we have been doing. I think it's just a new nomenclature that we are coming across. So this involves a distal or a total gastrectomy. So when I talk about distal, it is not exactly distal. It is about 2/3 of the stomach, along with omentum as and when lesser as well as greater omentum and lymph nodes. So the non-standard gastrectomies are something which are modified or extended. So it can be a modified gastrectomy where you have a proximal, where you have a pylorus preserving, or it can be D1 or D1 plus, or sometimes maybe extended gastrectomies, especially when you have adjacent organ involvement. They're also called as with multivisceral resections. So these are some of the classical non-standard gastrectomies that we actually look at. You can have a local wedge, but the problem is it's not very much proven or validated to the standard of care as of today. Now, coming to some of the controversies, whether when it associated with a gastrectomy, whether omentectomy is needed or not. For T1, T2 tumors, the omentum is removed 3 centimeters beyond the gastroepiploic vessel. That should be sufficient. You don't need to do a complete omentectomy. The reason being, it makes job easier for the laparoscopic surgeons. So for an open surgery, it really doesn't make a difference because you got to enter into the lesser sac and then you're going to remove. So, but for T3 and above tumors, removal of the complete omentum makes a complete oncological clearance. bursectomy. Bursectomy is nothing but removing of the fourth layer, basically. We call it as a fourth layer of peritoneum. And but we have now a randomized control trial which says that bursectomy actually increases the incidence of pancreatic fistula rather than helping, and it does not prove any oncological outcome. So there's no survival benefit, and again this has made the job much easier for the laparoscopic surgeon, because the most difficult thing in laparoscopic surgery or robotic surgery is doing a bursectomy. Now, the controversy still continues, because if you actually go through all the trials of the extent of lymphadenectomy, most of the trials says D1 is adequate, D1 plus is adequate, and if you see the outcome difference or the overall survival difference is very minimal. So I'll take you all through the evidence, but before we understand, there have been some changes to note in proximal, in total as well as distal gastrectomy, the extent. So what do you call as a D1, D2, D2 plus or D1 plus? So the standard is 1 to 7 is D1, D1 plus is you add on 8, 9 and 11P. And a standard D2 which is mandatory, along with D1 plus you also add 9, 11P, 11D as well as 12A. So you don't have to remove the 10 station 10 nodes, and if you have tumors involving the lower end of esophagus, 19, 20 and 110 also should be, stations 110 also should be added to D2. So similarly for distal gastrectomy, there's no need to remove the lymph nodes. It remains the same, but there's no need to remove lymph nodes at the hilum, or the splenic hilum, which has been excluded in the new guidelines. Now coming to evidence. So there are lots of trials which have actually gone through looking at D1 and D2. So if you concentrate at the lowermost portion, the highlighted portion, so definitely D2 has better outcomes when compared to D1 resection, but the Boenkamp study, actually in the overall group it did not show, but in those patients whom splenectomy was not performed, so these patients actually did better, and so the survival outcomes were better. Whereas the other trial which looked at T2 to T4 or N plus, in T1 probably really may not make a difference whether you do a D1 plus or a D2, but in T2 to T4 tumors and node positive, the survival advantage is huge. So D2 gastrectomy as of today remains the standard of care. So will doing more than D2 really help? There is strong evidence to show that there is not much of evidence beyond D2. But there is no actual trial comparing D2 versus D3. There is one ongoing trial at TMH, I think, which is nearing completion. The D2 versus D3 at the Tata Memorial Hospital should give us answers. So people have compared D1 versus D3 or D2 versus D4. But for certain tumors, those are involving the mesocolon or maybe an extended resection, something like a D3 lymphadenectomy, will it help? I think probably in a couple of years we would get data from the Tata Memorial Hospital, and it would help us answer these questions. So, but otherwise anything beyond D2 does not add any survival benefit. Now, so what is the consensus across the globe? So the consensus is standard, D2 gastrectomy is important. So if you see the Japanese guidelines, D1 can be done only in T1A tumors or T1B tumors, D1 plus T10, but it's not clearly mentioned. But all other tumors, whether you have a node positive or a T2 to T4, D2 is the standard, which is also in line with ESMO as well as NCCN. But NCCN also recommends for even for 1B tumors also to go ahead with the standard D2 lymphadenectomy. So splenectomy is not required routinely for unless and until there is a direct infiltration by the tumor. Now, so this is surgical part. Surgery remains the same, D2 gastrectomy, quite simple. But now the whole controversy remains between whether neoadjuvant versus adjuvant. So the problem of neoadjuvant versus adjuvant, the consensus, we do not have a consensus. And most of the Asian countries, that's the East, follows adjuvant treatment, whereas the West follows the adjuvant chemoradiotherapy or the radiation. So in Europe, it is predominantly perioperative. So main reason for this is the difference of the entire presentation of gastric cancer between the East and the West. So where do we fit in? So we actually see both worlds, and the problem with us is predominantly we see a lot of locally advanced gastric cancers, and we, unlike the Asian countries, we actually do not have early gastric cancers, and screening programs are not very robust. So we have to tailor our treatment accordingly, and we should be able to, that's why most of our centers use both forms of treatment, either neoadjuvant or adjuvant. And we also have problems with waiting time, so we may end up giving chemotherapy for those patients who may not need, and this is how it goes. So these are some of the evidence or trials that we have for adjuvant. You have for adjuvant chemotherapy, and then you have the perioperative chemotherapy in a nutshell. So what we know so far from the adjuvant and the neoadjuvant trials, MAGIC perioperative ECF is better than nothing. Classic adjuvant CAPOX is better than nothing. The ACTS GC trial adjuvant S1 is better than nothing. The SOX is better than S1, or perioperative FLOT is better than perioperative ECF. So we have not compared the sequencing of therapy in the right way that we are supposed to do. So these are the other trials which have also shown, some have shown benefit of neoadjuvant, some have shown the benefit of adjuvant chemotherapy. So this is the recommendation from the different associations, the Korean, Japanese, the NCCN, as well as the ESMO. So if you're going for neoadjuvant, the drug regimens have been recommended. You want to go for a SOX or not, there's some of them, but the NCCN strongly recommends FLOT. So adjuvant versus neoadjuvant, the debate continues. So at JIPMER, we did a propensity matched analysis for over about 200 patients, wherein we looked at the perioperative cohort as well as the adjuvant cohort. Some patients underwent upfront surgery at the physician's discretion after an MDT, and some patients underwent perioperative. But the disadvantage here is the patients, there was no uniform chemotherapy that was used. So we found that both either neoadjuvant or adjuvant, there's an equipoise. So we still do not have the answer. So actually keeping this in mind, in 2021 at JIPMER, we started the phase 3 randomized control trial, probably which would give us answers in about 6 years. So plan to randomize about 840 patients from 27 centers across the country, and we have close to 420 patients randomized so far. So probably another 2 years we should be able to complete the study, another 3 years from then we should be able to give the results. Now, touching upon chemoimmunotherapy, we have discussed today morning. Durvalumab, I think in today's era, if you do not talk about immunotherapy in any of the talks in gastric cancer, probably, and in MMR deficient today morning, we've seen that you can even completely avoid surgery in these group of patients. And definitely, FLOT with Durvalumab has the recurrence-free survival is better, especially in those patients PD-L1 more than or equal to 1%. Now, coming to some special situations. So the moment you actually see patients with gastric cancers invading local, should we go ahead or not is the answer. So what you see on the scan may actually not be P4B. So clinically T4B lesions need not always translate to PT4. And so this could just be a desmoplastic reaction and you may end up. But definitely systemic therapy is the goal. And the most commonly organs that are actually involved are the colon, spleen, pancreas, and the other small bowel, sometimes gallbladder, part of the liver, adrenal or ovaries. These are multivisceral resections. And we know that the outcomes are best when you have a spleen resected along when you have a direct infiltration, and Whipple's considered the most worst outcomes with multivisceral resections. R0 resection is something which is the key, and if you're able to achieve an R0 resection, the outcomes are definitely better with multivisceral resections when compared to R+. If you're going to have an R+ resection, might not really benefit. Do multivisceral resections actually improve survival? Yes, they do improve survival. It is better than palliative chemotherapy alone. So these are some of the factors that actually predict poor outcome. If you have a gross nodal burden disease and margin positive, or you have the Borman type 4 with lymphovascular invasion and pancreatic invasion, then these patients do bad irrespective of your multivisceral resections. So this curve explains everything, that multivisceral resections are better than palliative procedures or chemotherapy alone. So if you have an R0 resection possible and patient has good performance status, then I think you should go ahead with multivisceral resections, but after neoadjuvant chemotherapy. The next interesting situation is the para-aortic lymph nodes, because these are generally considered as M1. So when you look at the data, there is no randomized control trial to show whether you should be treating these patients with radical intent or not. But certain group of patients who have basically the 16A2 or the B1 group of lymph nodes actually do well if they have not progressed on neoadjuvant chemotherapy. So is there a role for prophylactic? There's no role for prophylactic lymph node dissection, but there is a role for surgery in these group of patients if they have not progressed, and their survival outcomes are better with para-aortic lymph node dissection. And there are no randomized control trials. Most of these are observational studies. And so these patients who are young, fit, good performance status, they should be given a choice after neoadjuvant chemotherapy, and if they do not progress. So these are these are some of the things which actually favors the para-aortic. So to conclude, prognosis is poor with para-aortic, but limited disease can be treated. The extent remains controversial whether you got to do routinely, and larger prospective trials are needed for the hour. Now you have peritoneal disease, which is an upcoming, which has always been graded as metastatic and worse outcomes. Actually, these patients do better than the oligometastatic liver disease. And the outcomes are poor, irrespective of whatever you do. But there are a lot of innovative, if you see the maximum outcomes is about 5 to 7 months. And for those patients who have microscopic peritoneal disease positive, that is only cytology positive, without macroscopic disease is considered to be stage 4, and we know, but their similar prognosis is similar to that of with visible peritoneal disease. So that is why there is a very important role of cytology in all gastric cancer patients. So we have started doing routine cytology in all these patients when we do a staging laparoscopy, especially in T3, T4 or node positive. And we have seen that 25 to 30% of them can come cytology positive, and the outcomes are worse. So now coming to the cutoff of PCI, Glehen et al. PCI cutoff of 12 is something that you can offer these patients some form of a curative intent, but more than 12, no patient survive more than a year, and so it may not be really worth. So CRS with HIPEC for select patients may be the treatment with a curative intent. But a group from Japan, the Yonimura et al., neoadjuvant peritoneal as well as systemic therapy has shown definitely promising, and this is how I would look at treating a gastric cancer patient with peritoneal disease. 0 to 6 systemic therapy followed by cytoreductive surgery plus HIPEC. 7 to 12, I would actually add on a little bit of intraperitoneal chemotherapy, NIPS, and then go ahead and do CRS with HIPEC. More than 12 goes for systemic therapy. And the last slide, please. And this is how, in a nutshell, we could actually treat patients, the optimal management. This is taken from the recent Japanese guidelines. And so what we have discussed. Thank you, and I'll be happy to take questions. And I kindly invite you all for the forthcoming NALCON at Tirupati on November 15th and 16th. Thank you.
Any questions from the audience?
What drug would you choose for HIPEC in gastric cancer, sir?
Yeah, so it's a controversial area. So there is no, so the mitomycin is something that which you can use, or you can use a doublet or even cisplatin alone. So the dose varies. The most common preferred drug is mitomycin along with adriamycin at 15 milligram per meter square, and it's 90 minutes duration at 42.5 degrees.
And how do you do these neoadjuvant intraperitoneal therapies? Like, do you just put in the catheters, or?
Yeah, you have an intra-abdominal port that comes actually. So actually in ovarian cancer, there is a lot of evidence for intraperitoneal chemotherapy. So we place in an implantable port, and you can give these patients but it is systemic as well as intraperitoneal. So IP as well as intraperitoneal. There are even ongoing studies on neoadjuvant PIPAC, that is pressurized intraperitoneal chemotherapy with systemic chemotherapy, but they're all in phase 2 single-arm studies looking at the toxicity profile. So I don't think those can be considered as a standard of care. Anything intraperitoneal with systemic should be done as a part of a research rather than doing it as a standard line of treatment.
Last question, like these gastric cancer patients, they have poor nutrition. And despite all the efforts, if their nutrition doesn't improve and the patient still has low albumin and persistent pedal edema, performance status is like in moderate PS2 kind of thing. Do you think surgery is an option, or should we defer surgery in such patients? Because we do come across such situations where not all patients become a good surgical candidate. So in those cases where it is still not non-metastatic, but the performance status is actually equivocal.
So that's about 8 to 10%. It is not a small number. So we've actually brought in a very valid point. Irrespective of your feeding jejunostomy And even though you do a gastrojejunostomy, you might have an obstruction. In spite of a GJ or a feeding jejunostomy, these patients don't improve. So I don't think we should, they are not a good candidates for surgery, and I wouldn't offer if they're not improving in spite of a good feeding procedure and your nutritional rehab. If these patients don't do well, I wouldn't consider surgery, because it would definitely increase morbidity and mortality without any benefit.
So the problem lies because now they are not really very great candidates for like just a systemic therapy also. So you are left in middle with doing nothing for a localized or a locally advanced disease particularly.
Biology is the king and we have to respect it. So I don't think we can win over everything, and so we have to respect the disease.
Thank you so much, sir.
Thank you.
Sir, for simplifying the complexities of gastric cancer treatment and making it so clear for us. So our next session is on targeted triumphs, PRRT, and other radiotheranostics as the new frontier in GI-GU cancer therapy. I invite Dr. Jairai sir, Consultant Nuclear Medicine Physician, Balco Medical Center, to deliver this exciting talk.
Good evening, everyone. So, I am going to talk about the radiotheranostics available in the GI-GU segment, and theranostic term has been coined in long back, and we celebrate it on 31st March. And at our center we have started it in 2018, and since then we are doing lot of cases: iodine, lutetium, PSMA and lutetium total. So neuroendocrine tumor will be the one of them. And about the epidemiology and incidence, it is rare but rising in the incidence, around 6.98 per lakh per year. Prevalence is more than 1.7 lakhs. Common sites are gastrointestinal tract, pancreas and lung, but in India, South Indian population, they have shown in their cancer registry that pancreas is number 1 in the India. And it is often indolent. Tumor is usually heterogeneous, functional, and it is found like the functional and non-functional variant. And frequently it is diagnosed late due to the non-specific symptoms. And there are multiple options for their therapy: surgery, somatostatin analog, targeted therapy, chemotherapy, and peptide receptor radionuclide therapy. So I will be talking about the last option which is available. So what is the basis of lutetium-177 PSMA therapy? Basically, neuroendocrine tumor which express somatostatin receptor overexpress it, we give them lutetium DOTA, and it get attached to those receptors and it get internalized, and then it damage the DNA by the beta radiation. So there are two trials, specific trials I would like to elaborate. First one is the NETTER-1 trial, and it was used for the midgut neuroendocrine tumor, and it was used for the patient with the progressive, well-differentiated somatostatin receptor positive midgut neuroendocrine tumor which has limited treatment options. And there were two arms were there. One was the PRRT arm and other one was high dose octreotide arm, long-acting. And endpoint was progression-free survival, and secondary endpoints were overall survival and objective response rate, quality of life and safety. So key results were there. Median progression-free survival was 28.4 months versus 8.5 months. Median overall survival was 48 months versus 36 months. Objective response rate was 18% versus 3%. Quality of life was also improved with the lutetium arm. And safety, few grades more than 3% event were noted in the, and 2% risk for the myelodysplastic syndrome were seen. So these are the progression-free survival and curve. You can see that there is significant difference. And after that came the Netter-2 trial, and it was planned as a first line therapy versus high dose octreotide. So it was used for the newly diagnosed advanced grade 2 and grade 3 GEP NET, and which have limited first line treatment, and it evaluated the upfront PRRT plus octreotide versus the high dose octreotide, and the treatment arm was research arm was the lutetium DOTA was given every 8 weekly for 4 cycles with octreotide 30 milligram, and control arm was the octreotide 60 milligram until the disease progressed. And primary endpoint was progression-free survival, and secondary was ORR, safety, and OS. So here also we have seen that progression-free survival was 22.8 months versus 8.5 months, and ORR was 43 versus 9, and disease control was more than 80%. And safety measures were comparable. And the other ESMO guidelines recently in 2024, they have done a subgroup analysis in which they have seen that the NET with the grade 2 has the better progression-free survival than the grade 3. So now I would like to take you for the prostate cancer, and I would like to tell about the 2 trials. One is the therapy trial, in which they have taken 2 arms, the lutetium PSMA arm versus other one was the cabazitaxel arm, and those patients with the metastatic castration-resistant prostate cancer who has been already treated with the docetaxel and suitable for the cabazitaxel were taken for that. 1:1 randomization was there, and endpoints were the PSA response, overall survival, and the public data shows that there was PSA response rate was more frequent among the lutetium PSMA arm. It was 66% versus 37% from the baseline, and adverse events were also less with this arm. And other trial was the Vision trial, in which they have taken the progressive metastatic castration-resistant patient and who has been already previously treated with the taxane and the novel androgen therapy, and 2 arms were there, lutetium PSMA arm versus the best supportive care arm, and randomization was done 2:1, and primary endpoint was the overall survival, and secondary were the radiological progression-free survival response criteria. And it was multi-country study, and more than 750 patients were recruited, and follow-up was more than 15 months. And in these patients also, median follow-up was done for the 20 months, and lutetium PSMA plus the standard of care arm has shown significant radiological progression-free survival. It was 60% greater than the standard care arm, and median radiographic progression-free survival was 8.7 months versus 3.4 months. Overall survival was also significantly improved by the 38% with this arm. And all key secondary endpoints were also statistically improved for the experimental arm. So there were dramatic difference were observed between the treatment arm, favoring the lutetium PSMA prostate specific antigen reduction of 50% and 80%, both they have taken from the baseline. And for the 50%, it was observed that 46% of the experimental arm have shown the result versus 7.1% on the standard of care. And for the 80% reduction, they were 33% versus 2% respectively. And side effects also were comparable. And after that, medicine was under the Novartis pharmaceutical company, and after that it has become available as a lutetium therapy. So there are many other trials have come after these 2 trials for the PSMA. So I will just skip those trials. So after these 2 trials, actually there is flood of trials using the multiple radiopharmaceuticals and multiple target places, as well as with the multiple endpoints, different. So many have not been completed and still going on. So what we are doing here at our center, I would like to show you a few cases. So we prepare the patient where blood counts are normal, means marrow reserve is good, creatinine level is normal, hemoglobin also is normal, and ECOG 2 or better we are taking for those patients, and myelosuppression should not be there, we just take care of that. We do the gallium PSMA scan, renal function scan, and after that we admit the patient and we give the lutetium PSMA with IV route with the proper hydration. We do the SPECT-CT on the second day. We can send the patient same day also, but most of the time we do it on second day. And then we discharge the patient and we follow up the patient every 15 days. So this is the first patient which I am showing. This was our first patient having extensive metastasis, and we have done 2 cycles of the therapy, and after that patient has improved significantly. Initially when patient came, he was not able to talk, but after that he was able to talk, but survival was not much. After the second cycle of the therapy, patient succumbed. This second patient, it is also showing significant improvement. Third patient also the same. You can see the PSA level, significant decrease in the PSA level. This is one patient which has not responded to the therapy and has progressed with the lutetium PSMA, and other one has, after 4 cycles, significant response was seen. So for DOTA therapy also we are doing the therapy. It was the ileal NET with the liver mets, and you can see the after 4 cycles there was significant response with the DOTA therapy. We are doing the lutetium EDTMP and samarium 153 therapy also for the bone pain palliation regularly at our center. So concerns are availability of the radiopharmaceutical and cost. Initial costs are more, trained staff, penetration into the remote areas are concerned. With few favorable points like groundwork related to management of the toxicity is already in place with the oncological center and other supportive staff. Future ahead is the actinium-225. This is our team. With them we are able to do the work and justify the patient treatment. Thank you so much.
Thank you so much, sir. Any questions from the audience?
Thank you so much.
Thank you, sir, for this comprehensive and knowledgeable lecture. So now coming to our last panel discussion, which focuses on the common sense oncology in GI cancers, moderated by Dr. Amol Akhade sir, who is the medical and hemato-oncologist, Fortis Hospital, Mumbai, and founder of Suyogi Clinic, Cancer Clinic. So this session brings us with the distinguished panelists, Dr. Sujay Hegde, Senior Surgical Oncologist, Kamal Nayan Bajaj Cancer Center, Ruby Hall Clinic, Pune. Dr. Arpan Chaturmota sir, Surgical Oncologist, Sanjeevani Cancer Care Hospital, Raipur. Dr. Sneha Botra Jain ma'am, Consultant Medical Oncologist and Hemato-Oncologist, Mittal Hospital, Bhilai. Dr. Kashi Sarkar sir, Radiologist, Balco Medical Center, Raipur. Dr. Vikram Chaudhary sir, Professor GI and HPV Surgical Oncology, Tata Memorial Center, Mumbai. Dr. Avinash Tiwari sir, Consultant Palliative Medicine, AIMS, Raipur. Dr. Devrat Hishikar, Consultant Medical Oncologist, MMI Narayana Multi-Speciality Hospital, Raipur. And Dr. Prashant Pote sir, Consultant Vascular and Neuro Interventions, NHMMI, Raipur.
So I think we are the last panel discussion of the day, and so basically we are showstoppers. If you have seen the fashion show, the best thing is kept at the end. So let us proceed, and we will be talking about common sense oncology in GI cancer, and we have been given 30 minutes, and it's a vast topic. So let us try to give as much justice to this as possible, and I thank my esteemed panelists for waiting patiently for this. I have no conflict of interest to declare with respect to this discussion, and aim of this panel discussion is to generate discussion because we are talking about common sense. So commonly we'll try to make some sense of what is happening in GI oncology. So let us start. Now the first question, ctDNA in GI cancer, and I will like Dr. Sneha to take it.
Sorry to interrupt, Amol sir.
Dr. Chandan Bajaj, sir is a I also want to invite as panelist.
Yeah,
sir
please.
is pathologist from Caring Arms.
Yeah, please.
Thank you, sir.
Dr. Chandan. Yeah. So we'll start with Dr. Sneha, ctDNA in GI cancer. ctDNA is the current buzzword. So the question to you is it prognostic? Is it predictive? Is it both? Do you do it for all GI cancers? So Dr. Sneha, your thoughts on this?
So it is still prognostic, and for all GI cancers, no.
So is it predictive or not as of now?
No, sir, not yet.
So it's not predictive,
No.
it's only prognostic, and still you do it.
Very rarely.
You do it very rarely.
Yes, sir.
And what is the rare occasion that on which we like to do it?
Sir, so in cases who are like not willing for chemotherapy, high risk colon cancers, not willing or can decide yes
So
or
the
no.
clinically high risk,
Clinically high risk, not willing. So at least give them some reason, some more reason that you
okay,
need to
so
go ahead.
those patients to whom you cannot convince for chemo, you want ctDNA to convince.
Yes, sir.
Okay. Dr. Ajit Mishra, is he there?
Dr. Arpan.
Yeah.
Yeah. No, we don't do ctDNA at present.
Okay. Dr. Chandan, since you are the pathologist, please. So what is your take on the ctDNA as of today for GI cancers?
Sir, I feel at present it is basically under research. Practical application, I don't feel at present it is much.
Okay. So basically, everybody agrees that as of today it is only prognostic, it is not predictive. But the next question comes from India point of view. If you want to ask in certain rare situations, which lab? So Dr. Sneha, you do it rarely. So which lab? And which lab do you think is good enough according to you? You need not take names, but are you satisfied with the reporting?
Fairly yes, because options are very limited. So whatever they can
Okay.
give us.
Anybody else in the panel wants to share that? Are they happy with the ctDNA reporting? Is there a standardization of the reporting? Are they okay with the quality control?
It is mainly for prognostic one. And
Yeah, it is mainly for
sometimes-
prognostic one.
Yeah.
If you decide to send it for prognostic purpose,
Yeah.
are you happy with the results of the labs?
Sometimes, you know, it's sometimes some labs says that they are not doing fine, but sometimes it's good with the med genome. People are saying that it's good
Okay.
with the med genome.
So, of course, on this forum we will not take names, but more or less, the standardization is an issue. So, to summarize, ctDNA is currently only prognostic, not predictive. Use it wisely, and when you say wisely, mostly occasionally. Choice of lab and quality of reports is an issue in India, and I use it only when decision to give or not to give chemo is in gray zone to get additional information, as Dr. Sneha has said. So, this is about ctDNA. Moving on, this is a new drug. Dr. Sujay, have you heard about this drug? Exorcizumab.
So
I'm sorry asking, you are a surgeon, I know that, but I wanted to ask you, this is the latest drug. Have you heard about this?
So we have been using this since a long time. So
Oh, fantastic, fantastic. I really appreciate that you're using this for a long time.
So, I mean, as part of ERAS, I mean, prehabilitation has been a part of ERAS since a very long time. So it's always been a focus on trying to get evidence, for exercise, which, it's almost impossible to get evidence, but we still have meta-analysis. We have a meta-analysis recently which said that, and there have been multiple guidelines which have said that exercise has helped in outcomes, including in colorectal. There's some study which
So
says
now we have a phase 3 trial which was presented in this ASCO challenge trial published in NEGM, and these are the curves from there.
Yes.
And as you said, if it would have been for any particular newer IO drug or ADC, there would have been a lot of news coverage or media coverage for this. So my question to you, Dr. Sujay, as per the protocol, there is a structured exercise program.
Yes.
That means you are telling them what exercise to do, there is a trainer involved. Do you think this is practically feasible in our country?
It's quite practical, because if you look at it from an institutional point of view, probably not so easy, but in a private setup like ours, most of us do give these guidelines to a patient on a one-on-one basis. It's not a very difficult guideline, some very simple points, 150 minutes in a week, 3 times in a week aerobic exercise, 2 times in a week muscle training, nothing very difficult. It hardly takes 5 to 10 minutes. The problem lies in individualizing as per cancer. So if you look in terms of general guidelines, you can give them very easily, but if you look in terms of individual cancers, obviously head and neck guideline is going to be different from a breast guideline, and that will be different from a prostate guideline. But there's another important thing in this whole problem. is that in our country, majority of the problems are environmental, implying most of them are tobacco related. So there's an automatic benefit for a general guideline irrespective of the cancer. So for me, it doesn't matter what cancer it is, because many of them are obesity and tobacco related cancers, and so kind of a general guideline will help.
So to summarize, of course, we all suggest our patients to have physical activity, more the activity better. This trial has shown that if you give them a structured program, it has definitely over a period in a prospective randomized trial shown benefit in DFS and OS both. So on the Monday morning, if our patient, if you think that particular patient is is inclined towards this kind of a structured program, we will offer them. So that is, you want to add some point?
Just a small point, like the other arm was health education. So actually all patients were given the education, they knew what are the best practices, but unless you do active exercise, it doesn't help. So just knowing things is not important. Probably.
Correct.
So that's probably
So that is an important thing that you just have to, of course, health education is important. Along with that, a structured exercise activity. So this is something which is exciting, which has come up this ASCO. Moving on, Dr. Vikram, low dose aspirin for colon cancer. This is another thing which is buzzing. And if you see, I have analyzed this data, that 160 milligram of aspirin is given to pick 3 altered stage 1 to 3 colorectal cancers. It has reduced the 3-year recurrence, almost hazard ratio of 0.49. They have taken more than 6,000 patients, and they found that 37% have PIK3 mutations, and those with hotspot mutations, they have 17%. Probably there was a lot of significant benefit in those with hotspot mutations. There is no OS yet. So are you impressed by the data? Dr. Vikram?
Yes, so I actually looked at the trial just because you asked me to, and then I found out that nearly more than one third of patients had that mutation. So doing that test for every patient probably may not be a good idea. Again, another.
So the difference is that 37% have some mutation, but the hotspot mutation or the main mutation was seen only in 17%.
17, yes.
So technically, the subgroup in which the benefit is shown is 17%. That means technically 1 out of 6 will have.
But the actual benefit was seen in both A and B and both groups.
But the benefit was more in the group A.
Yes, I agree. So there is a benefit, but there was a significant SAE rate in the benefit group also, and that difference was also significant. I think you will show that. And now 150 milligram aspirin has been taken away as a recommendation even for prevention.
But will you stick with 150 mg, or you feel that 81 mg is good enough?
So the recommendation.
Because what is the risk of suppose the patient ends up having subdural hematoma or some other problem with aspirin?
So there
then
the
what?
safe dose has been around 75 to 80. 81 is the mentioned dose. So somewhere around 75 to 100 is the dose, which probably should give a practical benefit of both primary prophylaxis against coronary like cardiac event or a prevention of malignancy. That's the practical approach which can be used in most patients if they don't have a contraindication to use.
But will you then test your patients for this particular mutation, or you will give it to everybody?
I don't think we are doing that regularly.
Do you think it is feasible to test? Because again, the cost factor of the testing is there.
A large proportion of patients do get these evaluations done, and if you know about it, then probably there is no harm in using it, is what I mean.
So, to understand that, of course, this is another slide from the same study, and they are given the numbers needed to treat. And if you see it carefully, the maximum benefit is for the stage 3 rectum and stage 3 colon. The benefit is less for earlier stages, and that is an important point. So, my thoughts on this is that, yes, it is difficult to implement in India, because to test everybody becomes difficult, especially the patients having middle socioeconomic classes. So, toxicity is also an issue.
And if you deep dive into the paper, you can see that the side effect profile is really significant. The adverse effects were unacceptable. And only this mutation, the patients with this mutation or a related mutation were given aspirin. The rest of the group was not given the aspirin. So whether this mutation itself is prognostically better or whether addition of aspirin was beneficial, I don't think this trial answers that.
Correct. That is again another thing that we don't know.
Again, it has exon 20 and exon 9 mutation. Exon 9 responds better to your routine treatment, 20 doesn't. So there are a lot of factors which are interfering with the results, though it is very clear that the DFS at 3 years in the mutation was with aspirin.
So basically, I'm not so sure whether it is practice changing as of today, but a lot of people are implementing it. Especially in the Western countries, they have started implementing it. But in India, probably it is slightly tricky. If the patient is inclined towards this, we can share the data, get the testing done, and if the mutation comes positive, he is ready to take it for 3 years, we can offer it. Now moving on, see, NGS is not a magic wand, don't break it. So Dr. Devrath, yeah. So what are the cases in which you ask for NGS in GI cancer? Upfront, metastatic, or both, or none?
In initial stages, I won't go.
Can you come to the mic?
In initial stages, like stage 1 and 2, I won't go for NGS. In advanced metastatic.
So in initial stage, you don't ask for NGS at all? The one cell people are standing outside, they will be unhappy.
Okay, I will go for that. But in initial stages, I will go for only MSI. And for advanced stages,
So in early stage, you will not ask for NGS. Anybody in the panel wants to ask for NGS in early stage of any GI cancer, from esophagus to the anal canal? For early stage NGS? Nobody? Good. So I'm happy that nobody is asking for it. Advanced stage, yes, biliary tract, it is recommended. MSI, now this is another question. Will you ask for specific MSI at least by IHC for all GI cancers, Dr. Sunny? Is he there? He is not there. So Dr. Devrath. For all GI cancers, technically speaking, at least MSI should be asked because there has a clinical implications of that. Those who are MSI high will respond very well to immunotherapy. What about PD-L1? Dr. Sneha, do you ask for PD-L1 in colon cancers?
No, sir.
No, why?
Sir,
you don't
no.
want to give immunotherapy to colon cancer patients?
So immunotherapy with MSI, not with PD-L1 positive.
Okay. So that is another thing, that the patient is MMR proficient, there is no point in asking for an PD-L1 in colorectal cancers because whatever be the value, the IO is not going to work much if the patient is MMR proficient. So that is a trap. What about HER2?
Stomach.
HER2, yes.
Okay, so most of the time we have a reasonably good data in stomach, colon, especially if the HER2 is 3+. So that is about the genetical testing to be done in GI cancers. Moving on, Dr. Sneha, back to you because you are the medical oncologist, and Dr. Devrath. Where can we avoid chemo? We will come to where can we avoid surgery, but before that, let us avoid chemo.
So in which setting?
Which setting in GI cancers will you avoid chemo? Early stage colon?
Early stage colons are stage 2, MSI deficient, definitely no chemotherapy. And otherwise also stage 2, older patients, no chemotherapy.
What is your definition of old?
70.
70? Dr. Vanita is there in the audience. Geriatric definition in India is above 60.
60.
So what about above 60?
60 to 70 gray zone.
So again you are 60 to 70. Okay.
PS matters.
Okay, so basically there is a lot of scope for de-escalation of chemo, and especially in early stage cases, need not give oxaliplatin. We have beautiful data about single agent capecitabine. Now what about Dr. Devrath? Maintenance PARP inhibitors for pancreatic cancer. Are you impressed by PARP inhibitors? Polo trial.
yeah, it has shown benefits, but I still use the conventional chemotherapy.
So even if it has shown benefit, you don't give it, and the meeting is getting recorded.
I'm not using it.
You are not using it. Anybody else in the panel like to comment about the maintenance PARP inhibitors of pancreatic cancer? Is it a high yield output, or do you think it's
Do we require
the
BRCA
trial
testing?
results are not that great, and maybe you will offer only in certain situations, those with BRCA and BRCA mutated?
BRCA
Yes?
testing or something? BRCA testing, then if it is positive, we can try for
So
that.
of course the trial was for BRCA and BRCA mutated patients only. The trial a lot of issues, but because it is there published and it is there in the guidelines, we can discuss. But the data is not that great. What about Dr. Sneha? Two drugs versus 3 drugs for colorectal cancer. Are you FOLFIRINOX for metastatic CRC, or you are for FOLFOX FOLFIRI?
FOLFOX, FOLFIRI.
So you don't like prodigy trials?
Sir, FOLFIRINOX in metastatic setting, no.
No? So which are the setting in which you use FOLFIRINOX in CRC?
In neoadjuvant setting in rectum, if at all, because it requires a very good PS, tolerability is a big issue. So we cannot complete the treatment. That is the major issue.
So when you use the original FOLFIRINOX or you modify it?
Modified, sir.
Modified. How much is the modification? 10%, 20%, or looking at the patient, whatever can the patient tolerate?
So at least 20%.
Yeah. So basic take-home message is that the 3 drug generally is not preferred unless in certain situations. Folfirinox is difficult to tolerate regimen, but there are almost 26 published modifications of Folfirinox. So whatever that is suitable to the patient can be tried, but generally 10 to 20% dose reduction is tried. Now the last question, Dr. Devrath, liposomal irinotecan. Is it old wine in new bottle or old wine in old bottle, or forget about it, you don't take wine? Okay, so do you like it? Okay. So do you think it is justifiable, the cost that has been given to it?
In pancreatic cancer, yes.
Okay.
Metastatic pancreatic cancers.
And why is it that? Because it has shown better results?
Yes.
Or it has shown the exactly same results?
No.
And behind less toxicity?
It has better results.
Okay, Dr. Sneha or anybody else in the panel who uses liposomal irinotecan?
I don't use.
You don't use it only? Okay. Cost factor. So yes, liposomal irinotecan has some toxicity benefits, but the efficacy-wise, more or less same results were seen in the pancreatic cancer Napoli-2 and the NALIRIFOX trial also. So basically, yes, if the patient can afford, you can offer this, but generally we have to use a lot of common sense when you're using these drugs. Now let's come to the surgical part, organ preservation and rectum. More or less everybody agrees that if it is feasible, one can offer that. Dr. Bishwaranjan? Is he there in the panel? Any surgeon can take it?
Yeah, we have to preserve. If we can preserve, we have to preserve the sphincter.
Dr. Sujay?
Preservation.
I mean, I am not a big fan for all patients because you think in terms of the basic purpose of the treatment is to basically make sure that the patient is fine.
Yes.
So if I have, and your objection to surgery is that it's causing morbidity, has a poor quality of life. So I would reserve my wait and watch only for surgery which I potentially see as problems. So things like an APR or a coloanal, ISRS, elderly patient, but you have a standard AR. Why would I want to do a wait and watch in a patient who can be treated in one shot? So it should not be a, kind of a...
Dr. Vikram, your thoughts? Are you comfortable at your center offering wait and watch to eligible patients?
I think we have to differentiate between organ preservation and sphincter preservation. So if sphincter is at risk, this is still justifiable. If it's just an AR or LAR, of course, as a surgeon, but there is evidence which is evolving, and we have some patients with mid and even upper rectum who are on wait and watch policy. So it's a feasible thing to do. If the patient is willing for surveillance and if there is a response, it's a feasible thing to do.
Now, what about esophagus? Now, because you have agreed for rectum, now people are saying that don't do esophageal surgery also. They are trying to get you out of the job.
I think, see, the problem is it takes away the chance of curative intent surgery in a lot of patients. You will always be able to prove the 3-year and 5-year survival, and then the survivals will be similar, the disease-free survival will be similar, but the long-term curative survivals, which we can get with surgery, which extends in colon like 15, 20, 25 years, whether that will happen with these agents, we have to think about.
So you are not convinced yet with the Sano trial. After the trial has an issue, non-inferiority margin was close to 15%, inferior results were accepted. So for esophagus, probably you require more data. What about colon? MSI high, you give neoadjuvant IO, the tumor melts, and there is nothing there. We'll like to preserve the colon.
See, you have a patient population in MSI high who probably in the younger age group. So we talk in terms of follow-up not less than 20 years, 25 years. Do we have data for that? We don't.
So as of now, no, but maybe if you get a mature data, you may incline. So maybe choosing wisely after 4 years, you will probably, in 2028, you will agree? That's what you're saying?
Yeah, it's too early to say that. And of course, I told you, the surgery has to be morbid. You have a morbid surgery, there's a logic behind organ preservation. You have a right hemicolectomy in a 25-year-old with a complete response post-IO. I wouldn't wait and watch.
So you're of that opinion that the best drug to get a complete pathological response is surgery?
Yes.
Okay. So, as far, okay, you want to add something?
Combination of surgery and chemo, immuno, whatever is feasible, where the organ is or the sphincter is not at risk, or organ preservation doesn't, like colonic preservation, I don't think it makes any sense.
Okay, so as of now, organ preservation is well established for rectum, esophagus, we need more data, and colon maybe for MSI high, for selected patients, we don't know. So we require more data on that. Moving on. I think the slides are stuck. So this is what happens when you stop surgeons doing surgery. The slides get stuck. So, okay, so moving on, after the next slide is about HIPIC, and that is everybody's favorite topic. So Dr. Vikram, Dr. Sujay, I want you to tell the audience, what is the current exact indication for which in GI cancer, that is stomach and colon, you will like to offer HIPEC? That is first question. And what are the centers in which it should be done, because it is a long learning curve?
I know. So I understand the concerns about, which are always centered around this procedure, because once people have that skills, they want to use it everywhere. So you need to choose patients well. I would take it for gastric cancer particularly, because that's my expertise, and I would expect Dr. Sujay to talk about colorectal. So in gastric cancer particularly, in cytology positive patients, it is the prognosis is similar to metastatic patients, and there it has been seen that it increases the DFS, and in some cases it can improve the PFS. But whether the benefit was given by a radical surgery or whether an addition of HIPEC helped, we don't know. But site reduction definitely, so radical surgery definitely helps. For low PCI patients in gastric cancer, we have randomized evidence also now.
What is the cutoff for low PCI?
Low PCI is 6, because the data was published that more than 12 PCI, there are really no long-term survivals with surgery. So that's a definite contraindication. But generally, in our experience, we have seen that if it is more than 6 also, the benefit is really not there. And whether it is a combination of surgery and systemic chemotherapy, or whether an addition of intraoperative chemotherapy helps, that answer we don't have. But a definite role for cytoreductive surgery in low PCI patient and combination with systemic chemotherapy.
Dr. Sujay, what about colorectal cancer? Which cases you will like to do HIPEC as a strongest recommendation?
Yeah, so I mean, if you talk in terms of technique, there are two parts to it. One is the cytoreduction. So if you look at it, it's just not possible to start off with a colorectal cytoreduction straight away. One of the easiest ways to start is to start off with ovary. For example, there's a strong indication to start off with ovary, and starting off with a total peritectomy there, because these are very responsive chemosensitive tumors, is easier. In colorectal, we started off long back. I have not had a great experience, honestly. Within 9 PCI, I think surgery is the main factor. I don't think HIPEC adds on too much, and I agree with the trials over there. Above 16 or above 20 is variable, but it really doesn't help any kind of surgery. And these are all heavily pre-treated patients. And between 9 and 16, probably I would use HIPEC. We stopped using it since the last 6 years.
So you have to be very selective for the cases.
So even burst appendix shows very good result. Only when there is one tumor of appendix burst out, then HIPEC shows a good result. Otherwise, till now, there are no great.
And the histology matters. You know, you can't do HIPEC for a signet and then say that it's going to work. You need a good histology, and you need a lot of other factors.
I would like to stress upon your last statement, which is very
So that's what I'm asking. Coming to the next question. Once you decide whom to do, the next question is where to do, because this is an extensive surgery, a lot of learning curve is involved. Not all centers have that training. So is there a way by which a patient can find out whether that particular center, there are enough expertise available who are trained to do this procedure? Because everything gets abused in our country. So the HIPEC is also getting abused. So a lot of people end up doing it in small nursing home setups.
It is mainly for CRS, because CRS can't be done in a nursing home. For good CRS, we require a big team, good OT, and good perioperative observation.
So Dr. Vikram, what is your take that what is this, how the patient should choose? How much learning curve is sufficient for patient to trust the surgeon on the team that they can do it a good job?
Unfortunately, they don't get to choose. Most of the times, if the surgeon is going to offer, they will choose that. But generally, surgeons should get themselves trained before offering this as their skill set. It should be, the learning curve should be over during training, and then only you should give it as a service. And particularly, not only the act of doing a CRS, also administration of chemotherapy intraoperatively, the changes, fluid shifts, the anesthesia risk, everything increases. The perioperative ICU stay, the morbidity associated with procedures. So these things will be managed better, obviously.
So the choice of the hospital, choice of the team, choice of the experience of the surgeon, all this matters for this to have a good outcome.
Play when for the patient to benefit in that advanced cancer. So everything has to be careful.
Yeah, thank you. So now let's come to if the surgical procedure is getting abused, then of course precision oncology is of course getting abused. So Dr. Sneha, have you heard about chemosensitivity test? It is being offered in GI cancer. Have you heard about that?
Yes, sir.
So do you recommend it, or do you follow it, or have you ever ordered it, or have you seen the report at least?
I've seen the report, never ordered. Not much of benefit of doing a chemosensitivity testing.
Okay, so let us understand chemosensitivity test is not like antibiotic sensitivity test, and there is not much data and probably should not be asked for. Now, Dr. Kashi,
yes.
I assume you are from the radio diagnosis, right? So I have kept this for you. FAPI scan. Can you tell us in which conditions you will give the maximum recommendation of doing a FAPI scan?
Yeah,
because
actually,
nowadays it is doing for everything.
Actually, FAPI scan are new imaging modalities. As the name suggests, fibroblast activation protein inhibition test. They are basically used for those cancers which are having higher expression for fibroblast or desmoplastic tissue like gastrointestinal cancers, colorectal cancer, pancreatic cancer, cholangiocarcinoma, hepatocellular carcinoma. It is also having advantages in detection of.
So basically, you have listed almost all GI cancers.
No,
what
not
I'm
all
asking
GI.
you is that which is the most indication that you will say yes. Which one?
Colorectal cancer.
Okay, but is there any data for that? Strong data for that?
Yeah, strong.
Because I tried to search what is the best possible indication of FAPI, and I was pretty confused. There is not much good data for anything.
No, we do not have any established data. We are using it in conjunction with old FDC.
So we are trying to generate the data. That's what you're saying.
No, we are not having any established data. It is still in experimental phase.
Okay, so still this experimental. Dr. Vikram?
Yes, so the two cancers which I treat, like gastric and pancreatic primarily, in that particularly the FDG fares very poorly, at least in gastric cancer, and their FAPI is really scoring over. We are experiencing it practically, and also we are doing a prospective study on that. So we have recruited quite a few patients in that. We see that the FAPI uptake in gastric cancer is better. It is detecting a lot of peritoneal disease which is not clear on the CT or FDG. And pancreatic cancer also a lot of recurrent situations. FAPI is scoring over FDG.
Especially in
so one has to be highly selective before going for the FAPI scan, rather than everybody is getting the FAPI
is
scan.
scoring better than FDG. Is what I would say.
Okay. Anybody in the audience wants to put some thoughts about FAPI scan?
Especially for mucinous carcinoma, no? Mucinous GI, FAPI is very helpful in that.
Okay. Is there any? What is the largest series that you know of for the mucinous? Because I could not. I did search a lot of things about FAPI, and that is why I put it here. I could not see anything much.
It will
okay. And of course, the CAR-T for GI cancers. My recommendation is not to do outside clinical trials. I hope all the panelists agree, or anybody wants to have different thoughts. So the abuse of the precision oncology should also be stopped. And now it comes to the last but important point, Dr. Avinash Tiwari, palliative care. Let me ask you, do we really care about it outside the conference hall?
Yes, we really do care. Now newer generation coming, they are trying to integrating us early in the course. As our panel discussion, choosing wisely, I will remember the 2019 Lancet publication by Dr. Pramesh et al. And it says patients with metastatic cancer, we should not delay reference to palliative care despite they are getting disease-directed treatment. It was the choosing wisely India, and then it was the first recommendation. With newer oncologists coming on, they are trying to integrate us early in the course, and exactly I will say it is more of association. If we have an embedded palliative care clinic, I will say specialist palliative care. I will not talk about generalist palliative care. If there is embedded specialist palliative care unit with ongoing oncological care, definitely there is difference.
So in your experience,
yes,
how many centers, say for example Chhattisgarh,
Yeah.
you are practicing here, right?
Yeah.
How many centers in this particular state have palliative care units, dedicated palliative care units?
So yeah, every dedicated oncologist center has
One,
palliative
two,
care unit. But
I'm
if
counting.
you talk about specialist palliative care, only one.
Only one.
Only one.
And all the audience, how many of your own centers have dedicated palliative care units? Of course, TMH, definitely. So what I'm trying to suggest is that, you want to add something, Ratisna?
I think, sir, every hospital, every institute, as we have medical, surgical and radiation oncology, palliative care should be a part of
Yes.
it, because it requires a lot of time, lot of dedication to counsel the patients regarding end-of-life care and a lot of other things, pain management, the feeding management, which requires a lot of time, which usually we don't have, and that can be taken care of, or which is left out.
Correct.
So that can be taken care of in the palliative care unit.
So
for
basically,
younger disease.
when you are thinking about common sense oncology, you have to make sure that the palliative care is integrated early into the care, and we need to have dedicated palliative care units as much as possible. So I think we have run out of time, And this is the last slide. What is common sense? Common sense is to distinguish between knowledge and wisdom. So what is knowledge? Knowledge is knowing that tomato is a fruit. Wisdom is not putting it in a fruit salad. And that is what is all about common sense in oncology. Thank you. So we have finished in time. Thank you. Any questions from the audience to the panelists? Okay. Thank you.
Sir,
yeah.
I have one question. Like for HIPEC, Vikram sir was saying the cutoff for PCI in gastric cancer. What do you say? PCI is many a time there is inter-observers. Sometimes with different surgeons there are some variation in PCI assessment also.
So Dr. Vikram, what's your take that PCI changes as per the surgeon?
No, we can't discuss that. Well, if the PCI,
is there a study to show that there is an inter-observer variation?
What he's trying to suggest is that sometimes people extend their indications. That's what probably he means. So we have also done that in some patients where probably the baseline PCI was 8 or 9 or 10 or 12, and then post chemo the patient has been doing exceptionally well for a year and a half. Then Anant or Vikas is standing back to me. Explore the possibility. I do a staging lab again, the disease is gone completely. Some of these patients exceptionally have received systemic surgery in our center, and they probably have done well. We don't know whether it was the same systemic therapy and act of doing a gastrectomy has helped, or whether a CRS hypertension. So you will never have those questions because you will never study them in randomized patients. Because
so Dr. Yashwant, he is trying to say is that PCI 6 or less than 6, he doing the HIPEC is similar to we giving IO for PDL1 2%, 1%, less than 1%, more or less similar analogy.
And sir, take on cytology positive versus if patient has peritoneal washing cytology positive.
So the moment you say, so again the cytology positive disease in gastric cancer behaves like a metastatic cancer. So Japanese classify it as metastatic disease, but the intent at most centers is curative because you can take out the disease morphologically completely. But again, because the disease is in the peritoneum, the act of giving chemotherapy is likely to help, and that's why the extension. So you consider it a low PCI or a zero PCI disease, and then you offer. My experience with 50 cases, 23 offered, 27 were not offered. It happened over a period of years, and there was slight DFS benefit, but not statistically significant. So again, whether only gastrectomy and systemic therapy helped or HIPEC helped, we don't know. But HIPEC definitely did not improve the overall survival.
Thank you, sir.
Dr. Vanita, I want to ask a question.
I wanted to ask about organ preservation and esophagus cancer. I think I know nothing about colon cancer, but Sano trial they reported the 2-year survival. Now esophagus, if it is going to relapse, it will relapse within the first 2 years. Usually, almost never we see relapses post 2 years. So why are we saying this is not the standard of care? I mean, if you can save esophagectomy for a patient, that's phenomenal, right? And if it's a non-inferior outcome at 2 years. So
the margin of non-inferiority that they chose was close to 15%. And to have in a deadly disease like esophagus, to accept that I am okay with 15% inferior results, I am personally not comfortable. Maybe the views may vary from person to person or oncologist to oncologist, but that is quite a large margin in a potentially deadly disease where there is a curative option upfront by doing a surgery. So that was my take on that. I'm not comfortable with that margin.
Global study that was approved globally across multiple ethics committees, multiple investigators who all thought that it was an appropriate margin.
So that is my personal take, and that is, I may leave it to the panelists and audience whether they are comfortable for 15% margin.
A few issues there. One is they clubbed both adeno and squamous. That's one. They allowed crossover, and you had almost a 40 to 45% recurrence rate in these patients. So you can always argue in multiple ways, but I think the data is still immature. So you can if you offer a patient a choice, you want an esophagectomy or not, and if he says surgery, it will be really weird. Most of them would. There was almost 50% of the patients who were, not 50, I think it's 25% of the patients who were offered surgery who opted for non-operative. So there's a lot of problem. You need a better trial. That's my point.
So how would you design that?
Locally advanced cancer which has a poor prognosis, you will always get the evidence on both sides with both the approaches, because the patients are not likely to do well either ways. That's why surgery fails, and that's why you can argue for that. That is why the trial. You can't argue in stage 1 cancer.
Maybe we can have a local Indian trial if it is possible, and maybe have a good data. Maybe in future. Thank you. Thanks.
Sir, sorry again. Sir, for low dose immunotherapy in GI
Yashwan
cancer.
is host, so you can ask as many questions.
Yes. Low dose immunotherapy in GI cancers. So, what does choosing wisely say?
Choosing wisely says if the IO drug is going to work, it will work at low dose, at standard dose, any dose. So, doesn't make much of a difference if the IO is going to work. That means if the patient is MSI high and you are giving IO, the low will also work. And I hope Dr. Vanita will agree. Her paper is going to get published soon in this year about the daily trial. Oh, that is the secret. Sorry. Thank you.
Thank you.
So it's time for a group photograph.
Thank you, sir. I request all the panelists, moderators and chairpersons to accompany on the stage for the photograph. I request everyone for a group photograph.
We are going to have a quiz session. So before that, I think quiz master is 15 minutes late. So please come for group photo. Everyone, please come for group photo. And we have gala dinner after 8 p.m. onwards. And before that, there will be a quiz competition for PGs and all. Okay. Please come for a quiz group photos.
Hello. Everybody's mementos are in their bags, so please receive it from the registration counter. And So, I, Dr. Palak Agrawal, on behalf of Balco Medical Center, thank all the esteemed chairpersons and panelists for joining us and making it a great success. And I request everyone to join us tomorrow for another one-day academic extravaganza. Our gala dinner will start from 7:30 onwards. So please join us for that also. Thank you.